Great. Good morning, everybody. Welcome, day 3. I got to start my morning with a wonderful text from a graduate who had one of those once-in-a-lifetime, unbelievable save cases of a person who had just had her cath. Oh, you guys, the advancer? Is the advancer around? She'd had a cath, was on her way home she had clean coronaries, had a cath, was on her way home, had a syncopal episode in the car, didn't crash, thank goodness. Was found hypotensive and tachycardic, 60-year-old healthy woman, came into the ER, and a combination of 2 people working on the case found that she had tamponade from a ruptured coronary artery, got her intubated, got her lined, did a pericardiocentesis several times in a row to keep her pressure up, got her in a helicopter, flew her, and the woman just texted her a thank you. I swear to God, what you guys have the ability to do is really, truly unbelievable. Those are the cases that'll keep her fueled for a year of work. Those are the kind of cases that you really can, truly, honest to God, save a life. It is amazing what you have the ability to do. So I'm just still flabbergasted at what we do, and as a teacher, what the impact that we can all have in helping each other, and I don't know, it's just kind of crazy. I'm just feeling very, very overwhelmed at the moment about what we do. Okay, let's talk about adult chest disorder. Oh, by the way, I want to make an announcement. At the break, you're going to notice that I have a lecture before the break, and Ken has a lecture after the break. We're going to flip that, mainly because Ken has a flight issue, so we're going to basically flip that. So yes, Mr. Pink shirt in the back room, Ken is in the back. So just know that those 2 lectures will flip. If you have a specific reason you want to listen to one or the other of those will flip. So I think my dysrhythmia is after the break and his lectures before. Okay, so we're going to do part 1 of 2 lectures on adult chest disorders. So this one kind of is a mishmash of things that can happen in the adult chest, not the child's chest, the adult chest. And the second half, which is the last lecture I'll do for you this morning before the lunch break, is going to be talking mainly about PE, which is a huge sort of conundrum for all of us that hopefully I can help you not feel so overwhelmed by the idea of PE and give you an approach to that. So let's start with this, adult chest disorders. So we know that lung disease is very, very common. Fortunately, lung disease is decreasing in general because people just aren't smoking as much anymore, so we're seeing much less lung disease than we used to. We are definitely still see a lot of this. Pollution does it, asthma does it, we see lots of this. And we have a separate lecture completely on reactive airway stuff, COPD and asthma. It's going to focus kind of on broader concepts with the lungs, one of which is the chest x-ray. So in one of my former wannabe lives, I thought I wanted to be a radiologist. I would have gone insane in that dark room all the time with no people. But radiology is incredibly cool because what you have is this picture that if you know how to look at it, you can tell all kinds of stuff, not just make diagnoses, but tell all kinds of stuff about somebody's, whether they had rickets when they were kids or whether they have sickle cell disease, or you can look at all these just plain films and determine all this crazy, fabulous stuff. We order bajillions of chest x-rays, and it is one of the films that you have to become good at. Don't count on the radiologist, and you can, absolutely can. But there needs to be a system at looking at a chest x-ray. Like most things, we'll talk about it with EKGs as well, having a system so that you don't miss anything. And there are lots of different sort of ways to do this. There's different mnemonics for this sort of stuff, different books to do this. But the reality is you need to have a system to look at chest x-rays, because otherwise you'll miss something, because you may go to the what's obvious on the film. It's like, wow, look at that pneumothorax over there, and miss the thing that's not obvious on the film, which is the fact the patient has rib fractures on the other side. So make sure that you look at a complete film. So the system highlights, there are things to know about the x-ray itself. Back in the day where we actually took real x-rays without the digital stuff, the digital is awesome. It's amazing. It's amazing. Back in the day where we didn't, we would get terrible films. We would get films that are just awful. You can fiddle with films often on your sort of Pixis kind of, not your Pixis, the digital film that you have on your screen. But there are certain things that you just shouldn't even start reading a chest x-ray until you get the film right. So one of them is to see the quality of the film itself. And is it good penetration? And how do you know if it's good penetration? The way you know is you can adjust it on your screen, or it's taken appropriately, where what you can do is see the vertebral bodies through the heart. If you can see the vertebral bodies through the heart, that is enough penetration to get everything you need to see in the right amount of penetration. And why do I care? Well, you can do it now on your digital thing. Make it super dark, you lose everything. Make it super light, you lose everything. You need to have the right penetration of this thing. So know that you need to see the vertebral bodies through the heart. That's great penetration. You need to make sure the person is straight on. Now, the way to do that, we tend to look at like, oh, the heart looks like it's kind of displaced a little bit. The way to do that is to find two things in the body that are fixed, in that person that are fixed, and make sure that they are lined up in a way that the patient is straight on. And the things that are fixed in that individual's body are their clavicular heads and their spinous processes. Find the spinous processes, look at the clavicular heads, and see that they're equidistant. If they're not, the patient is rotated one way or the other. And you can tell by which is closer, which is further. Usually the one that is closer is the one that's closest to the screen, closest to the x-ray machine. It's rotated that direction. So that's the one that's closer is the way it's rotated. But the key is look at the film, look at the spinous processes, look at those clavicular heads, and make sure they're equidistant. That means the person is straight on. Now, I can see if the heart is really large or looks funny or whatever. I can see that. And the breath needs to be good. It really needs to be down to rib 9 or 10. And some people get way down there, which is great. Some people live way down there because they have COPD. So make sure that it's a good enough breath that you can see things in the lungs as real things if they're in the lungs. So always check quality of the film. Always, always, always. Before you make it just a habit to check the quality of the film. And then there's a bunch of things you're going to look at on that x-ray. The system I like to look at this is a mnemonic called Doctors ABCDE. I apologize for the doctors, but that's what fits. And the D is details. And I like that because especially with films that are on our pull-up digital screens these days, it's really easy to look at the wrong x-ray, right? It's really easy to pull up the last one that they had, not the one that's today. So make it a habit to make sure it's not just the right patient. So check the patient's information. It's, John Smith. Yes, it's John Smith. And then make sure it's today's date and maybe even this last x-ray. The one you may have had 3 today because the patient had procedures done and you got a follow-up x-ray. Make sure it's the right x-ray. It's really embarrassing to admit somebody for pneumonia that was the last time's pneumonia, not today's x-ray. So double check that and make sure. And then go ahead, and RIPE is the image quality mnemonic. That's kind of cool. Rotation, inspiration, what's the picture look like in the exposure? That's cool. And then the key is to look at all of the parts. And you can use this from outside in, whatever mnemonic you use, but make sure it is a reproducible system so that you don't miss looking at the bones. You don't miss looking at you may look at somebody an x-ray, it looks like, well, they look like they have something in their lung right there, and miss the fact that they have a mastectomy on the other side, and that thing in their lung may be a met. So look at all the parts of the x-ray. All the parts of the x-ray. And this is just one mnemonic that's a suggestion. Whatever you use is fine. Just have a system. Because there's lots of information on that film. Tons and tons of information. I love chest x-rays. You can find so much out on a chest x-ray. Not just things that are the lung and the heart. Nutrition things. Sickle cell disease shows up on chest x-rays, on their bones. There's all kinds of cool stuff that you can see on an x-ray. So get good at it. Chest x-rays in particular, get good at it. Plus you look like a rock star, and it's fun. Okay, let's talk about how your sort of pulmonary system works. A couple of basic sort of physiology things that I think are elucidating, especially for findings that we look at. So one of the things we look at is cyanosis, right? So one of the things when somebody comes in short of breath, we look at whether they're blue or not. People aren't supposed to be blue. But it's very interesting how you become blue. So we know that hemoglobin is what carries most of our oxygen. You have some of it dissolved in your blood, but you have these fabulous moieties, these hemoglobin moieties, 4 of which live together, and they bind a whole bunch of oxygen, and they carry it around your body and let it go at certain places. They release it at certain places. Really, really cool. 95% of my oxygen is carried that way, so very little of it is actually dissolved in the body. So once it's deoxygenated, that hemoglobin basically is now what would be causing cyanosis. It's deoxygenated blood, deoxygenated hemoglobin that causes cyanosis. Now most of your hemoglobin is oxygenated all the time, even post, sort of getting around your system. Most of your hemoglobin is oxygenated. Cyanosis is seen when a certain amount of hemoglobin is deoxygenated. Now, you aren't blue right now because the majority of your hemoglobin stays oxygenated all the time. Even once it's done its circuit, it stays oxygenated all the time. Cyanosis happens when 5 grams of your hemoglobin is deoxygenated. Now, this will help explain to you why blue bloaters look blue, but they have normal hemoglobins. And they actually often have plenty of oxygen in their system. So say you're a normal person, you're sitting there right now with 13 to 15 grams of hemoglobin in your body. That's what you have. you are just fine because you have more than 95, you have a lot of that still oxygenated. You don't have 5 grams of that deoxygenated. But let's say I'm a COPDer, or I live at altitude in the Andes, for instance, where I get polycythemic. I have 20 grams of hemoglobin at baseline because that's what I need to oxygenate myself. Or I'm a COPDer who gets polycythemic because I need it to oxygenate myself. If I desaturate 5 grams of that, I turn blue even though I may still have 15 grams that's still oxygenated. I'm still kind of okay at the end organs, but I look blue. That's one extreme. The other extreme of this is, let's say I have menorrhagia, and I've been bleeding vaginally during my menses for years, and I come in with a hemoglobin of 6. I will never turn blue before I die. I will die before I turn blue. If I have a hemoglobin of 6, and it takes 5 grams of that to get desaturated for me to turn blue, I will never turn blue before I die of hypoxia. So cyanosis is really just an indication of more than 5 grams of hemoglobin deoxygenated. It is always a warning sign. It should always worry you. But don't expect people who are hypoxic to get cyanotic regularly. They don't. They only do if they have enough hemoglobin to get deoxygenated to make them sick, to make them look blue. So I think that's important because we kind of have a little misconception on cyanosis. Always pay attention to it. Always, always, always. But we know not to expect it in even profoundly hypoxic patients. Now, when we deal with respiratory stuff in people, pulmonary basics, we talked about this in the vital sign lecture. You're not going to just look at their respiratory rate. You are going to watch the tidal volume. You are going to look at their respiratory effort. You're going to watch their ventilation. It really is incredibly helpful. Absolutely helpful. And what drives your breathing right now is basically your CO2 level. It's not your O2 level, it's your CO2 level that drives your breathing. And if you want to do an experiment on this, you can do this in the privacy of your seat right there quietly, or you can do this up in your room if you want. But if you want to do an experiment about the fact that CO2 drives your respiratory rate, I want you to breathe yourself down on purpose right now. Do it quietly. You can take a whole bunch of nice deep breaths, keep blowing off your CO2, nice deep breaths, get all that CO2 out of you, and then stop breathing, and wait until you get the urge to breathe again. You are going to be flabbergasted how long it takes before you feel like you need to breathe again. Because you have to build up that CO2 again to basically turn your brain on to say, I need to breathe. You can do this experiment anytime you want to. It's a great example of the CO2 drive for healthy lungs. Unhealthy lungs, though, so people have really basic, they're hypoxic all the time. It is a hypoxic drive for them more so, but just know, CO2 is what drives your respiratory effort. It's also the reason that people who retain CO2 stop breathing. Okay, they get acidotic too. That we talked about the pH thing, but basically your brain says, well, God, I don't need to breathe. This is fine. People, they get sleepy. So the people who retain CO2, if they are hypoxic drive people, they can go to sleep. They don't have that drive anymore. So most of us, though, have a CO2 drive. So know that. This is absolutely key. Know that. And do the experiment yourself. You can figure this out yourself. Kids do. It's the reason, by the way, kids can drown if they hyperventilate and then go underwater. If they hyperventilate a lot and go underwater, they will become hypoxic before they get the urge to breathe, or can become hypoxic and pass out underwater before they get the urge to breathe again. So don't have your kids do that respiratory thing, breathe and then go underwater. Not a great idea. So blood gases. Venous blood gases are absolutely 100% fine for 99.9% of what we need. You really don't need to stick a needle in an artery. If you need the pH, the venous blood gas is absolutely a fine pH. And let me give you the logic behind that. You don't suddenly become super acidotic on the sort of post-oxygen delivery side of your body, on the right side of your sort of perfusion system. Your pH doesn't suddenly drop to major acid. It doesn't. Your normal pH on either side of your body ranges a maximum of about 0.2. So you go from basically a pH of 7 to pH of 7, 7.01 or 7.02. Your pH has very little range in a normal, living, healthy body. Very little range. So your venous pH is fine to use as a pH measurement. Your PO2, you can look at a pulse ox on somebody for a PO2. You don't need a blood gas for that. And the venous blood gas, of course, the O2 is less because you've withdrawn some of the oxygen from your blood on the circuit. That's fine, but I can look at my pulse ox. That's all I need for that. And the capnography is a little bit up on the venous side, but not enough to make a clinical difference. Venous blood gases are absolutely fine. Pulse ox on the monitor, venous blood gas for pH, absolutely fine. PCO2 can be on the blood gas, or it can be actually on capnography of that as well. So you don't need to do arterial blood gases virtually ever anymore. Now, respiratory failure is two versions. One is hypoxic, I don't have enough oxygen in my system. The other is hypercarbic, I have too much CO2 in my system. Most respiratory failure is a little bit of a combination of both. You can have purely one or the other. Most is a combination of them both. So we manage hypoxic respiratory failure. We saw this with COVID. You all got super good at this with COVID, because most people with COVID had hypoxic respiratory failure. They had PO2s of, O2 sats of 60% and sitting there chatting with you. We fix that with either non-invasive ventilation, high flow oxygen, or intubation. Of course, oxygen delivery first, but the more invasive stuff. Non-invasive ventilation, high flow oxygen, or intubation. People have hypercarbic respiratory failure. We fix that with non-invasive ventilation or intubation. High flow doesn't fix pure hypercarbic respiratory failure. It's just an oxygen delivery system. It doesn't help ventilation. So just keep that in mind. Non-invasive ventilation and high flow, you've all become experts at. COVID took people who had hardly ever used it and made all of us experts in using non-invasive ventilation and high flow. Just remember again, high flow is pure hypoxic respiratory failure. Non-invasive ventilation can be used for either kind of respiratory failure. And if you are using non-invasive ventilation, one of the things I find people get confused about is, how do I adjust it? I kind of know which numbers to start with. I'll start with 8/3 or 10/5. I'm kind of comfortable with starting with those numbers, or just a CPAP of 5 or a CPAP of 8. I'm fine with that, but how do I adjust it if people aren't getting better? The rule of thumb is, if they stay hypoxic once you've started them on non-invasive respiratory stuff, you increase both the IPAP and the EPAP, the inspiratory and expiratory pressure support. You increase both. If they are still hypercapnic, they have too much CO2, you increase the IPAP only, leave the EPAP alone. Increase the IPAP only, leave the EPAP alone. And know that, again, high-flow nasal cannula is only for oxygen delivery, not to help ventilation. So those are sort of the basics. And we have a little deeper talk on this later that will come up as well, but that's the basics. All right, let's talk about pneumonia. Super, super common. Osler called pneumonia the old man's friend, because it was a common means of death. It was just a common exodus for people as they got older or got sick, was to get pneumonia. And we've all seen a ton of pneumonia in the last 3 years. You've seen a ton of COVID pneumonia, but frankly, there's a whole lot of pneumonia still out there. We're seeing pneumonia like crazy in our ERs even now. So part of this is to know the approach to pneumonia. Like, how do we approach pneummonia? If we know it can be viral, we know it can be fungal, we know it's bacterial frequently. How do we approach pneumonia? Well, the first thing is the X-ray. Or imaging, not just necessarily X-ray. Who needs imaging for pneumonia? And there are guidelines out there that, frankly, I honestly think are stupid. The guidelines that are out there mainly were meant to take studies and make them comparable to one another. So if you see someone who says, a study that says patients with temperatures of, let's see what they had in here, 100 degrees Fahrenheit and heart rates over 100 and a respiratory rate greater than 20 all got chest x-rays. Great. That was the entry criteria, the inclusion criteria into that study to make sure everybody in that study was kind of the same to start, to be able to then make any kind of conclusions from that study. You at a bedside can make a clinical decision if you think somebody needs a chest x-ray. And frankly, you're not breaking any laws if you order a chest x-ray that doesn't meet whatever kinds of criteria. If your spidey sense says, I need an x-ray here, for whatever reason I decide I need an x-ray, go ahead and get the x-ray. Again, you now are experts in how to interpret them. You have your system in how to interpret them. Get the x-ray. And absolutely, people who have decreased breath sounds need it. People who have crackles need a chest x-ray. People who have no asthma but they're feeling short of breath consider a chest. Even if you're thinking it might be a PE, you might want to consider a chest x-ray, because you might find something on the x-ray that explains their symptoms that you're good to go. We'll talk about that in the second half of this talk. The reality is there is no magic in ordering a chest x-ray. You don't break any laws for ordering a chest x-ray. Order it if you think you need the chest x-ray. The key is to be able to interpret it. What you're going to look for are infiltrates. And you're going to look for infiltrates that are low. And not just, yes, they have them. You're going to describe them. Are they lobar? Do they sit on a fissure? Are they infiltrative? Are they patchy? Are there holes in them? Do they have cavities in them? Is there fluid involved with this stuff? You're going to look for you're going to be a sophisticated X-ray interpreter in this, because it's going to help guide you on what you decide to do with somebody. So how does this stuff look? And I'm going to give you some caveats to that, because it's not 100%, but it does help kind of guide you. And every positive chest X-ray isn't COVID. I mean, I think that's the first thing on everybody's minds right now, because everybody's seen so many abnormal x-rays with COVID, but there are a lot of things that cause abnormal x-rays. So bilateral interstitial infiltrates, which is what we saw a lot with COVID, you see with a lot of other things as well. Before COVID, we saw this with a lot of stuff. It was mainly the viral sort of atypical pneumonias, the chlamydias, the viral, the mycoplasmas, but I will tell you, it is not always. There is no magic to this chest x-ray being absolutely either chlamydia or absolutely an atypical pneumonia, mycoplasma. You can have bacterial pneumonias that cause this too. It's just less common. So this is one of the things you look at. It's like, this looks kind of viral to me. This looks, and put it in the context of the patient, right? You're a smart person. If this is an 88-year-old who's living in a nursing home, I'm going to wait a second, hang on a second. Usually it's somebody a little bit younger who's out and about that's getting these atypical pneumonias, not a nursing home person. So let me think about this again. So patchy infiltrates, the bilateral patchy infiltrates on this one. Lobar infiltrates. Now the thing I love about lobar infiltrates is that if it's truly a socked-in lobe of the lung, you can tell which lobe is involved as a sophisticated chest x-ray interpreter. For instance, on that right lower x-ray, on this picture, that x-ray, there's an infiltrate on the right side of that patient. Can you tell, just by looking at that film, if it's right lower lobe or right middle lobe? Kind of a trick question. The answer is absolutely yes, you can. Right middle lobe infiltrates will haze out the right heart border, called a silhouette sign, because the right middle lobe abuts the right heart border. So if I have a right middle lobe infiltrate, I'm going to lose my right heart border and have an infiltrate that looks kind of like that. I'm going to listen, I'm going to go back, if I haven't done it already, I'm going to go back and listen, not in the back, I'm going to go listen in the front, because that's the only place you hear your right middle lobe. That's the only place it abuts the chest wall. You are now a sophisticated diagnostician. Same thing on the left. The left lingula is a lot like the right middle lobe. It blurs out the left heart border. I'm going to go back and listen in the front. There are some parts of the lung you don't hear in the back. You don't hear in the sides. You hear it in the front. So a good lung exam, if you have somebody with a pulmonary complaint, is I go 3 places on each side in the back, I go both sides on the sides, and I go in the front. Because that's the only place I know I can hear a right middle lobe or a left lingular infiltrate. So you can walk away from a bedside and guess. It's like I hear crackles on the right and the front of this person. I'm going to look at the x-ray and I'm going to guess that this x-ray is going to have an infiltrate that's going to haze out that right heart border. And you will be right. You will be right because your clinical judgment and what happens on the x-ray matches. That right, the one that's on the left on this film should scare the bejesus out of you. The good news is that we are all masking all the time now because you are now standing in a room with somebody who probably has active pulmonary tuberculosis. If you have cavitary lesions, particularly in the upper lobes, that tends to be tuberculosis. Where I work, that is almost 100% tuberculosis. We see this in certain populations more than others, particularly the incarcerated, people in group environments, people who are HIV positive, people on the streets. But immigrants, we see this as well. So maybe the person you're standing next to in the grocery store is coughing, red snappers on you, coughing tuberculosis on you. This is the cavitary lesions that you see with tuberculosis. You also see cavitary lesions with certain fungal diseases. You definitely see it with some certain aspiration pneumonias. Just know that you can see abscesses in the lungs, but this is the kind of thing you see with TB, and that should scare. That's one of those things that's like, okay, this is like droplet. This is droplet isolation for everybody. This person has TB, we'll keep them isolated so that they don't give it to somebody else. So this is how, again, being a sophisticated chest x-ray interpreter, putting the clinical picture together, you can figure out what's wrong with somebody. So people with pneumonia tend to present with what you'd expect. They have a cough, they may have a fever, they may have findings that are consistent, they are tachypnic, they may have chills, the stuff you would expect. That's absolutely fine. The people who break those rules are the immunocompromised and the elderly. Older people may come in just with altered mental status and have a raging pneumonia. They may not have a fever, they may not have a cough. So this is where you'd go do your searching in that altered mental status older person, look for check that chest x-ray, see if they have pneumonia. And to clinch it, to say, yes, indeed, you have pneumonia, it really does rely on an abnormal chest imaging something. So chest x-rays were the be-all and end-all when that's all we had. And there were cases of patients who were basically x-ray negative, chest x-ray negative pneumonias that bloomed the next day. The next day it was like, oh, well, there it is. That was, they were here yesterday sounding like pneumonia. Now tomorrow they have it. That chest x-ray turns out to be a relatively rough tool, not a very sophisticated tool. What is best, frankly, is ultrasound. Ultrasound in the right hands is a really great way to diagnose pneumonia. CT is definitely, but that's kind of overkill. You don't really need to do that. So chest X-ray is fine. It may miss a few. Ultrasound is great in the right hands, so it diagnoses it accurately, doesn't call failure pneumonia, because it can look a little similar, but ultrasound is great. CT scan, you don't need to get for pneumonia. If you're getting a CT scan for something else, like a lot of us did when we were diagnosing COVID early on, trauma patients would come in, they'd get a CT scan for their trauma, the CT would show the infiltrate, we would go back and find out they were COVID positive. So your CT scan is often an incidental finding, not something you're ordering on up front. So chest X-ray is fine, it has just a few false negatives for sure. You don't need to order labs in most young, healthy people with pneumonia. You've made your clinical diagnosis, you've gotten the chest X-ray, you have the diagnosis, you're good to go, fine. You only order extra labs if there's a clinical indication to do so. So admitting somebody with lots of medical problems that are you're worried about, you have to evaluate, or somebody who's admitted who might go to the ICU, that's blood cultures as well. Those are people that need labs. But in general, if you're in an urgent care fast track, walking, talking person, they look great, otherwise they're fine, don't need to do it. Treating pneumonia, and again, now this is, COVID is, by the way, I just want to step back. Viral testing right now in people that have pneumonia is probably worthwhile on the acute setting. Mainly for public health and infection control. Influenza A right now is insane in the United States. Every state is now deep purple. We have so much influenza. And COVID is still around. So it is probably worth doing basically rapid viral testing in folks, just mainly for public health purposes, and to know that certain patients are at higher risk for deteriorating, like the elderly and the young. So just be aware of that as well. Now, treatment, especially if this is I think this is bacterial. This is somebody who's pretty sick. I think it's bacterial, not viral. The initial treatment depends on several pieces of information. Have they been hospitalized recently? So that makes a difference because they will have different bugs they've been exposed to. Have they been recently on antibiotics? That will make a difference because they may actually have some resistance now to certain bugs because they've been on antibiotics. Have they traveled? Have they been anywhere where that might be something that's not your run-of-the-mill kind of pneumonia? Your hospital's antibiogram. What is your resistance pattern in your hospital? Because it will alter what may be a national guideline into a national recommendation into something that your individual hospital treats a little differently because you have a high resistance where you are to certain antibiotics. And those guidelines are important. They get altered based on what is population data. It helps keep us from willy-nilly prescribing whatever we want to anywhere and then totally messing up resistance patterns. So it really is useful to try to kind of stick to what's recommended so that when things shift in mass, we all shift in mass together. Your first decision with pneumonia patients is to decide am I keeping them in the hospital or am I sending them home? That's your first decision. And you can make that decision clinically if you want to. It's probably useful to add something like the CURB 65 score or the Pneumonia Severity Index. These are all in your MD Calc, so you're going to pull out your MD Calc, and you can basically say, patient has a good socioeconomic status, has support system and a primary care doctor, their Pneumonia Severity Index is low, safe to discharge home, will discharge with the following antibiotics. Done, easy. Put it in your chart, super easy to do. None of these are easy, don't try to memorize them, don't waste brain space. That's what these apps are for. Once you've decided in or out, and if it's is it in ICU, now you have a kind of a rubric to go to what kind of antibiotics you need, because here's your severity index, by the way. If somebody's going home as an outpatient, when they've done studies on those folks and looked at what bugs they have, this is the list. And the reason they chose certain antibiotics for outpatients is because these are the bugs they're covering. If you admit somebody, but they're not super sick, they just need to be in the hospital, it's a different set of bugs. So the antibiotic choices attack those sets of bugs. And if they're super sick and they need to be in the ICU, the antibiotic choices in these guidelines basically are focusing on what bugs have been cultured out of those folks. So there is logic behind the guidelines. And the community-acquired pneumonia guidelines are here. I'm not going to walk you through each one. You can read just fine. Just know that this is sort of the standard. It makes very good sense to do this. Steroids are not indicated as an addition, so they don't get added. But these are the antibiotic choices for you. And again, find out your own institution's antibiogram to know if there's anything different at your place based on, from these guidelines that are from 2019. These are actually from right before the pandemic, or right during the pandemic. There's a few tables here that are kind of fun, interesting facts about specific pneumonias. These actually kind of help. I'll tell you the bottom one here, Legionella. There was an outbreak of a suspicious pneumonia in Argentina just this last year that scared everybody because it killed half the people who got it. It was 11 people got this outbreak of pneumonia, and there was this big worry, is this the new latest awful thing that's going to go out and now kill half of people, which turned out to be Legionella. We'll probably see more and more Legionella going forward with climate change because it's air conditioning based. So this is as people are staying inside with super hot outside, it's air conditioning based. Just keep in mind Legionella, it's liver stuff as well, tends to be older men, but not always. So that's kind of an interesting one to keep track of. The rest of these are for your interest. The last two things I want to mention in our last minute and a half together, one is spontaneous pneumothorax. These are so fun. This is the tall, skinny person with sudden onset, kind of sharp chest pain. X-ray or ultrasound shows a pneumothorax. It's so fun. It's like, woohoo! It's like getting an SVT case or a shoulder dislocation. It kind of makes your day. Several ways to approach this thing. You basically have a pneumonia. Ultrasound's the most sensitive thing. You can treat this with a pigtail. You can treat this with a dart. And basically, you can aspirate these things. There's no actually magic right way to treat these things. There's lots of options in treating these things. Often they will end up in an OBS unit just to let that thing come up and stay up for long enough. You can send them home sometimes. There's lots of nuances to this, probably more detail than we can talk about here. We can on the panel if you want. But these things are really fun to treat. Just don't put in a big chest tube. You don't need it. Okay, you don't need it. It's air, spontaneous air. And the last thing I want to mention is hemoptysis. So hemoptysis is pretty common, and most of the reasons that people get hemoptysis are bronchitis. Cough, 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 cough. That is 50% of hemoptysis. It's not a scary cause of hemoptysis, but I will tell you, if it's somebody who's HIV positive, who's living on the streets with some weight loss, who comes in with a cough with some hemoptysis, I'm worried about tuberculosis. If it's a cancer patient who comes in with hemoptysis, I'm worried about that thing eroding into a vessel. So hemoptysis comes in sort of minor and major. Massive hemoptysis has numbers attached to it, but frankly, anytime somebody comes in with a photograph of here's a bunch of what I coughed up at home, make sure it's they coughed up, that worries me, because massive hemoptysis is a terrible way to die. If somebody has they start coughing and it is a gusher, what you need to do is try to figure out what side it's coming from. So say it's a cancer on the left lung. I am going to put that person on the left side down, let that bleeding end up in there. I'm going to try to intubate them in the right main stem if I can, oxygenate and ventilate through the best lung, the good lung here, and I'm going to call in all the troops. I'm going to see if I can get IR involved. I'm going to try to get pulmonary involved. I'm going to talk to cardiothoracic surgery. I'm going to try to because this is a terrible, terrible thing. Get your blood transfusion protocol ready, but you drown before you die of exsanguination in this sort of thing. So your key is to try to manage. These are awful. You won't have many of these in your career, hopefully none. These are pretty awful things, though. So just keep your head together, bad side down. Try to, if you can, oxygenate and ventilate that other side and get all the troops involved. All right, I am done. It's time, I think, for Ken. All right, thanks, you guys. I'll be back in a little while.
I was just reviewing the levels of evidence for mastitis we did a podcast yesterday on, is it called the ABA? ABM. American Breast Association. The Academy. Breastfeeding Medicine, and they've made some recommendation changes, and we were discussing them last night, and I just wondered what the quality of the evidence was, or the grade of the evidence, and would you say that most of it was level C, and there was a few maybe level B, but no level A recommendations? Anyways, that's what I was doing, always learning. All right, so welcome, ankle and foot. So we worked our way up the body yesterday, and now I'm going right back to the bottom, down to the ankle and foot. And we're going to go through some of the abnormalities, some of the injury patterns, some of the things to look for when you're examining someone who comes in with a complaint in the foot or ankle. So with regards to the anatomy, we went through some details on the hand and wrist yesterday. Really, really important to get really good at knowing the anatomy of the hand. The foot, not so much, right? It's just doesn't have the same prestige, maybe, as the hand, same risks as the hand, and so basic anatomy stuff. The lateral ankle is where most of the injury patterns are that you'll see. Who here hasn't gone over on their ankle? Who here hasn't had an inversion of their ankle? Who last night didn't invert their ankle, right? So it's a very common injury. There's 5 ligaments there that's holding that fibular head against the lateral aspect of the ankle. Now, usually it's the anterior ligament that pops right? People will say, I felt my ankle pop. Sometimes it's the one that goes from the fibula, another coffee please, from the fibula down to the calcaneus. And sometimes if it's a really bad sprain, you really rolled that ankle and came all around on it, you'll get the posterior ligament as well. But those are the ones. All right, so plain films, plain images, 3 views, right? You've got your lateral, so you look at the side. You've got your straight on, and then they've got that mortise view that's slightly turned so you can see the joint all the way around the ankle, and you want to see that it's equal all the way around. So those are the 3 views you'll get when you order an ankle x-ray. Now, there is one thing that I want you to avoid diagnosing, and that's the os trigonum. That is referred to as the os misdiagnosum. You do not want to have that egg on your face when you go, oh, look, there's a fracture back there. Now, they don't have a positive arrow sign. They have a circle sign around that. And it's a nice, smooth, round, normal finding in about 10% of people. And so looking around this room, there might be 30 of you if we x-rayed your ankle, and we would find this os misdiagnosum or os trigonum. It's a normal variant. Don't be fooled. And there's more. Oh, yes. There are more to fool you in the ankle. So you have lots of these little round areas of calcification, nice and smooth. If it doesn't hurt there, it's probably not a broken bone. And I keep a picture of this in my phone as well for when I'm looking up x-rays and I see one of these and I go, oh, is this one of the ones I'm not supposed to misdiagnose as a fracture? Because they can catch you by surprise because they came in with a foot or ankle issue and you take the picture and you see something. Clinical correlation, push there, but also check to see if you might be misdiagnosing a normal variant. So when it comes to ankle sprains, these are super common. I don't need to tell you. Inversion is way more common than eversion, and it's those lateral ligaments, the anterior talofibular ligament, and like I said, the calcaneal one can go if it's more severe, and then you can go all the way around on that ankle and pop the posterior. Now, when you're deciding whether or not to get ankle x-rays, Ottawa ankle rules. This is the most validated clinical decision instrument in medicine. This has been derived and validated and tested so many times to be extremely accurate for safely ruling out whether or not this person needs an x-ray to diagnose a fracture that's clinically important. I don't like calling them clinical decision rules because I think rules tempt me to break them. I like clinical decision instruments when it comes to these types of things. One thing, though, this has been validated in children as well. So you go, oh, well, you know, it's an adult, so it works for them, but it doesn't work for children. Validated down to the age of 5. 5. All right, and then when sprained, it has a mnemonic there called Pricer. I don't think that that's highly evidence-based. I mean, sure, protect it. Okay, I can get on board with that. I can get on with the R, rest it. I don't know if elevation is that important. Icing, I'm not sure. We have great evidence that ice changes a clinically important outcome. If icing it makes it feel better, great, but I don't want to, drill down and say, thou shalt ice, and it'll be 10 minutes on, 10 minutes off, no, it's 12 minutes on, 12 minutes on, no, it's 15 minutes, If ice makes it feel better, fine. Putting that tensor bandage around it, does it provide structural integrity? No, but it certainly reminds patients, hey, I injured my ankle. I should be behaving. So I call that proprioceptive therapy. Something's wrapped around my ankle, and I need to be taking it easy. It's injured. But I don't know if there's something magical about it. Could it just be an elastic band or something? So here are the Ottawa ankle rules. There's 5 things. 5 things in the Ottawa ankle rule. I can remember things that only have 5 parts to it, but you can get out your MD Calc and look this up. The first thing is, can they step on this, weight bear on this immediately after the injury or in the department? And then you have the posterior aspect of both the medial and lateral malleoli to see if they're tender. Now, everybody is going to be, if they roll their ankle and it's an inversion injury, almost everybody's going to be tender in that anterior aspect in the front, right? It's big and swollen and stuff. It's the posterior aspect. They put down 6 centimeters, that's about 2 inches. Posterior aspect, both medial and lateral, those are the two. And then the navicular bone, so pain over the navicular or midfoot, and then pain over the head of the 5th metatarsal. So you put your thumb and index finger and squeeze on the head of the 5th on the foot. You put your fingers on the midfoot, you check the back of the medial and lateral malleoli, and you ask them if they could walk in the department or immediately after injury. If any one of those is positive, x-ray. Is this a hill I'm going to die on? No. Deltoid ligament. All right, so the lateral aspect, they've got these thin little ligaments. There's 5 of them holding it on there, and you can pop them, right, pretty easily. Not so much with the deltoid ligament. The deltoid ligament is this thick ligament that is in the shape of a triangle, a deltoid, right? It's a delta sign. It's very thick, and it's harder to pop that one. So it's much less common to do an inversion of your ankle, going over on it like that. Takes much more force. It rarely tears completely because it's one big ligament as opposed to a thin string ligament. But you've got to look for fractures on the medial malleoli. If you go over on your ankle like that, if you go over and have enough force to tear that deltoid ligament, you could fracture the medial component, the medial malleolus. So for non-pediatric fractures, so adults here where growth plates are closed, common injury to roll your ankle and break it. Now, often we'll hear people say they heard a pop, and that's why they think it's broken. The vast majority of them are not broken, but you get the x-ray if they're Ottawa positive, okay? Now, this is one of those cases where you say, examine the joint above and below. And does that mean you're doing a thorough examination of the knee if somebody comes in with an ankle injury? Am I doing a Lockman? Am I going an anterior and posterior? No. I'm going, does your knee hurt? No. Okay. Then I put my hand on their knee. Is it swollen? No. And then I put my hand on the head of the head of the fibula up here because I'm looking for a Maisonneuve fracture, especially if they've got a medial fracture, medial malleoli fracture, if the force came out their knee up here. And they may be so concerned about their ankle that they don't mention, yeah, my knee's kind of sore too. So when you see that ankle, just say, hey, how's your knee? History, appropriate history, directed physical exam. Sore? No. Swollen? No. It's tender here? No. Okay. But if it is, x-ray the knee. All right, so what do you do with these ankle fractures, distal fibular fractures? You usually just put them in a back slab or some kind of a mobilization boot and refer them to orthopedic surgery. And here's the Maisonneuve fracture. Okay, so you can see that, if you do an inversion of your ankle, you can get a fracture up the head of the fibula. And so you've got to be careful for that. There's also a nice little nerve that runs along there, the common perineal nerve, that is responsible for dorsiflexing your foot. So dorsiflexing your foot, and it gives sensation to the lateral aspect of your leg and down to the 5th digit or the little toe. The reason I know that is because when I had my surgery on this ACL, the surgeon mistakenly or accidentally or a complication of surgery cut my common perineal nerve, and so I had foot drop. Now, of course, being, having lots of swelling and it was fixed acutely and stuff, they thought that maybe this numbness and this lack of being able to dorsiflex my foot was just due to the compression of the nerve, and that was reasonable. But I kept saying, no, I can't dorsiflex my foot. I can't dorsiflex my foot. It's all numb here. And so, yeah, okay. So I'm telling you this story because this is the second time in my life that I fainted. And so they sent me for EMG testing. And so they hook you up to the machine with EMG testing, if anybody's had that done, and they put the electrical probes in, and they fire some current across, and I'm like, yeah, I'm dead on the inside. I got nothing. I feel nothing. Nothing's happening. Nothing's moving. Oh, well, let's check on the other side for an internal control. But they had turned it all the way up to 11, okay, 10, but they turned it all the way up to the maximum on this side, right? This one goes to 11. Thank you for all the Spinal Tap fans. But they turned it up, and then they didn't turn it down. And so they did it on the opposite leg, and it was like, thunk. Yeah, I felt that. Next thing I know, I'm looking up, and I'm getting a cold washcloth and some ginger ale. Yeah, so anyways, really important nerve that runs along there. I got my motor back, but I didn't get all my sensory back. Okay, so children's fractures, if they have growth plates, there's this Salter-Harris classification of growth plate injuries. And they go from 1, which is the mildest, to 5, which is the most devastating or worst. So 1 through 5. 1 is the mildest, 5 is the worst. There are many of you, I'm sure, who had parents who did not bring you in when you hurt yourself, and you probably had a Salter 1 fracture. Did you have parents like that? I had parents like that. Walk it off, Kenny. Suck it up, Buttercup. Right? Come on, right? And so, I'm sure, and it heals fine, right? There's no casting involved. So the parent, appropriate pain control, but you'll be fine. A Salter 1 fracture, you may not be able to see it on the x-ray. You've probably seen x-ray reports that say, could be, or suggestive of a Salter 1 fracture. That's just through the growth plate. And because there's not calcification in there, you can't see the fracture, right? They've got this nice lucent line through there. Now, a Salter 2 goes through the growth plate, so there's a growth plate fracture, but it comes up, comes proximal, not distal. It doesn't go into the joint. That's a 2. Not that bad. A 3, though, goes through the growth plate, but into the joint, and that's the problem. If it goes into the joint, you can lead to premature arthritis if there's that hairline crack that's going to rub, or if there's any displacement there. That causes damage to the articular surface. So that's why a 3 is worse than a 2. And then a 4 is very unstable. It goes all the way from the diaphysis down through the growth plate into the joint. So that's grossly unstable, and that's probably going to cause some arthritis if it's not appropriately managed. And then the reason 5 is the worst is that you have a crush injury. So the growth plate is crushed. It is a growth plate. That is where you grow from. Now you're not growing there. That's why that's the worst. So I hope that explains the Salter-Harris classification for 5 things. 5 things. All right, so let's talk about the 5th metatarsal fracture. It's very common. So you see this with severe ankles, right? Severe sprains of the ankle. They rolled their ankle really bad. Ask about the joint below. Does it hurt in the head of the 5th metatarsal? That's why that's in the Ottawa ankle rules. It's not about an ankle fracture. It's about a foot fracture. And you can fracture the head of the 5th metatarsal. One type of fracture of the 5th metatarsal is called a dancer's fracture. So dancers go up on their toes. Believe me, here we go. This is a live demonstration. There, I'm up on my toes. You can see how you could easily roll your ankle and then pull off the end of your 5th metatarsal. It's called a dancer's fracture. The key about this is they don't need to be casted necessarily. A good, firm shoe, right? You could use an air cast, I guess, but they don't necessarily need to be casted. These heal very, very well by and large. And I know what you're thinking, but wait a minute, I thought some of these things went on to non-union. Oh, you're thinking of Jones. Not the dancer, the Jones fracture. And that's down into the diaphysis of the foot. So that's past the joint line, where that little avulsion or the dancer's fracture pulled off from rolling your ankle so much. This is down into the bone, down into the diaphysis, and that's part of the structure of the foot, and all that weight can cause that to be either a delayed union, non-union, malunion, and these sometimes need to have some kind of surgical open reduction internal fixation to hold that or put that together. These people are not weight-bearing. These people are on crutches. These people are immobilized, referred to orthopedic surgery. A Jones fracture versus a dancer's fracture. And then, of course, you have the epiphysis here at the end where, you have this little center on the end of your fifth metatarsal. And this is a common variant. This is a normal variant. Some of you out there may have this if we x-rayed your foot and you're fine. You don't have any pain and you've gone through your whole life functioning without knowing this. And so if you see that little area of calcification off the tip, like it was like a little piece of bone pulled off, check to see if it's nice and smooth and round. And what's a really good indication that it's not a fracture is you take your finger and you push on it. And if you push on that area and it doesn't hurt, clinically correlated, it's not broken. That's just a normal variant, okay? The radiologist will call this, or you'll call it as a fracture, and they'll say, no, this is just a normal variant. Metatarsal stress fractures, these are also called March fractures. You see this with people wearing very, very stiff boots and doing a lot of activity on their feet. So it was called a March fracture because of the military, and they were doing a lot of parading, and they would get these stress fractures, usually in the second or third metatarsal. You don't see them usually on plain film acutely. The patient will come in and it'll be sore, it'll be tender there, but in a week or two, you'll see the calcification and healing of that fracture. That's how you know that it was that. A CT or MRI can help, but not necessarily in a ER situation. And what do? You put on a good supportive shoe and you limit their activity. If it hurts when they do that, don't do that for a while. And some analgesia. A Liz Frank fracture, though, is much more severe. This is a much more devastating or potential devastating injury. It's in between the big toe and the second digit, and you get splaying, and that's where you get your Liz Frank fracture. It's usually, the typical thing is I was on my motorcycle and I put my foot down and it got caught and it jammed and it caused my foot to pull apart. These are bad fractures. They can be missed too. It can be with or without a dislocation, but the patient will usually not be able to weight bear. It'll be like, like it is really sore if you have a Liz Frank fracture. If you're concerned and the plain films don't show it, you can ask them to do weight-bearing films because that'll put their weight on it and push that apart, and then you go, oh, there it is, yep, they've got a Liz Frank fracture. Serious injuries, get a consult, immobilize. This does have the positive arrow sign, so if I didn't have another x-ray up there, you're kind of looking at it and going, that looks a little wide, doesn't it? It looks a little wide. Now, I don't have a comparison one, but with that arrow, something is wrong. And so you go, yeah, that's where the Liz Frank fracture is. Between the first and second cuneiform, it splits open. And that's really important to the structural aspect of the foot. Calcaneal fractures, okay, so fractures of your heel. Plain x-rays can be misleading. Yes, I have missed at least one of these in my career because it's not as obvious as you think. Now, these are people that are falling off roofs, falling from a height. Usually in my area, it's falling off a barn. I have a theory. It's more of a hypothesis, actually. But whatever decade of life you are in, that is the stepladder you go up to put up your Christmas lights. So if you're 80, you've got an 8-foot ladder. And you're up there doing it, falling. If you're 100, you're on, like the 30-year-olds are on a 3-foot step ladder, right? But the older you are in decades of life, the higher the step ladder you feel comfortable going on and falling from. It's just a hypothesis. I have not done any testing on that. But coming down, that's a lot of force, and you can crack your calcaneus. Now, it's obvious when they come in and they've got this big, huge heel, right? The calcaneus is huge, but sometimes it's not. It's just they've got a sore foot on the plantar aspect of their calcaneus. Now, there's something called the Bowler's angle. I've never actually got out and measured the Bowler's angle, but if it's less than 20 degrees, it's highly suspected that they have a calcaneal fracture. It's more like clinical gestalt going, yeah, that doesn't look right. The heel looks like it's jammed up. It's jammed up there. You can get something called a Harris view, and you'll look good with your text if you go, listen, I'm suspecting a calcaneal fracture. Before we go ahead and get a CT, I was wondering if you could throw in a Harris view. Say it like that. Oh, Yeah, see how it goes. Anyways, the Harris view is shot from behind at a 45-degree angle, and it's got a couple of positive arrow signs there to show where the fracture and the joints are. But if I go back here, just at the bottom, if you're landing, right? If you've done an axial load, and they love it, I have to stay in the box. I am in the box still, guys. Ready? And I jumped. They don't like it when I move outside the box. But if you have an axial load on your calcaneus, enough to break it, how's their tibial plateau? Do they have hip pain? How about their spine? Is there any spine pain? Because you could get a burst fracture. You could get a compression fracture. But maybe they're most concerned about their heel, so they're like, oh, my foot. But my back hurts, but I fell off a ladder. I'm expecting that. They could have a compression fracture. So think, if they have enough force to break the calcaneus, think about that axis, that axial load of their spine, their hip, their knee. And there's that view. Toe fractures, not such a big deal, common, painful. I'm sure almost everyone here has kicked something, kicked a door, kicked a coffee table, and broken a toe, and plus or minus got an x-ray. Sometimes, who cares? What are we going to do? We're going to buddy tape most of them, right? We're going to buddy tape most of them. There's a concern that if it's an open fracture, maybe antibiotics, right? With an open fracture there, especially in the foot, it's a bit dirtier than trying to keep your hand clean and stuff like that. If it's angulated or rotated, have a discussion with your orthopedic surgeon. Plantar fasciitis, we don't see a lot of this in the emergency department. I don't, where I work. Don't see a lot of plantar fasciitis, but it can be quite debilitating, and it's severe pain, anywhere from the heel spur area forward along the arch, and it's difficult to treat. It involves various shoes and orthotics, NSAIDs, those types of things, sometimes even steroid injections. I think that would be a very painful place to put a needle. Achilles tendon rupture. Oh, this is spaced repetition. Remember this from yesterday? So an Achilles tendon rupture, you're thinking, oh, could it be fluoroquinolones? When did you get treated for a UTI with ciprofloxacin or something like that? Or maybe a respiratory infection with moxifloxacin. But it can weaken tendons, and the Achilles tendon is the classic one to go. It's not that common. It would be in the rare category. Sometimes you can't feel the gap, but if you get out the ultrasound, you can see the gap. They'll be really painful right where that tendon is ruptured. And the Thompson test, that's where you squeeze the foot, and that should contract the muscle, right? And if you contract the muscle, this should happen. And if you contract the muscle, that doesn't happen because the foot's already down, right? It's already torn. Splint in a plantar, splint in a plantar aspect, so toe down, equine, so the ends of the Achilles tendon are closer together, as opposed to that neutral 90 degrees right angle, all right, and refer to ortho. And then I talked about my screaming eagle story yesterday about acting like a teenage boy and winning a competition, but maybe losing overall. But tearing the medial head of your gastrocnemius. Little spaced repetition. Yeah, and you can feel it. My one calf, you can see it just looks different than the other side from the rupture. But they heal. A lot of TLC. Tibia and fibular fractures. Okay, this takes a fair amount of force to break both your tibia and your fibula. You often see this with person versus car, and it's usually person versus the bumper of the car that hits you here or something like that. That kind of injury, it can be open, right, which is more dangerous for getting osteomyelitis and stuff like that. And there's not a lot of cushion up front, in the front of your tibia. There's not a lot of cushion there. Yeah, so if it's open, you're going to get IV antibiotics, and most of these will need to be admitted, right, to your orthopedic surgery team and fixed. Compartment syndrome. Okay, so the lower leg is one of the highest risk areas for compartment syndrome. Again, it's getting hit as a pedestrian, usually in the lower leg. The case that I saw wasn't due to a motor vehicle collision versus pedestrian. It was another type of accident. And they didn't have a fracture. They just had a big swollen leg that came on suddenly, and the pain seemed to be out of proportion to what the nature of the injury was, and the x-ray was normal. So just be careful. You don't need a fracture to have a compartment syndrome. And so, there are these 5 Ps. Yes, they come in with pain. They can get numbness and tingling because of the compression of the nerve. paralysis. Wow, okay, so that's pretty. Pallor, because they don't have any blood supply, and lack of pulse. And you don't have to have all 5 to have compartment syndrome. These are the 5 things that go with compartment syndrome, but a combination, and hopefully it's not a pulseless limb. Hopefully they get to it before that, and it's pain that starts this process, or hey, maybe it's a compartment syndrome. I have never tested the compartment pressures. I refer it on if I'm thinking that. And they have this little chart about how it's an immediate treatment options for compartment syndrome, but this is the definitive care. Hope everybody had breakfast. This is the definitive care. You have to do a fasciotomy if you're worried about the vascular compromise of the limb, because you can lose the limb. And so they need to open up the compartments, surgically release the pain, release the pressure, and that'll alleviate the pain. But that's the treatment, a fasciotomy. All right, I finished on time. Who's up next? The Sharma. He always looks so much better than me because he wears a jacket. I'm going to start wearing a jacket just so I can be like as sharply dressed as you.
What about the sparkly lab coats?
I do have sparkly lab coats, but I could only bring my flight suit because I was doing carry-on. But I did make a mistake this morning, Mike.
Just one, though. Just one mistake.
Well, the first mistake I made this morning was I wore pink today, and I had an audience member point this out, that it's not Wednesday, Ken. Because on Wednesday we wear pink, and I'm like, oh, it's Wednesday, I got to bring my pink shirt and talk on Wednesday and wear my, it's Thursday.
I have pink in my shirt too, look at that.
See? But it's not, it's Thursday apparently.
Pink bros.
Boom.
Boom. All right. Hey, everybody, thanks for being here. It really means a lot to us that you've spent, 3.5, 4 days with travel, giving the most important thing you have to offer, your time and your attention to us here at the faculty. So we really appreciate your time here. I appreciate all the warm welcomes I've gotten from Rick over the past 2 days, but my name is Mike Sharma. I'm one of the 2 emergency medicine PAs on the faculty here. It's just always been a real humbling opportunity to speak with people like Ken, with Diane, with Rick. You're going to meet Chip later on. He's the other emergency medicine PA, and it's a real joy to be a part of this group, and people I've respected for a long time. Everyone's got that complaint that when they see it pop up on the EMR, it comes up and it says, whatever your complaint is, your pet peeve complaint, and you go, time for my break. There's a big laceration I gotta fix. Might take a while. I better take care of that, And for a long time, that was toenails for me. Because with toenails, it's hard to get the anesthesia right, and the patient is squirming. You're shoving this metal implement under the nail like you're trying to extract a confession from the patient, okay? It's just a bad scene most times, right? And so for a long time, that was toenails. But, guess what? What's the worst situation possible here, right? Mr. Smith, our team struggled valiantly. In the end, you've lost your toenail. That's okay. I know a lot of folks with 9 toenails, and they do awesome. Okay? How about the eye? Hey, remember that binocular vision? That depth perception you used to have? Yeah, we're all done with that. Okay? So perhaps the eye for you is kind of your thing where you're like, oh boy, time for my break. But I want to show you today that what's great about the eye is that pretty much everything you need to diagnose and catch a bad eye complaint is up here, or at least it will be shortly, okay? Or you walk into the room with it, okay? There's not a lot of lab tests I got to order for an eye, okay? But there are certain times you have to know to consult. Those are very important to catch, and also some important diagnoses you make with a strong physical exam and history. All right, but everything you need to know is basically what you walk in with. Let's get into it here. The anatomy we're all familiar with. The one anatomical feature I want to call your attention to that is not notated on this thing is something called the limbus. So look at the sclera, the white part surrounding the colored iris, and the part of the sclera that just surrounds the iris. If you can imagine a zone right around the iris here, so that's called the limbus, okay? And the limbus is a very important feature because a lot of bad things involve problems at the limbus in those areas. And I won't belabor the point for now. You'll see it as we go through the lecture here. So I like when someone's got a bad eye or even an eye complaint, I will document, hey, the limbus is clear. If it doesn't look like there's a lot of concentrated either blood or injection at that place. That's a good next level clinical finding for you to document. If the chief complaint has eye somewhere in it, go ahead and have the nurse or tech get a visual acuity. This is the vital sign of the eye. It's super important to document that they had a good eye. Because a lot of times people don't understand, they don't catch how their eyes kind of degrade, their visual acuity will degrade over time. So it's important you objectively catch that here. Classic thing with pupils, you'll get an EMS call, hey, this person's coming in with a blown pupil, and people are freaking out, and then you talk to the patient, and they go, yeah, I had cataract surgery. It went great. Okay? Some folks functionally have a funny-looking pupil. Good to document, but also good to know, hey, there's more things beyond some sort of giant brain bleed that cause a funny-looking pupil. What else to do about the eye exam? The slit lamp exam. We all have slit lamps in the ER, and you know what it is. It's that thing, that piece of equipment that looks like it's from the 40s, and it's back in the back corner of the ER, either covered with a tarp or several layers of dust, okay? And, you know, a lot of people, when they have an eye complaint, they come back to their little dictation area, and they sit next to their colleague, and they say, wow, that looks like a bad eye. I think it needs a slit lamp exam. And you look at the person looks at you, and both of you are like, nope, ain't got it today, okay? There's a very brief video, 8 minutes to learn it. It's even shorter to actually perform it. And this is one of those things where I think it's important to take the bandage off and learn how to do a slit lamp exam. It's really important to catch these subtle but very important, really emergent conditions of the eye. Okay. Where are my new grads? We'll call it within the past 5 years, whether you're a new MD, DO, PA, NP. Who are my new grads? Let's see, hands up in the air. Okay. You guys think you're so smart. And you remember, during your whole person exam in PA school, you've got your ophthalmoscope up to that person's eye, and you're going, oh yeah, I don't see any sort of nicking or pulsations, and the cup to disc ratio is da-da-da-da-da, and in your head you're like, I don't see a damn thing here. And what's worse is when your lab partner walks up and they're like, hi, I'm your lab partner today, and they have like Coke bottle glasses, you're like, oh geez, I'm really not going to see anything today. Okay. So you just kind of get a gross look inside the eye with your ophthalmoscope in the ED for an eye complaint, okay? Just kind of get the broad strokes here. Panoptic scopes are less intuitive than the ophthalmoscopes we maybe grew up with in school, but you can get a nice wider set of vision on that. So consider playing with that if you have those in your ED. Lots of ways to measure the intraocular pressure, 10 to 20. Just recall 10 to 20. And that's a nice range of the normal pressure in the eye. Now, if you are at 21 or 22 or, Lord forbid, 23, do you automatically have acute angle closure glaucoma going on? No. You can have intraocular hypertension, just like you can have hypertension other places here. That does not mean you have an emergent condition. But just know, like, once you get out of 20, that's where it starts to go, oh, I wonder what's going on here. Could this be related? Under 20, less of a concern. It's really hard to get a good triage on someone who is screaming and clutching their eye and rocking back and forth. So if someone comes in like that, they just came from the gas station or some industrial site, and they just got hosed in their eye by something, it's okay to kind of like speed them to triage and work on that complaint, irrigate, dilute out whatever's going on here, and then we can catch up on the other, kind of stuff we have to do later on here. What's the classic thing? Someone's coming in with bad vision. Oh, great. Do you wear glasses? I sure do. Where are they? They're at my house. Super. Okay. That's where the pinhole acuity test can come in. And you can have a cool device like this, or you can literally just take your pencil and poke a hole in a piece of paper. And what that does is those function as makeshift glasses. Because what's the problem here? If someone has baseline terrible vision, like I used to do before I got my LASIK surgery, which is freaking awesome. Like if you consider it, if you haven't yet. If you already have baseline poor vision, how do I know that your complaint today is at your baseline or it's correctable with your usual glasses? The pinhole helps to reduce refractive errors. It's not going to fix like a neurological problem or some sort of trauma. But if you have some sort of refractive error that your glasses fix, this pinhole test will help kind of reduce that effect. And so you can go, oh, okay, this is fixable by pinhole. This is more related to your baseline problems and not any new complaint you have going on here. Topical eye anesthetic, pretty controversial. We're going to get into that in a little bit here. Really important to avert the lids. Not only might you find something interesting under the lid that needs to be removed, but sometimes you'll see things like cobblestoning, things that suggest, oh, this is more of a chemical conjunctivitis, an allergic conjunctivitis, and not sort of trauma or a foreign body under there. Okay. Let's talk washing out the eye. There are few complaints, in my opinion, that cause less pain or more pain rather, than a really painful eye. Like you can't even open your eye, the lights are bothering you, all these things, right? Yes, topical anesthesia, very helpful. This is a time where I will also give oral opioids or even IV opioids if I have to, if I really want to get that eye washed out with a really concerning chemical exposure here, okay? You're going to have a hard time letting someone or someone letting you pour a liter of normal saline over their eye without them just saying like, I'm done. So what I also like to do on top of all the anesthesia is some anxiolysis. So I'll go ahead and give them some sort of benzodiazepine or maybe hydroxyzine and let them chill out a bit. And that's where I've had the most success in people actually tolerating the amount of volume that is recommended in the textbooks as far as how much you want to dilute someone's eye out. Okay, and there's different tricks here, right? So you can use the Morgan lens. You can also kind of like use a nasal cannula, and that has kind of two prongs, two outflows, and you can rest that on the bridge of the nose, and now both eyes are getting hosed out. Another way you can do this is get an angio catheter. So like a little angio catheter, and you shove it on the end of your IV tubing, and now you got a little hose. And you can kind of have someone spray the eye out and then take a break, kink the hose, and then spray again. That's a cool way like parents can be involved in their kids' care for trying to irrigate a kid's eye out. Okay, so lots of different options there in terms of irrigation, but be generous. Be generous with your pain relief and maybe also your anxiety relief as well if you really want to get this out. Okay. Checking IPH is a cool thing to do, and there's a little strip there, a device designed for IPH checking, but maybe you don't have that. Maybe you don't have that in your urgent care or your ER. But what you got, most probably, is urine dipsticks. And on the urine dipstick, there is a pH tab. So what you can do, a pretty ninja trick, is if you can snip off the part that does your pH on the urine dipstick, you can check their IPH that way. Let the eye pH kind of equilibrate after you've washed them. Don't just hose them out with a liter and then, well, bam, put your pH strip on there. Let it sit for 15 minutes, let the eye tears kind of like wash out the saline, and then check their pH. And the idea is you want to check before and after, and ideally they come back to their physiologic pH after. And if they're not, that could be an indication you need to irrigate more and wash them back to their physiologic pH between 7 and 7.4. There may not be a more like enjoyable procedure for me than getting a foreign body out of someone's eye or ear or nose or, wherever else, okay? Like, this is why we got into emergency medicine. Somebody walks in with a complaint and they walk out fixed. And that's like the best thing ever. That's why I like emergency medicine, okay? So how do we do this? Yes, anesthesia, right? Fluorescein, very helpful because sometimes you just can't see these foreign bodies until that fluorescein really highlights that, okay? But fluorescein strip, like, have you ever tried to stab somebody with a wet noodle before? It doesn't work very well, okay? Especially if the person's like really, sensitive with their eye, understandably. So what can you do? You can get a saline flush, a 10 cc saline flush, and I squirt out about 9 of those cc's I pull the plunger off the back, I drop the strip in there, and now I have 1 ml of fluorescein drops. Okay? So even in a real squirrely patient, I can kind of time it right and go, okay, just open your, there, and I just like squirt the whole ml right there. And some of that fluorescein's getting in there, okay? So that's a way you can do that if you're not a big fan of that. It takes some practice to not make a giant mess. You gotta there's literally videos on YouTube about how to do this. It's tricky because if you pull the plunger out wrong, all the saline goes out the front. Watch the video or just play with it and you'll get the feel for it after a while. If you see this classic pattern of these up and down scratches, that is your cue to really, really look under the lids, okay? Because that blinky, blinky, blinky with the foreign body is gonna make that scratchy, scratchy, scratchy up and down. So you really gotta take more time and really look under the lids for those things, okay? Now, how do we get out the foreign body? You've numbed them and you've found it and you're gonna get it out, okay? So the Q-tip or the moistened cotton tip applicator is one way, and if it gets out that way, then bonus. That's just a real easy thing to do. The other way you can do it is you can use like a 20-gauge needle, okay? You use a 20-gauge needle, and you're almost like flipping pancakes here. You get the bevel pointed up, and you get the very tip of the needle underneath the foreign body and just kind of flink, like you kind of flip it out of its place in the eye, okay? This is understandably kind of an anxiety-inducing procedure for patients sometimes, okay? And maybe it's an anxiety-inducing procedure for you as well. If you haven't had your right dose of caffeine for the day, or maybe you went over a little bit and you're kind of shaky. So as always, you got to assess the patient's ability to tolerate sitting still and your ability to do this procedure. Because maybe you call in somebody else, maybe you sedate the patient, maybe there's things you can do. But be absolutely sure that everyone's ready for this procedure, including you. Now, in terms of any rust ring left over, does anybody on a regular basis, does their shop, their ED or urgent care, do y'all burr out the rust ring? I'm looking at maybe a handful of people here. It's great that y'all do that, and sometimes I think in rural shops that is better because it's otherwise ophthalmologist is in the next state over, So it's nice to do that if you can do it in the ER, but it's not the emergency. That can be taken out later on, but it should be done because otherwise, especially if that rust ring is in the field of vision, they're always going to have this kind of haze in their field of vision. So something that ophthalmologists can do later on. We ask these questions about drilling, grinding, hammering, because we want to know if a foreign body is not on the eye but has been launched into the eye, okay? And even if the eye looks all right, you want to have a stronger suspicion for some sort of intraocular foreign body. There's a great video on YouTube about the Seidel sign. What that is basically is it's the eye leaking from the hole this foreign body put into it, and it pushes the fluorescein around. So you can see that, and that can be your second clue, oh my gosh, this person has a penetrating foreign body. How to better evaluate that? X-ray, ideally CT will locate these intraocular foreign bodies. I mean, if it's metal, you could do an MRI, and you'll get it out. Okay, just not in the way you want to, okay? So X-ray or CT for these things, please. Sometimes we worry and we wonder, okay, this person with a red eye, do they have a corneal abrasion, or is this just pink eye, okay? We've all gotten poked in the eye before, or we've been walking around and it's windy and something hits you in the eye, and it almost knocks you off your feet. It hurts to have a scratch or even a little dust mote in your eye. And so that's kind of a way I assess, how painful is this person? Or are they just kind of looking at me yeah, this sucks. I don't like that it's red. What do I do about it, doc? Okay. So that's a severity of discomfort here. Okay. It's one of those situations, especially when you have a suspected viral conjunctivitis, the textbook answer is you don't have to do anything. But as we'll see later on, how do you know? How do you know it's not an early bacterial conjunctivitis if they come in on hour 6 of their pink eye, which is not unusual, okay? So even though these are often viral, when it's a pink eye, And especially when there's a corneal abrasion, when there's more pain, usually we'll prescribe antibiotics here. Okay, and we'll get into which ones later on. A lot of other things are not really recommended. In terms of topical anesthesia, this is a really touchy subject, okay? The emergency medicine literature says it's safe to do in very short courses, no more than 48 hours, and then they trash can that anesthesia, okay? And you could do that for a patient. You could give them that bottle and say you only use this for this amount of time and you throw it out if you think the patient is reliable. Be prepared for a nasty gram from ophthalmology, though, if you do this, because a lot of the ophthalmology specialists will say, this is unsafe. And we'll say, okay, well, tell me why. And there's not a lot of evidence in the ophthalmology world. There's case studies from the 60s of about 7 people who abused the tetracaine. They obviously used it more than they were supposed to. And it's I'm not advocating for them to misuse it. I want them to use it right. Is there any evidence that people who use it right, that they have bad outcomes? There is not much evidence about that, okay? So it is an option to send them home with it, but be very careful about both educating and then documenting how you told them to use this. I'm always asking my eye patients, do you wear contacts and do you have diabetes, okay? Because every single person who wears contacts, if you ask them, hey, do you always use the right solutions and you take them out at night and you swap out your contacts at the right intervals? And if they say yes, you know they are a liar. Because even I didn't do that when I had contact lenses back in the day. There's always, you miss, things happen, whatever, it's fine. You're in Vegas and you're busy and whatever, things happen, okay? So having diabetes, wearing contacts, you are at an increased risk of having a different set of flora live on your eye, okay? And that's things like Pseudomonas. And so we'll use fluoroquinolone drops or ointments for those patients. Fluoroquinolone drops or ointments for our contact lens patients and our diabetes patients here. Okay. There are case studies of eye tetanus. As rare as tetanus is, there is eye tetanus as well. These case studies have shown this happens, or have documented patients with intraocular foreign bodies. So a superficial scratch of your eye, not as big of a deal. If they walk out and you're like, oh my gosh, I forgot to give them a tetanus booster, it's probably going to be okay if it's just a scratch on the eye. And we'll talk more about tetanus and other reasons to boost for tetanus and the other things in the tetanus booster at a later lecture. I mean, you can see these hyphemas from across the room, so that's not hard. But like everything else we talk about today, there's a spectrum, okay? So there are microhyphemas you just can't see, even when you're up in their face. So again, another great use of the slit lamp to find these microhyphemas. This is a Call Ophthalmology Today case. Here we go. There's a great kind of review of viral versus bacterial conjunctivitis, this bread and butter, emergency medicine, urgent care kind of a thing that I'm going to link to and show you in the next slide or two here. But here are some things. If we really think somebody with a red eye has viral conjunctivitis, I want to hear an awesome story. I want to hear about somebody else in the house having pink eye. I want to hear about this person having a cold or something else. I want their vision to be great. Usually they'll say, oh, it's blurry. And it's probably from all the schmutz that is on their eye, right? If you blink, 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 does that blurry vision go away? Oh, yeah, it does. Super. Okay. Sometimes you get little puffy lids, which can be tricky because, like, do they have a cellulitis going on as well? We'll talk about that in a second, okay? Schools and work are often just a murder about their people coming in to work with a pink eye because of how contagious these conjunctivitis are, even your viral conjunctivitis. So I'm pretty free with some work notes for a pink eye because they're just going to come back and get it from somebody else if they don't get it from you. How do I know it's bacterial and not viral? Well, like I mentioned early in the course, you just don't know sometimes. The quality of the discharge is helpful. If I'm seeing the eye leaking pus, like thick pus in front of me as I talk to the patient here, that's probably not a viral conjunctivitis. I'm worried about some sort of bacteria. And in a lot of patients, you're dealing with your typical like ENT bacteria, okay? And so like things like augmentin or whatever else can happen here. Is this patient at risk for an STD? And that's tricky because like how do you know? What are they disclosing to you? So consider covering them with things like ceftriaxone, and now doxycycline is the treatment for chlamydia, okay? Consider, again, Pseudomonas coverage as well for our contact lens wearers, our diabetes sufferers here. I like erythromycin, especially in kids. Like, I can't pick a booger out of my 3-year-old son Andrew's nose without him flipping out and running away from me, right? So good luck putting eye drops in your kid's eye, okay? But if you have the ointment, all you gotta do is kind of pull the eyelid down and squirt that ointment somewhere in there, and the kid's gonna blink, and it's gonna spread the ointment around, and there you go. Okay, so ointment's especially helpful for kiddos. There is one of our episodes we did for the two of you talking about kind of recent things here as far as like update on literature on bacterial versus viral conjunctivitis. One of the big ones we don't really check enough of, in my opinion, I'm guilty of this too. I've already got the light in my hand looking at their eye. I need to go around the corner and check their ear as well, even if there's no ear pain. When you see a red bulgy eardrum, this is suggestive of this conjunctivitis otitis syndrome, and they need oral antibiotics, like an augmentin or something like that. And it's weird, these people, you look in there, you're like, wow, red bulgy ear. Does your ear hurt? They say, no, zero ear pain at all. So that's a neat way to catch, oh, this is actually a subtle bacterial conjunctivitis. The eye may not be looking as bad as other bacterial causes. Iritis, uveitis, again, what do you need in a red eye treatment and taking care of someone's eye? You just need your big brain and some good physical exam skills and a few tools. So what do you do with iritis, uveitis? How do you diagnose it? An easy, a cool way to do this is this. Hey, your right eye hurts really bad? Close your right eye. I'm going to shine this in your left eye. And if you do that and they go, whoa, my right eye really hurts when you do that, you're taking advantage of that consensual reflex of the eye that we learned about in school. What do I do when I shine the eye and the light in the left eye? Both the left eye and the right eye, their pupils constrict. And so if someone's got an iritis and I stimulate their iris by doing that, that's a clue. Maybe there's an iritis uveitis, okay? These folks need to see ophthalmology at some point because it's easy in a way to diagnose iritis uveitis. But the master clinician thinks, why? Why does this patient have iritis uveitis? Is it from a trauma? That can happen. Is it from some sort of other disease, like a multi-organ disease, things like lupus or sarcoid or HIV or other things like that? So your diagnosis properly and referral properly of the red eye in this patient could be their key to figuring out they had something they didn't know they had. And you can be making that diagnosis with them. This is one of those cases where you can have ciliary flushing. Okay, ciliary flushing is that increased injection at that limbus, that sclera right around the iris. So look for that. You see that. That's your other cue. Hey, this could be that. There are just so many reasons to have a red eye, okay? Especially if y'all are snowbirding in Colorado and doing some locums work. Maybe you live there. Someone came off the slopes and they didn't have nice tinted eyewear here. You can get UV keratitis, and there is a physical exam finding with that. You can have bad allergies, and that can see cobblestoning, and chemosis is a great thing to see of the eye. In bad chemosis cases, the eyeball looks like it's bulging. Okay, it's really swollen, and that can be something as simple as allergies, as dramatic as that looks. Hordeolum, chalazion. If you don't fix the hordeolum, it usually becomes the chalazion. It goes from this painful, focally swollen thing on your eyelid to this non-painful, swollen thing. Early on, warm compresses, gentle massage. Controversial treatment if it's the bounce back hordeolum. They say, I've tried your warm compresses for 2 or 3 days. It's not working. Now what do I do? Jury's kind of out. You can do ophthalmic. You can do oral antibiotics. Lots of possibilities there. My mom grew up farm girl tough, immigrant tough. She was born in the Philippines, slept on a straw mattress when she was a kid. And what did she do when she was a kid? She tended to the livestock. And she was out in the fields as a child. Didn't have the cool Oakleys and such that we have today. And I noticed from a young age, Mom, why do you have that yellow thing in your eye? She's like, I don't know. It's never bothered me before. Okay? Turns out Mom has a pingueculum. Okay? This little yellow globular looking thing on the white of the eye only, not spreading over into the iris. That's called a pterygium. Both of these things are often from repeated sun, wind exposure like my mom had when she was a kid, and this is routine follow-up with ophthalmology. There can be chronic dacryocystitis where someone's had a goopy discharge from the inside of their eye since they were born, or you could have a more of an acute bacterial dacryocystitis where at the kind of the corner of the eye next to the nose, painful red swollen, you can express pus out of there. You can treat those with your typical, again, different antibiotics that you would do for other bacterial situations up here. Augmentin, amoxicillin, those kind of things here. Right. It's really important to distinguish this from this. So things like our hordeolum, things like our dacryocystitis acutely are going to be very localized. Right here or right there, there's going to be redness, pain, swelling. This is going to be more diffuse when we have an orbital or periorbital cellulitis, okay? We know what cellulitis looks like. It's hot, it's painful, it's red, and you know, you can have swelling underneath the eyes from an allergic conjunctivitis, allergic symptoms. But those things will not be red, painful, swollen, firm. That's the way you can distinguish, oh, this is more of a bacterial versus an allergic thing. So you can have really dramatic allergic shiners here. A real good way to document that you knew what you were looking for to distinguish between periorbital and orbital is asking the patient, when you look around, does it hurt? Does it make it hurt worse? And if they say yes, that's really concerning. It's concerning that the tissues behind the eyeball, the fat, the muscles back there are inflamed from an infection, okay? And the concern there is that this infection will continue to spread back behind the eye further. What's behind the eye? The brain. Okay. How do we know, how we kind of confirm with imaging our suspicions here? This would be a CT of the orbits with IV contrast to look for inflammation and, God forbid, even an abscess back there, which can happen. Who's usually getting this? Sometimes trauma, but also are people who are at higher risk for bad infections, diabetics, chronic steroids, things like that. Okay? The lesser concerning thing is often in people who have had a recent upper respiratory infection, and they can get kind of some mild pain and swelling around the eye, but no pain with looking around. Okay? These patients can be actually discharged with broad spectrum skin coverage antibiotics with close follow-up. In your real dramatic patients, you're going to see things like proptosis, where the eye is bugging out. You're going to see ophthalmoplegia, where the eyes don't move together. But just like with Ken's talk about, compartment syndrome, you don't want to wait until that. You don't want to catch it here. You want to catch it much earlier. You don't want to wait until they're pulseless and their limb is dead. Okay. Again, CT with contrast is the way to go. These aren't unusual things for people to have one time, okay? Maybe, you went to the Caesars buffet, and then after that you came back to your room, and you're on the toilet, and you're kind of, grinding one out a little bit, and you go to wash your hands, you look in the mirror, you're like, oh my gosh, what is that? And you see a little redness, a little blood in your sclera here. One time is okay, and that's often how people get it, a little bit of increased intra-abdominal pressure temporarily, okay? But if it's the patient's second time, third time, fourth time, or if there's trauma Or if it's a lot of hemorrhage here, that's when we're going to do a little more of a workup. Let's get coags, let's get some labs, let's see what else could be going on here. Is it a more serious trauma than we thought if the entire eye is red and bloody? 10 to 20 is our number to look for acute angle closure glaucoma. If it's way above 20, we're concerned that the fluids in the eye are not circulating properly. There is a classic kind of presentation of being in a dark room and all of a sudden, oof, one side really hurt bad, I have headache, nausea, vomiting going on here. There's many different medications that you can use for this patient who often has this kind of, they call it a mid-dilated pupil. It's not pinpoint, it's not blown, it's somewhere in the middle. And that cornea, as you can see, can look a little bit cloudy there. You're for sure going to want to get ophthalmology on board because there's certain treatments you give at certain levels of pressure. It's kind of complicated. Good to have ophthalmology in your corner backing your play here. A lot of us have little smart books, whether it's paper actual books or even a little cloud drive where they put cool little devices and figures and stuff. This is a great one for you to keep in your smart book or smart drive here about a methodical way to go through the red eye and not miss the bad red eyes. Okay? If you were oogie about eyes a half an hour ago, I hope I've shown you today that as long as you have a good head on your shoulders and you have the right tools in your urgent care and ER, you can diagnose and catch the important reasons, the emergent reasons for the red eye. And there's no reason to be scared anymore. Right? Thank you.
Can I borrow the jacket? No.
I don't know if it'll fit you.
We'll see. That's right, get up and leave. Sure, now's the time. It's only my last lecture. I won't take it personally, but I know who you are. All right. So this is the last lecture that I'm going to be giving, and then I have to leave and head off to the airport. We have a winter storm going back home, and the flights have been switched around and changed, and that's why we had to change around the schedule a bit. So if you have any questions from this lecture, if I'm in the airport, I can answer some Slido stuff for you. If not, my email address, you can email me at any time. It's the SGEM, that stands for the Skeptic's Guide to Emergency Medicine, the SGEM at gmail.com. I answer my emails. Just send, I love talking nerdy. So if you have any clinical questions or talking about science or methodology or anything like that, or 80s movies, just send me a line and I'll respond. All right. So this is about cervical spine disorders. We're going to be looking at mostly benign ones, but some that are not so benign. So this is minor C-spine injuries in the emergency department. We are not going to be talking about the major C-spine injuries. Multi-system trauma stuff will go to the trauma bay, will go to the trauma center. These are not the cases that we are going to be talking about in this lecture. This is going to be focused on cervical injuries that might slip through. I don't know if you guys have fast tracks where you work or green zones, but sometimes you'll find these people in the green zone or the fast track, and it may be considered minor, but it might be something really important, much more important, and we often pick up these things in fast track or green zone. And so advanced imaging is often required, such as a CT scan, an MRI, which, depending on where you work, can be more of a challenge to get. C-spine immobilization. We have been doing this forever, it seems. So somebody comes in and they have a neck and it's sore, it seems like they get a hard collar. Now, I'm not saying that's what's happening, but it seems like everybody's getting this hard collar. And what's the evidence for hard collars to prevent secondary injuries? Even in traumas, we don't have really good evidence. Now, I'm not saying don't follow your hospital protocols about putting on hard collars, but just know that in other developed nations, like Australia, they put on soft collars. They put on these soft collars, and they'll have a Velcro strap on the front and a little thing that they can put, and it says not cleared. And then they can pull that little badge off, and then it says collar cleared or C-spine cleared. And so having a rigid collar, anybody here been in a rigid collar? Yes? Was it very comfortable? No. Did you have a lot of neck pain when they put it on? Did you have more neck pain after they put it on? For a long time? Yeah. So we need to have these protocols to try to get people out of collars safely, but there's not great evidence that putting them in the collar prevents secondary injuries. But clear them as quick as we can, because if you've been in a collar, I've been in a collar. I was pumping gas once at a gas station, and in came one of those box vans or cube vans, because it was a red light, and they thought that they could just, deviate through the gas station to avoid the red light and make their turn and stuff, and I'm just sitting there, poof, and I get hit, and I get thrown about 30 feet, I think. I mean, in my head it was 30 feet, but I got thrown, and of course it was like an episode of the movie Zoolander, and there's gasoline, because I was pumping gas at the time. There's gasoline, and I'm lying, I'm fine, and people are like, no, hold still, and I'm like, I'm fine. Yeah, got put in a collar for that. And I had a sore neck after. I didn't have a neck injury, but I had a sore neck after. So please get these people out of their collars as soon as you can safely do that. So, yeah, these people come in, they've got these boosters on either side, pillows, rolls, rolled up towels, yoga mats rolled up, I don't know, and then they've got duct tape across their forehead, and they're like, I can't move, right? So we have immobilized these people, and it can be very uncomfortable. So there are a couple of methods of getting people out of the collar or clearing their C-spines using some clinical decision instruments. There's the Canadian C-spine rules, which is used more in Canada, and then there's the nexus criteria, which is used more in the United States. To limit your medical legal liability, just follow these and document that I followed either the Canadian C-spine or the nexus rules or whatever your hospital protocol are for getting these people out of a C-spine collar as soon and safely as possible. So here's the nexus criteria. And so for the nexus criteria, I like it because it's nice and simple. There's only 5 things, and I like it when I can count to it on one hand. So 5 things. You'll find this in MD Calc. But if there's no posterior midline spine tenderness, that's good. No evidence of intoxication, all right? A normal level of consciousness. No focal neurologic deficit. You can imagine if they can't move one side of their body or the other side of their body, they might have a spinal cord injury. The last one's a little hard. No distracting injury. And we talked about this the other day about having a code paronychia team, because people's perception of pain is different. You can have someone with a femur fracture going, no, I'm not in too much pain. I'd say it's about a 3. And you have people, do you have people in your emergency department? And you give them explicit instructions. Please grade your pain on a scale of 0, no pain, to 10, the most pain you've ever had in your life. What do some of those people say? Oh, it's a 14. I'm not sure you understood the question. It goes from 0 and 14. It doesn't go beyond 10. What's your pain? 14. Okay, so it's subjective. Pain is subjective. And so how do you quantify a distracting injury? Is a corneal abrasion distracting injury? It can be very painful. Will that distract you enough not to know that you have a fracture in your neck, or a trimalleolar fracture of your ankle, or a paronychia? So it's up to the patient to decide really if it's distracting. At least I'm like feeling their neck going, listen, I know that you have this bruise on your knee. Is it so painful that you can't tell if this hurts when I'm pushing on your neck? So I try to get them involved that way. But you have to be careful. That last one is fairly subjective. And read the fine print. So under that 5th point down there in the highlighted gray section, there is a discussion about what they meant when they put the clinical decision instrument together for distracting injuries. And what they meant was specifically put. But there is subjectivity to that. And then you can see why the Canadian rules look a little bit more complicated. It's not like 5 things. There's like, these first 3 things, and then you go here, yes or no, and then you go here, and is there a dangerous mechanism of injury? And then they describe what a dangerous mechanism of injury is. I need an app to use the Canadian C-spine instrument. I need an app for this. Now, who uses what instrument? Well, Americans use the Nexus criteria. It was developed in the US, it's simpler, and it's used there. I have to say in Canada, we use the Canadian C-spine rules because we're trained that way. You can have your own institutional algorithm. This is not for you to memorize. This is not for you to know. You will not be quizzed on this. This is for you to go, hey, we could come up with our own institutional algorithm to get people out of a C-spine collar as quick as safely possible. Here's an example. I could take this back to my own institution and say, hey, committee or group or whatever part of your institution looks at this and says, here's an algorithm that we could base it on, that we could edit for our own needs. And so that's why it's there, not for you to go, oh, okay, I need to study this. Same thing with the pediatric spine evaluation pathway. This is one for pediatric cases. Again, if you're in a community shop or a critical access hospital where you see cradle to grave, womb to tomb, all comers, not just adults, if you're seeing pediatric patients, this could be an algorithm you could take back to your own institution and say, hey, could we come up with something if we don't have something so we can safely get people off the collar or out of the collar as soon as possible. And then the discussion comes up about, well, how about CT versus plain old X-rays? And it's still debated in some places. Some places it's not. It's just, if it's a neck, we're scanning it with a CT scanner. I always joke about the emergency medicine alphabet, A, B, C, T. That's the alphabet, okay? And so getting a CT might be what your institution does. But plain films can have a role, and certainly where I had worked for many, many years, since we didn't have a CT scanner, we were doing a lot of plain films and then selectively sending people off for a CT scan. They talk about some of the concerns about CTs, this radiation load. Okay, it's somewhat theoretical with regards to the radiation exposure. It's extrapolated data. Yes, the thyroid is sensitive to ionizing radiation, but we do have an effective treatment for thyroid cancer. And so if they need a CT, if you need a CT of your neck, I wouldn't use, the radiation sort of thing to prohibit me from doing that if they needed one. And then they talk about other things like costs and charges and all that kind of stuff. If you're getting the neck and they've had a head injury, you can go both ways. If they've had a head injury and their neck is tender, you can scan both. There's, if you're going off for a CT head and you're going to get plain films of the neck because it was tender, no, just get the CT of the head and you can get the CT of the neck at the same time. You'll get more, you'll pick up more injuries with that CT. So plain films of the neck, if people haven't been operating with plain films of the neck, there's ways to read, on that lateral film, which is shown on the left-hand side, the anterior line, the posterior line, the laminal spinal line, and you look at all those things lining up. And then you have the CT scan on the right, which gets you much greater resolution. And then they can do these fancy things with their computers to reconstruct these things into three-dimensional models. So plain films are not gone completely. Let's say you just have a minor bump and it's, the CT scanner is backed up for hours because of everything that's going on. If you've got a minor case and you can't clear it by the Nexus criteria, or it's a patient with chronic pain, it's not an acute pain onset, getting plain films may be totally appropriate and reasonable. You get 3 views typically. You get your AP, you get your lateral. That's the open mouth odontoid view in case you don't speak that. So you just open the mouth and you get that odontoid view for the peg. If more significant, you get a CT. The soft tissue can tell you stuff about whether there's an occult, a hidden, a darkened. I can't see that injury. It didn't have an arrow on it, so I missed it. So you look for the soft tissue. And there's sort of this general statement that if you have 6 millimeters at C2 or 22 millimeters of soft tissue at C6, that could suggest that there's an underlying fracture or occult fracture that you're not picking up. And then you have the atlantoid dens area, and there's differences. In children, there's a lot more space because that hasn't calcified as much, and so there's 5 millimeters on that peg coming up between, 5 millimeters on either side, and in an adult it's 3 millimeters, it's tighter. This is the odontoid view, and you just want to make sure the lateral bodies line up, the peg looks good. Now sometimes when you see that dens, the peg, sometimes when you see that, you'll see the shadow in the back, right? You can see it on that film there. You can see that shadow of the occiput, and you go, oh, that looks, just follow it across. That's not necessarily a fracture. Okay, so the neuro exam of the cervical spine. We went through this sensory exam yesterday. We looked at C5, we looked at C6, we looked at C7, C8, T1. We even went to T3. Do you guys remember that? Is space repetition? Are you sure? Julianne, could I get some help, please? Could you stand up? Thank you. Now, Julianne, why don't you get your teammates to come around to the front of the table there and come up, and maybe we could do some spaced repetition. Give them some courage there, people. Come on. You know? All right, Julianne, standing up and looking at me just to start with. You've trained these individuals, correct? Are you guys ready? So ready? 5, 6, 7, 8, T1, T2, T3. Yes, okay. They did great, didn't they? Julianne, can you turn around and get everybody to stand up and do it with us, please? Everybody, stand up. Let's do this. Come on. It's the last day for me. We have a social contract. I've been teaching. I want to go home with this big audience on their feet. Okay, you guys ready? We'll go through it slowly first, and then we'll speed it up. Julianne, you ready? Everybody ready? C5, 6. Come on, do it with attitude. Pop. 6, C7, 8, T1, T2, T3. Now, we're going to speed it up, and I want you to say it with me. It's there, there's muscle memory, but there's also that verbal learning too. And please, really say it loud and pop on that T3 for me, okay? With attitude here, people. You ready? Here we go. 5, 6, 7, 8, T1, T2, T3. Now, I'm going to do it without saying it very loud. This is the last time no, stand up, sir. Oh, you stand up. Come on up. Come on up. Come on up. You can't pull that kind of stuff on me. Sits down. Oh, look at how spry he is. He must be much younger than me. We have not met before, right?
Yes, I'm from Australia.
Oh, he's from Australia? Okay, but we haven't met before. We didn't set this up, of course. Right? You ready to do this?
Yes.
Loud as you can. Now, he's Australian, so I'll do American Sign Language. I don't know you well enough, but here it is, clipping it on.
Okay.
Woo! You ready?
Okay.
Ready? Here we go.
C5, 6,
7,
8, T1, T2,
T2,
T3.
Okay, now we're going to do it fast. Ready?
Okay.
Here we go.
5, 6, 7, 8, T1, T2, T3.
Very good. All right.
And I can confirm C-spine, collar, soft.
So our gentleman here confirms that in Australia, soft collars for C-spine injuries. So thank you very much. I have an independent verification of this. Thank you, Julianne. You've been the best all conference, I tell you. You're not supposed to have favorites. I got a favorite. All right, so now I'm going to teach you one other thing. This is the reflexes. It's 1, 2, tie your shoe, 3, 4, kick the door, 5, 6, pick up sticks, 7, 8, close the date, 2, 3, 4, keeps the poop off the floor, 3, 4, 5, keeps the diaphragm alive. You got it? Okay, next slide. You got that, right? Okay, so 1, 2. Okay, 1, 2, tie your shoe. That's your deep tendon reflex there. 1, 2, tie your shoe. 3, 4, kick the door. L, 3, 4. 3, 4, kick the door. 5, 6, pick up sticks. 7, 8, close the gate. Close the gate. 2, 3, 4 keeps the poop off the floor. 2, 3, 4 keeps the poop off the floor. And then C, 3, 4, 5 keeps the diaphragm alive. Okay, so it's 1, 2, tie your shoe. 3, 4, kick the door. 5, 6, pick up sticks. 7, 8, close the gate. 2, 3, 4 keeps the poop off the floor. 3, 4, 5 keeps the diaphragm alive. This stuff is easy, people. All right, we already did our sensory exam here. Cervical strain or sprain, what is commonly referred to as whiplash, if you've gotten plain films. And the plain films don't show an injury, and the neuro exam is attacked, you can have ligamentous injuries or perispinal muscle injuries. You can see with, modern vehicles, we've got those restraints in the car, and your head will go forward even though your shoulder and chest are held against the seat. Some cars are really smart, and they actually tighten up on you if you hit the brakes suddenly, right? And so you can see how that neck can go forward and cause some soft tissue injuries. Treatment is usually can get by with nothing with regards to immobilization, but maybe a soft collar for a few days. NSAIDs, I would move narcotics and steroids, usually just NSAIDs to start with. Seatbelt sign, though, this is different than somebody coming in going, I rear-ended someone at a traffic stop at low speeds. Having someone have a high-speed injury and having this seatbelt sign. If you see that seatbelt sign, be very concerned. There are things that go in and out, go huffy-puffy, thumpity-thumpity, to make the brain go thinkity-thinkity. All right? And so those are important structures in there. And if you see that gentleman with that nice purple bruise across the neck, you're worried about airway. You're worried about nerves. You're worried about arterial injuries there. So don't dismiss it. This could be that green zone case. They were okay. We cleared them at triage with regards to the C-spine injury. And then they unbutton their shirt to get examined, and you go, oh, I think we're going to need a little bit more attention on this case. This isn't the last 20 minutes of your shift chart case, right? This is something that's going to take a little bit more investigation to look into this. Don't dismiss these types of injuries. Cervical rib syndrome, we talked a little bit about this yesterday. Thoracic outlet syndrome, it can be congenital. You can have some narrowing of the thoracic outlet. That can put pressure on the arteries and the nerves and give you chronic pain syndrome in the hand. You can get numbness and tingling in the arm. You can get this heaviness that you feel. You can get color changes. Thoracic outlet syndrome. We talked about that Adson test where you get the person, you take their pulse, you put your thing over the thumpity-thumpity there on the wrist, and you get them to turn their head and lift back and twist to see if you can pinch that off to the point where you don't feel their pulse anymore. That checks for an arterial problem of the thoracic outlet. And then we talked about the put your hands in the air and wave them like you just don't care. Okay, that's the East test that you do for 3 minutes to see if you can mimic the heaviness, the pain, the numbness, the tingling that people are describing for a thoracic outlet syndrome. And this gives you more examples and more anatomy to look at. And there's the Adson test and the East test. Cervical disc disease, these are usually chronic symptoms. You want to do a good neuro exam, right? So a good neuro exam. So check for motor loss, check for sensory loss, look for fasciculations, do your reflexes. You know this now. You know 5, 6, 7, 8, T1, T2, T3. You know that the median nerve is British. You get apposition when you pick up your teacup. You flex at your wrist, you flex at your elbow, and you pronate. You know the motor function of the median nerve and the radial nerve. The radial nerve extends the wrist and these 3 fingers, and then the ulnar nerve crosses your fingers, and these fingers can extend, right, if your ulnar nerve is intact, and they go like this if your ulnar nerve is injured, because I gave you the story of giving the crucifix of the Pope. Right? So you already know that. There's one pure sensory nerve, and that's the dorsal branch of the radial nerve, and there's one pure motor nerve. That's the recurrent branch of the median nerve going to the thenar muscle, the $1 million nerve, and then you can't do this. Right? So you should know that. You should know about the flexor digitorum profundus. It goes all the way to the end. It's very profound. It's very deep. And then the superficialis only goes proximally. It doesn't go very far. It's your PIP, not your DIP. That's your superficialis. People with chronic disc disease, you can get their images and stuff like that. You'll see these degenerative changes. We talked about some of the degenerative changes with osteoarthritis of the knee. Eventually, they may require surgery. Eventually, an MRI may be indicated. The MRI is not necessarily indicated usually in the emergency department for chronic things that have been taking months and months or years to develop. Cervical stenosis, degenerative changes after age 50. You get narrowing of the canal. The symptoms can be progressive. You get stiffness, pain, numbness, these types of things in the neck, extending down, getting weakness. Again, you know a really good exam of the upper extremity. You have that down now, thanks to this course and Julianne. Treat the symptoms first, get some NSAIDs on board, maybe opioids and steroids. Cervical facet syndrome, so this gives you the layout of C2-3, C3-4, C4-5, C5-6 over here. It gives you the area. You can see this in whiplash injuries, post-procedural issues, occupational stress, people that are putting their head down while they're working all the time. NSAIDs, and try to avoid those activities. Some people will do some trigger point injections with some steroids as well. A stinger or a burner, if you're playing one of those high-impact sports like hockey or football or rugby and stuff like that, if anybody's had a burner, it's a direct blow here. It puts traction on that neurovascular bundle, and you get this burning and stinging down the arm. They call them a stinger. The only thing that I'd warn people about, especially if they're, some people will volunteer and do the local football team, right, for the high school and stuff. If they have a stinger, it's one arm. If you're feeling symptoms in both arms, I want you to think about the big nerve in the middle. Okay? If you've got symptoms in both arms, it could be a problem with the big, important nerve in the middle. Thank you. I'm done. I finished a little bit early. I'm heading out. It's been a real pleasure. Thank you so much. Remember, email me anytime. I'd be happy to answer any questions. Thank you very much.
All right, and before you all get up, the break is 15 minutes, but at about 5 minutes before we regroup, there's going to be a video played for a new kind of exercise, if you'd like to try it, where there's a physician who will act out the arrhythmias, and you can actually check it out. I used to do it live on stage. I just got to. It's not easy. So we'll play that during the break if you get bored. 15 Okay, everybody. I figured we could do that between Ken's exercises that you do based on neuro exam and that guy's thing he does with, we could have like a whole exercise routine based on medical stuff. I used to do that up here live. It's not easy doing what that guy just did with that video, and these days with the waggies I've grown as I've gotten older and the fact that makes me short of breath now, I'm not going to do that. But it's actually great exercise. It really is, it's amazing, actually, amazing. All right, let's talk about your heart. Let's talk about cardiac dysrhythmias. We're going to basically do all dysrhythmias in 30 minutes, no problem. And actually the reality is we have to be really good at this, and we have to be really good at looking at EKGs. So it is worth, I'll tell you, EKGs evolve over time. Our sophistication of what we are finding on EKGs has evolved even over my career, quite a bit. So having a way to keep up on EKGs is really important. In addition, having a system, just like that chest x-ray system, a system for looking at an EKG. There are a gajillion different sort of versions of how to learn the basics. You all have done that. I think the main thing now is to find a way to keep up with EKGs. It's really worth walking around the ER, picking up the ones that are all over the counter, taking a look at them. If you know there's one that has an interesting finding, go look at that, get it into your head. Because EKGs, it's just something that's like a habit to get into in reading them. And you know sort of how to do this stuff. I'm not going to walk you through. We're going to talk about the abnormalities, but make sure you have some sort of go-to for looking at and learning about EKGs. I'm going to make a plug for a colleague I think is probably the master of all time in teaching anything cardiology, who is Amal Mattu, M-A-T-T-U, and he has an ongoing sort of EKG reading blog that you actually can, I think it's free, I'm not sure, but it is well worth your time because the guy is a master. There's a lot of different versions out there though. Whatever you use is great, but practice it. It's really worth staying up to date. And this is sort of the approach. We know that this EKG is just a bunch of squiggly lines on a pink piece of paper, but each of those squiggly lines and lumps and bumps in there actually makes a difference. We know that there's durations on this thing, there are heights of things on this thing that are important to be aware of, because the durations make a difference, whether something's short or long. So we'll talk about the normal ones and the abnormal ones, but know that is what's on your EKG. You can actually use those boxes for measuring lengths of time, and all of this is sort of things you know, but just make sure you focus on that as you look at EKGs. The other thing I want to mention as we get into the specifics is EKGs come with all the pink squiggly, pink paper and squiggly lines on it, and then a bunch of numbers and things at the top and an interpretation at the top. I really want you to know that you are smarter than that EKG is frequently. That EKG, the way it interprets the findings on that EKG is a vector algorithm that was developed that basically is just programmed into the EKG reading. It's better than it used to be, but there are things it is not quite as good at as you are, particularly things like rhythms. It is not particularly good at rhythms. It makes mistakes on rhythms. It calls something VTAC that may actually be aberrancy. And this is where you need to use your smarts. Where that EKG, though, is probably better than you are is the numbers on the interval side, particularly the QTC. So things like the PR interval and the QT interval and the QTC that are up on that top left of your EKG, those are really worth looking at. The interpretation, certainly take a glance at, but make your own mind up on what you think is wrong with that EKG, because you are smarter than the algorithm is, and please do that. Don't let it dictate your treatment. Pay attention to it, but if it doesn't match with what you look at the EKG and you think is wrong, trust yourself more than the EKG. Now, we'll start with the blocks. So first degree AV block is where the P wave and the QRS are just not talking as well as they should. There is a longer interval between that P wave starting and the QRS listening to what the P wave is telling it to do. This is extremely common, and we see this in kind of two big populations of people. One is as you age, that sort of conduction it gets a little bit kind of glitchy, so it just as you age. But also, if you're in this room, you're a marathoner, you probably have a prolonged PR interval. You probably have one. It's a high vagal tone thing as well. It is rarely, if ever, in isolation pathologic. It's something we just say, wow, you have it. We take a note of that. Look at the rest of the EKG, make sure there's nothing else there that's scary, and then just make a note of that. Rarely is it anything that we do anything about specifically. Second degree AV block is where we're starting to up the ante. And it has two types. It has Mobitz type 1 and Mobitz type 2. Mobitz type 1 is Wenckebach, and that's the one where that PR interval gets longer and longer and longer, and then a P wave gets dropped. Okay, your RR also gets, sort of changes with that. Everything just kind of shifts. It gets a little longer, and then you drop a P wave. That can happen in all kinds of conditions. That can happen in ischemia. That can happen in young, healthy people. It is rarely in and of itself pathologic. In the bigger picture, somebody having crushing chest pain with this, you're going to raise an eyebrow. In and of itself, it is rarely dangerous. So we just know it's like, either somebody's in great shape and they have this Winky-Buck deal, or there may be something like ischemia going on in the heart, but let me do a clinical assessment. So in and of itself, it doesn't raise an eyebrow. Drugs can do this, by the way. Certain drugs can do this. Medications we use on purpose for people. As you go, though, from Mobitz 1 to Mobitz 2, now you start to your own heart rate starts to go up a little bit. Mobitz 2 is basically the P and the QRS are fine. The atrium and ventricles are talking to each other just fine until the ventricle says, I'm not listening at all. And it drops the beat out of nowhere. You have a P wave that has no QRS to follow it. When you're looking at EKGs, always check, is there a P before every QRS and a QRS after every P? The reason you're doing that is for things like this, to find things like this. So we've dropped a QRS. This is a higher stakes game. This is not a normal thing. This is an abnormal thing. In a syncopal patient, it's going to raise your eyebrows. In an ischemic patient, it's going to raise your eyebrows. I will tell you, for Mobitz type 2, this is a cardiology consult. This is like, hang on a second, let's put the big picture together. But I'm going to talk to a cardiologist about this because it tends to be worse as far as indicating something wrong with someone's heart than the other things, the first degree or the Mobitz type 1. So in second degree, again, it drops it out of nowhere. The PR stays the same, the RR stays the same. It's just a P wave with no QRS. Versus Winky-Buck, which is actually that PR gets longer. The RR tends to get shorter, and then that P wave gets that QRS gets dropped. So just know that dropping out of nowhere, scary business. Versus now, as we up the ante even more, now you have the atria and the ventricles not talking to each other at all. The atria says, I'm going to turn this way and do my own thing, and it goes at its own rate, usually 90 to 100 if it's a normal atrium. It's over here. And the ventricles are like, I'm not talking to you at all. And my baseline as a ventricle is a heart rate of about 60. So what you're going to find is you have P waves marching right through, so they're going at their 90 to 100, and the QRS is doing their own thing, and they're sitting at about 60. This is assumed to be, it is extremely rare for this to be a chronic condition, for someone to be able to walk around with third-degree heart block all the time. We actually have a patient at Harbor who basically is always in third-degree heart block, doesn't want any interventions, seems to be doing okay. That is so rare. Consider this abnormal. In a syncopal episode, that's scary as heck. In an ischemic sounding story, it's scary as heck. And it always is a cardiology consult for this. Third-degree heart block, always. Medications can do this, by the way. High overdoses of certain medications, particularly beta blockers, can do this. But assume it's bad. There's nothing really good that causes third-degree heart block. So here's a little summary slide for you for interest, if you're interested. And if you're a super smarty pants, you're going to know that this basically second-degree block there, that's the third one down, is hard to tell if this is Mobitz 1 or Mobitz 2. And we can talk about that later if you're interested. Let's talk about atrial stuff that's premature, or premature stuff. We're going to go above the ventricles first. We're just going to hang out in the atria for a while. So PACs are where somewhere in your atrium, you have an AV node that goes crazy. So your AV node says, I'm just feeling a little irritable today. That's the AV node that starts all of your normal beats anyway. But today it's a little cranky, and it decides to have a PAC. There's probably a couple of you in the room having these right now. Super, super common. Not anything that's dangerous. The P wave basically is aberrant sometimes with this. The QRS follows it right away, though. Everything is fine. It's just an early atria beat. So an early P wave, QRS follows right along. It's like, oh, okay, we'll do this early. I'm in. A little bit of pause afterwards to go back to normal. That is it's usually benign. Nothing wrong with those. Those aren't a big deal. But let's get into the SVTs. Now, I want to tell you, technically, the word supraventricular tachycardia means tachycardia, fast heart rate, coming from above the ventricles. So technically, that term includes things like MFAT, atrial flutter, atrial fibrillation, but we tend to use the term SVT for that reentrant thing that we all think about when we hear about SVT. So technically, it includes all of this. In this talk and in sort of our medical parlance, we use the term SVT for that reentrant thing, which is what we're going to focus on at this moment. These are the ones that you get the call from triage where they say, person's out here with a heart rate of 180 or 190, young, healthy person, feeling palpitations, bringing them right on back. And you get to go, woohoo, You get to take care of this thing. It's usually a no biggie deal, all kinds of options to treat this thing. Usually doesn't hurt the person at all. And actually, some of you in this room may have had SVT. It's a really common problem. We have lots of ways to approach this thing. It is rarely, if ever, a bad thing for somebody. This narrow complex, really fast, in the 180 to 190 range is where this tends to sit, 170 to 190. This is usually narrow. Now, sometimes it's fast, 180, 190, and it's fat. It's wide. It is always fast. It's wider. It's not narrow. Those are cases that kind of make us a little creeped out, right? It's like, okay, is this just a normal reentrant SVT, but the patient's having aberrancy? Is this that SVT, though, with that WPW thing I know can kill people? Is this that thing I'm supposed to be worrying about that is so crazy scary? I will tell you, if you are not clear, it is always best to assume the worst. It is always best to assume that rapid, wide thing is the bad thing, is VTAC. It is more common for it to be VTAC in the old and the sick. It is more common for it to be an aberrancy thing in the young and the healthy. So put it in the big picture here. But if you are unclear, you are absolutely not wrong to assume the worst and assume it's VTAC if you're not sure. That is absolutely fine. Super fast is hardly ever VTAC, by the way. 220 range, that's almost always an SVT, and we'll talk about that a little more in detail. But if you're not sure, it is completely fine to err on the side of VTAC, and we'll talk about what to do about that in a minute. So if you have somebody who has paroxysmal SVT, that young, healthy person who comes in with that heart rate that's super, super fast, you have lots of ways to address that, some of which involves jump-starting electricity, some of it involves medications, and some of it involves just the person and their own physiology. It is really, I think the best thing to do is start with their own physiology. So start with something they may be able to fix themselves. And we have lots of ways to do that now. We had the vagal stuff that we've done forever, but now we've kind of gotten more sophisticated on those vagal things. We have things like people doing the revert method, which was that, sit them up, have them blow into the syringe, take their feet up, and then that whole tilt them thing it works sometimes, about half the time. But I'm going to tell you, you don't even have to worry about that. This new reverse Valsalva thing is fun. This person, all they do, like I have SVT. I'm sitting there, my monitor's going whack-a-job. It's going completely crazy. What I do as the patient, and you do at the bedside, is you say, what I want you to do is pinch your nose, seal your mouth, and basically breathe in for 10 seconds. Hard as you can, breathe in for 10 seconds. Nothing's going to move because everything's sealed. 10 seconds. Watch the monitor. This thing in very tiny, tiny studies has had amazing efficacy. We've tried it at our place. It's had it work sometimes. Why not? What's the harm in that? It's much easier than trying to tell the person, blow in this thing or bear down. When you tell people to bear down, they do the craziest things. They make like wacko faces and do no bearing down at all, right? It makes me wonder what happens in bathrooms for people. I don't even know. But the reality is telling somebody to bear down, not so much. Don't do carotid sinus massage. You can, super young people maybe, but don't you get anywhere near my carotids, because I have no idea if I would stroke out if you would push on mine. So carotid sinus massage, probably not a great idea, but try the person stuff first. Then you can go ahead and if you need to, try the meds. We'll get to that in a sec. And in the unstable person, SVT, hypotensive, crushing chest pain, pulmonary edema, shock that person. Do it on the higher end of the spectrum. Go for the 100 to start. Shock that person synchronized. Warn them ahead of time and go for it. Okay, and just shock them out of it. Don't futz with one or two of them. Just go for it. Go to the 100. The med we use that go to now is adenosine. I don't know if any of you have ever had adenosine, but I have certain patients that will come into we have patients come into our ER who say, "Don't you ever give me that medicine again, ever again." It basically kills you for a short amount of time. It shuts your heart down for 8 to 10 seconds. First time I used it, by the way, it went on for 20 seconds of asystole. It was like, okay, that's making me a little nervous. Make sure you use it right. Make sure you warn the patient it's going to feel like they get kicked in the chest. They may get chest pain. Warn them. It works. It's beautiful. Actually, this thing is amazingly effective. But some people really, really hate it. Some people will actually choose the shock over that thing because they hate feeling like they're dying, and that's actually technically what happens. There's ways to use it that's appropriate, but the key is it works. So do the calcium channel blockers, frankly. We use those for years and years and years. You can use those as well. Those are fine. You have lots of options with SVT. Most of the time, it's a young, healthy person. You can kind of fiddle with what you want to try. And it's really uncommon for you to be pushed to the point of needing to cardiovert. That's uncommon. So we see this all the time. We're really good at this. If you get an EKG like this and somebody hands it to you, this is a fast rhythm. This is at about 300, about almost, this is really fast. This is like 2 something. This is a really fast heart rate. If they hand you this and it's wide and you don't know which is which, assume it's VT. If you're not sure, go ahead and treat it like VT, which we'll talk about in a minute. Totally fine. This turned out to be SVT with aberrancy. That's fine too. Either way, the meds work. We'll talk about that. So another SVT, though, is this AFib, aflutter group. Now, AFib, as far as how to manage it in the big picture, what you should need to do about cardioverting, whatever, should you convert them, should you rhythm control them, that's a separate lecture. This is the rhythm part of this. And we see these 2 kinds of entities as AFib, aflutter, in lots of different conditions, lots and lots, anything from thyrotoxicosis to heart attack, renal failure, dialysis, tons of things can cause this. Aging is the most common cause, by the way, of AFib. It's just your heart gets old. It's aging is the most common cause of AFib. We see this a lot. The key is to be good at recognizing it and knowing when to intervene. So I'm going to start with flutter. So flutter is that sawtooth baseline. My atrium is just fluttering along instead, like the poor guy trying to do atrial flutter. It's fluttering along, but it's a sawtooth, and it is at a rate of 300. Your heart chooses to flutter at a rate of 300. We see this, frankly, most often in holiday heart. So we see this in people who've been binging like crazy, been drinking. You see that it's called holiday heart because it's about the season. We tend to see this, where it is almost always, in fact, it is always temporary. Nobody is walking around in the world for aflutter for days and days and days. It will either degenerate into AFib or revert back to normal sinus rhythm. And all we usually need to do with these is watch them. What you will see is a sawtooth pattern, and your ventricles can't keep up at 300, so they will actually go at a blocked number. It'll either, every other one will get transmitted, so the heart rate will be sitting at 150, solid, sit at 150, or it'll wait every third one, it'll sit solid at 100, or every fourth one, it'll sit solid at 75. If you see somebody who is sitting with a heart rate of 150 on the monitor and it is not budging, think about that being a 2-to-1 atrial flutter patient, especially in the right clinical setting. Even if it's sinus rhythm at 150, it tends to kind of fluctuate up and down a little bit. It doesn't sit spot on 150. If it sits spot on 150, worry that may be an atrial flutter patient. And frankly, we just watch these folks. They tend to just change on their own. They either go back to normal sinus or degenerate into atrial fib. So no treatment refers on its own. And I will tell you, I can't remember the last time I actually did anything except recognize that somebody was in aflutter. It is extremely rare you need to do anything. AFib is a little different. This is that irregular rhythm, right? This is, you've done the pulse check as you're walking up to the patient's bed, and you feel the heart being irregular. It's just like the guy that danced in the video. This is really common, and it's problematic usually when it's new. So it's the first onset or something triggered a new episode of atrial fibrillation, not the chronic AFib person. This is actually, that person is usually relatively different than the new onset AFib. So our treatment, first of all, the main thing to look for is why? Why did they go into this? Is it just somebody who's older, or is this a young person who's having thyroid issues? Is this somebody who is having a heart attack? I will tell you, it is not a common rhythm, abnormal rhythm in people having heart attacks, but it is seen in heart attacks. Back when I trained in internal medicine 30 plus years ago, I was trained that everybody with no onset AFib had to get ruled out for an MI. That's dumb. That's just dumb. That's like, doesn't make any sense. But if you're the right clinical setting, I have chest pain radiating into my shoulder, and I have new AFib, okay, well maybe that's associated with that. We rarely need to do anything acutely for AFib. The times to intervene acutely is when there's an acute something happening. They're in acute pulmonary edema. They're having crushing substernal chest pain. They're hypotensive. They've dropped their blood pressure because they've lost their atrial kick and they're in atrial fibrillation. Rarely, though, do we have to do something right this minute with AFib. And I will tell you, there is and if you do get into sort of the conversion to try to convert them, shock them into a normal rhythm, or drug treat them into a normal rhythm versus rate control, just know you need to know an onset time. You have to have a pretty decent onset time to decide which of those is safe. Now, one of the things I want you to be very careful not to do, and I hear this all the time, especially people that start in their careers in medicine, is rapid AFib, atrial fibrillation with a rapid ventricular response, so AFib with RVR, I must do something about. That is absolutely not true as far as the AFib being the thing you need to fix. Think about this. Let's say I'm 70 And I live in atrial fibrillation all the time. That is my baseline. I'm an AFib. That's it. My atria are fibrillating all the time, and that's what it's going to be like for the rest of my life. I'm walking, talking, my life is beautiful, I'm on the appropriate medicines, everything is great. And now I get, let's say, hit by a car. And I rupture my spleen. We had this case. And I get brought to a trauma center. My rhythm is going to be AFib, and because I am bleeding to death, I'm going to have a rapid ventricular response because that is my sinus tach equivalent. That is my physiologic response equivalent to you in normal sinus rhythm bleeding out from a spleen injury. So we've had this in our trauma center where the knee-jerk response of a surgical intern was, oh my gosh, it's AFib with RVR, I'm going to give metoprolol, and did in a person bleeding from a ruptured spleen. That doesn't do well together. Okay, that doesn't do well together. So your sophistication now as a practitioner in emergency medicine is you're going to go back home and you're going to say, wait a minute, this is an older person who's had AFib forever. They have RVR. I'm going to find out why. Are they septic? Are they bleeding? Is there a GI bleed? Are they stressed out? Are they febrile? Is it something physiologic? Because it usually is. It's a physiologic response to a stressor. So be sophisticated in this. Don't just treat the rhythm and slow them down. Treat the problem that made them go fast in the first place. So if the rate does need to be treated, you have lots of options here. You can slow them down lots of ways. It's rare that we actually need to acutely cardiovert somebody, or shock them into and try to shock them out of it. The reality is most of the time it's fix the problem if they're chronic AFib. If they're rapid AFib and having a problem from that rhythm itself, you can slow it down, okay? And if you really have to, you can cardiovert them. But the reality is, be sophisticated in this. It's not as complicated as it seems sometimes. If you're not sure if it's AFib or aflutter or just sinus tach, try a carotid, a vagal maneuver. Sometimes it'll slow them down enough to see the sawtooth in the background, or to see that fibrillating in the background, or to frankly cardiovert them if it turns out they're in an SVT. So that's a way to kind of tell the difference in what's out there. Now, one of the other SVT equivalents, by the way, sinus tach is technically an SVT if you want to be sort of a niggler about it. You can basically, I'm being specific about that. This is multifocal atrial tach. So this one, they're going to hand you an EKG. They are going to be irregularly irregular. When you check the pulse, it's irregularly irregular. When you look at why, what you're going to notice is that their QRSs are usually they're normal. They're kind of skinny all over the place, but they're irregular because the P waves are coming from all over the atrium, not from your usual node that starts this. Basically, as your SA node, it's actually all over the place. And that's an irritable atrium, usually from lung disease. So we see this in COPDers. You see P waves of various shapes and sizes. They have to be 3 or more P wave morphologies, and it's an irregular rhythm. And the way to fix this is to fix the lungs. So that's how you fix this. So that's MAT. And here's a couple of slides, or a couple of pictures to show you the differences between the ones. WPW is what scares the heck out of us. We are all terrified at that sort of rapid pathway that can take something that would normally be no big deal, like SVT, and make it lethal, or atrial fibrillation, and make it lethal for somebody. We worry about this. What you look at on an EKG to find WPW, and it's not always there, frankly. Sometimes it comes and goes, or sometimes it's hidden. We can't see it. But on the EKG, what you are going to look for on purpose is look for your delta wave, that little slurring on the upslope of the QRS. Look for that for sure. But that's not the only finding in WPW. You also can have a long QRS because it kind of widens it on the other side. It makes it look like it's wider, and your PR interval is short. If you see somebody with a PR interval that's teeny, no delta wave, normal QRS, that still is very suggestive of WPW. Those are the components of the EKG findings of WPW. Why do I care? Well, I care because what starts up at the atrium now has a kind of an alternate route to get down to the ventricles that's faster. Now, if I see somebody who is fast, they come in with a fast heart rate, and it's narrow, it means it's going down the normal pathway. To stay narrow, it's going down the normal pathway. If it starts to go down that WPW pathway, it becomes wide. My QRS becomes wide. So rapid, regular, narrow, I can treat that as an SVT. Even if somebody had a WPW on their EKG before, today it's going down that normal pathway. If it is regular and wide, though, it could be SVT going down that WPW, or it could be VT. I don't really know. In that case, treat it as VT. And what you're going to do basically with this is give them procainamide, and we'll talk about that. What you never, ever, ever want to do, ever, is see somebody who has an irregular rhythm. That means that's AFib, And they have QRS complexes that vary in width and size, and it is really erratic. They have bursts of really fast, and then it's a little bit slower. But their overall rate is high. Their overall rate is 180, 190. It can be as high as 240 in these cases. It's wide, though, and it is not regular. That is AFib going down the wrong pathway. That person, please don't block anything. You'll degenerate them into VFib. And again, don't freak out. Don't freak out. Wide complex. Think it might be VT, fine. If it's VT, fix it with procainamide. Procainamide works. It is safe. You're not going to hurt anybody with this. It will convert VT sometimes. It will convert SVT sometimes. It will slow down people with atrial fib. Grab the procainamide. It is the magic medicine if you're unsure. Here's a couple of other EKGs. Oh, by the way, that one is wide burst. Look at that EKG. Those bursts of super fast in the middle there, right by the V2, that is super fast. That's a rate of almost 300. Holy smokes, that's scary. And the only thing that can be doing that is atrial fibrillation going down the wrong kind of pathway. So you're going to basically, if they're unstable, shock that. If they're stable, you're going to give them procainamide. Here's a couple of algorithms for you, for the SVT algorithms, really good, mainly for your reference. Let's go down to the ventricle. PVCs, also very common. You may have them. I mean, you may have them right now. They're really common. In somebody who has them isolated, otherwise is doing great, we do really nothing about them. And frankly, isolated PVCs, even in somebody who's having a heart attack, we don't do anything about specifically except note them. This is the ventricle that's irritable for some reason. One of the things you want to check, though, with anybody who's having PVCs who's in your ER, especially if they have chest pain or anything that's scary history-wise, is please check a pulse ox and please check a potassium. Those are the two easily fixable and identifiable things that you can fix for people, other than something that's going wrong with their heart. Don't treat them, though, as isolated PVCs. So please do not treat them as isolated PVCs. As they become more complicated, though, as more parts of the ventricle are irritated and they start to make multifocal PVCs, we start to raise our eyebrows, but we still don't treat them. Okay, multifocal PVCs, we raise an eyebrow, but it turns out we harm more than help in trying to fix the PVC. We need to step back and fix the problem that's causing the PVC, the low K, the ischemia, etc. So multifocal PVCs are more concerning. You kind of keep a closer eye on that person. And then the thing we, of course, worry about is VTAC. And that's 3 beats in a row, ventricular beats in a row, or more. Sustained is more for a long time. Unsustained is just little bursts of it and then it goes away. All of them are bad. All of them are scary with these. And again, SVT with embarrassing is always in the differential there, but I'll tell you, in the right clinical setting, especially if it's an older person who's having ischemic kinds of symptoms, a person who's really hypokalemic, that's somebody you really worry about this being VTAC. If they're stable, so people could be sitting in VTAC playing Sudoku on their phone. If they're stable, those people just sit there and we can put them on something that converts them into a normal rhythm. We don't have to do anything wacky. But if they're unstable, we're going to cardiovert them. We're going to synchronize cardiovert them into a normal rhythm. And if they are pulseless, we're going to treat that like VFib. We're going to basically unsynchronize and we're going to just cardiovert that person. One of the last weirdo rhythms that we see is torsade de pointe. Now, torsade de pointe is, I'm sure many of you, maybe not all of you, but many of you have seen this, and you look on the monitor and it is completely obvious that this VTAC is not a normal VTAC. Because it looks, to me what it looks like is, you know those crepe things you hang when people are having a party and you twist them so it looks kind of twisty? It looks like that on a monitor. It's bigger, smaller, bigger, smaller. It looks like sort of a twisted piece of crepe paper. What we have found with torsade de pointe, which is very rare, is that it is usually a toxin-related rhythm, often something that has caused something to be a QT prolongation issue. So we see this with people that had antidepressant overdoses back in the day. Certain drugs will prolong the QT, and if they go into VTAC, they may go into this instead. The treatment for this, the main treatment of this is first grab bicarb. You don't think about using bicarb, but bicarb actually takes care of the acidosis that we see with some of these particular drug overdoses, or will shift the drug itself, and grab magnesium. So the two things that you, normally with VTAC, you're using amiodarone, lidocaine, shocking. With this one, shocking doesn't work, by the way, won't do a thing, but give mag and go ahead and just bolus it 2 to 4 grams, just get it in there, and get an amp of bicarb, and push an amp of bicarb and see what you can do. Not common, but once you notice that bigger, smaller, get those extra drugs. The last thing we're going to talk about is Brugada. So Brugada didn't exist when I trained. It was a no big deal thing. It was a nothing. We didn't even know it existed. But we did know that young people tended to drop dead sometimes, and we didn't know why. We knew myocarditis could do it, but some of these people didn't have myocarditis. Why were they just dropping dead? And this came to my attention when we had a resident who post-night shift was up in the OBGYN floor where he was post-night shift, put his head down on the table in cardiac arrest. The OBGYN resident recognized it, thank God, intubated it. God, I don't even know when the last time that OBGYN resident had intubated anybody, intubated him, and it turns out he had Brugada. He was a young Asian male. He had Brugada. So Brugada is one of the things in syncopal or pre-syncopal, or I think I have palpitations kind of people, you look for on that EKG. I'll show you a picture in a second. This is a channelopathy. This is something that is only fixable by an AICD because they need to have a backup for when their heart does this, and it tends to be familial. So it's something you need to be aware of. It looks like this. So you go to V1 first. And by the way, if you can't remember this, just Google it. Look, Google images of Brugada, and it will show you this. This is V1, the precordial, V1, V2, but V1's the big one. It looks sort of like a weird right bundle. Kind of looks like a strange right bundle. You see that, and somebody says, I think I fainted, or I get lightheaded sometimes, you're going to call a cardiologist. Absolutely. If you see it in somebody who's asymptomatic, you're going to still call a cardiologist. They can still go home. They probably shouldn't drive, frankly. And that cardiologist is going to evaluate them whether they need anything done. So who knew that in 30 minutes and 45 seconds, we could go through all the dysrhythmias. So thanks a lot. I'll see you back in a half an hour. Oh, Chip is here. You guys get to meet Chip. Awesome, 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 Chip. Hi. It's up there. Mm-hmm.
It's muted. There you are.
Oh, there we go. Okay. Easy fix. All right, good morning. So I'm going to talk about clinician collaboration. So my name is Chip Lang. I'm a PA that works in rural Missouri. I primarily work in kind of the south central part of Missouri and have been at the same position for about 8 years now. And in that role, I've got to do quite a few different things and obviously get to work with lots of different patients and physicians and then other PAs and NPs as well. So in that, though, I've worked at different departments across this country. I also work in EMS still sometimes because I'm a sucker for punishment. So there's lots of different things that we'll kind of talk about, and the first one is going to be about collaboration. When it comes to collaboration versus, say, if you're working in primary care, a lot of times you're working with one or two physicians that you're collaborating with frequently. Sometimes you might be part of a bigger group, but usually you're going to have someone who's kind of your main person. In emergency medicine, it can be very different because you're doing shift work and you're often going to be working with different people. You will still usually have a primary person as your collaborator, but depending on the state, depending on the laws, this may be someone that you see every once in a while. This may be someone that you work with almost every shift. And I've done both of those types of things. I've definitely been in the place where I think I've met the collaborator just a couple of times in the entire time I worked there, versus the one I work with now. It's usually a couple of times a week or so. I'm at least working part of the shift with them. And that can be a really positive thing because you get used to certain people and you get used to certain practice patterns, but it can also be a real challenge because not only do you have your background, your experience, and what you like to do in certain situations, but now you're also working with what physician A prefers, what physician B prefers, and sometimes that can be a real challenge because you have to sometimes maybe do things a little bit differently or present things a little bit differently on a case-to-case basis. And overall, I like it because usually, especially as long as I've been at the same place, I've gotten into a routine, and most of the physicians, they pretty well know, my practice patterns and what I'm doing, but that's something that's earned over time. That's not something that usually happens right away if you're in a new position. When it comes to also department policy, this can play a huge role too, because there are certain types of, there are a lot of different hospitals that you work at where they may say you can only see ESI levels 3 through 5, or maybe even only 4 and 5s, versus where I'm at where I can see 1 through 5 and it doesn't matter. just see the patients and get the patients through and take care of things. But each one's a little bit different, as well as who do you have to collaborate with and when do you have to collaborate with them. That's something that is going to be really dependent on each department as well as hospital policies. So talking about PAs in emergency medicine first, overall, and these numbers are changing, and probably by the time we'll have this, next session, our next conference, we'll have new numbers, but there are over 125,000 PAs in the United States with about 287 programs, although I think that just went up again. And there's about 10,000 PAs that are graduating each year. About an eighth of them are working in emergency medicine. And that's been actually a pretty decent increase since 2016. And the average age for a PA is 38. The majority of PAs are female. That's kind of shifted over time. And in emergency medicine specifically, you can also get your certificate of advanced qualification or added qualification, and that's a CAQ, and that's also awarded by the NCCPA. The NCCPA is the accrediting body for PAs and who you get your certification through. Most states still require that you maintain certifications. Some states, and that number's gradually increasing, are no longer requiring you to maintain certification, just that you have to maintain licensure. The tricky thing with that is if you decide to move at any point to another state or work in another state, if they're ones that require certification, you're kind of out of luck in a lot of cases. So just something to kind of know as far as that goes if you're moving to a new state or you're planning to do something later in career. But generally speaking, for PAs, we take the PANS the first time to pass, and then the PANRE, which I just signed up to do the PANRE LA, and we'll see how that goes. I think Mike did the same thing. He just signed up for it, so we get to take it together and figure out how this goes. But the CAQ is something that I did, and it's one of those things that sometimes can help you actually increase your pay. It might increase sometimes what you're able to do. Other places, it may not necessarily change your practice at all. When it comes to NPs, there's a lot more NPs than there are PAs. There's over 400 programs, and there's over 325,000 licensed NPs, and about 36,000 new NPs a year, so a huge difference compared to the 10,000 PAs. The numbers are also a little bit harder to track down, but it's about 7,500 to 9,000 NPs that are in emergency medicine. There's also an ENP certification that started in 2017, and sometimes that can be a little bit tricky because there are some hospitals, some policies where if you have your ENP but you're not your FNP or your PNP, that you might end up having to be limited with the patients that you can see, stuff like that. A vast majority of NPs are women, but again, those numbers are changing with time, and then the average age is about 49, which one big thing with that is that NP, kind of with how it's set up, is the fact that this is usually more of a second career or at least a later career. When it comes to the actual teamwork side, so to be a successful team, because you're working with a physician here, whether it's directly or indirectly, it really is key to have good teamwork, good communication, and one of the biggest things that we can stress, and one of the reasons why you're here, is to stay up to date on the guidelines, best practices, because it's one of those things you might, depending on the situation, be more familiar with a certain condition or treatment than your collaborating physician may be. And this is something that I see a lot in my own clinical practice, is that there are certain things that I manage a lot more, or I see a lot more, that a physician will actually ask me questions about, and then there are certain things that I'm less comfortable with or I have less experience with, I'm going to ask them about. And that open communication can easily go both ways, and is something that can help be built if you have the good evidence-based practice guidelines, if you have good knowledge, if you're in a good rapport. And part of that can also be getting good feedback and having positive experiences overall. But as I mentioned, it's really important to know what your laws are and what the hospital guidelines and policies are as well, because this can very much dictate your practice as far as what you can or can't do, and it varies widely across the country. Speaking of, when it comes to this is kind of a smaller graph. You should be able to see it better in your notebook. But when it comes to ESI levels, and this is a study that was done where it basically compared different groups and helped see, okay, how much of your time, or based on ESI level, is this something that the NP or PA could see, or could they not see? And if they could see it, did it have to have physician review in real time, or could it be more of a post hoc, or how did that work? And if you'll notice overall, and notice they're using supervision requirement here. Supervision versus collaboration. Collaboration is becoming more the thing over time because it's there's a couple different reasons why that is, but collaboration is truly more reflecting the teamwork style of what PAs and NPs are doing across the country in emergency departments versus someone's truly supervising you all the time. Meaning that, you know, some people take that quite literally as like looking over your shoulder, and in some cases, depending on where you're at and what you're doing, that may be the case. What I find most particularly interesting is that if you look in that kind of far left category when it comes to supervision requirement, that's the third row down. It's the fact that there's real-time physician presentation for all patients, and if you think about like workflow and being able to do this, if you have to talk to someone about every single patient, which in some of these places, you know, even ESI level 5s you have to talk to someone, and they also have to see the patient. That's again a huge burden. But some places do that for other reasons, and part of that revolves around incident 2 billing, which I'll talk about here in a few minutes. But it is something that, again, it's good to know in advance, especially if you're a very experienced PA or NP in working. This can really kind of drag you down. It might be an annoyance, but if you're in, say, more of a residency program or you're fresh out of school, this could be really beneficial because sometimes you might pick up little things that could be recommendations from your physicians. And you'll also find that sometimes this is going to be in either really academic institutions or really rural institutions where you might be doing this. And that's where I've traditionally seen it the most, where you have this, every single patient, the physician also sees. The other kind of interesting little graphic thing we have, the little table, is this. It's about procedures, and it's the percentage of EDs in which there are various procedures that were listed and what could be performed independently by at least one PA or NP. Some of these make sense why you're not seeing it a lot and why there's lower percentages. For example, when it comes to sedation or central lines or intubation, thoracentesis, stuff like that, those are lower percentages. A lot of those are single digits that I just mentioned, versus ones that we are kind of more bread and butter type procedures, you know, laceration repairs, incision and drainage, splinting or reductions. Those are ones that you'd expect that, generally speaking, you could do that anywhere. But again, there's kind of interesting percentage of the fact there's nothing that's 100%. Laceration repair is pretty darn close. It's 96.6, but that also means that about 3.4% of these emergency departments that were surveyed, they couldn't do it independently. So at least in some form or fashion, someone had to collaborate or supervise that procedure, or at least be involved in some way in the care. And I think that goes back to that last slide where we're looking at it and we're seeing that, you know, there are some places where, probably because of incident 2 billing, they're generally seeing all the patients as well. When it comes to the setting, there are, generally speaking, more urban and suburban hospitals versus rural. But what you may notice here is that overall percentage-wise, in most EDs, if there's PAs, there are NPs and vice versa. There's not a ton of them that only hire PAs or only hire NPs. With the exception being, you might notice that in the rural emergency departments, the NP percentage is higher. Part of that is because of some states with independent practice, and so that's a major advantage for nurse practitioners in certain sites because they can function without physician supervision or collaboration, and that may be why you see the higher numbers there. Versus in suburban settings, you're going to see a lot more places that if they only hire one or the other, they tend to hire more PAs. But overall, most departments are going to be hiring both. So this is another kind of, again, graphic sort of thing. Can be a little bit hard to see on the screen here. But the key points are as far as how do you have effective team practice? How do you make this work? And a big part of it is, again, sharing goals. So knowing from the beginning, what are things that are expected of you, how do you do them, and what does that mean as far as the overall team strategy? And that includes having those clearly defined roles. What are you able to see? What are you not supposed to see, or maybe can't see totally independently? And then what procedures can you or can you not do, whether that's independently or with some type of collaboration or supervision. And the shared knowledge part is, again, a really beneficial thing. This is one that I find particularly interesting in my setting and with other places I've worked at, is because the fact that this truly can be shared knowledge. Again, I can give advice to my colleagues, they can give advice to me. It doesn't matter if it's a PA, physician, NP, we all work together. That also ties in, though, with having that effective but also timely communication. So if it's someone who's higher risk, especially if it's someone that you're not really sure about, or you want that feedback, to actually do it in real time versus saying later on, oh, hey, by the way, this is what I did, should I have done something different? Like, especially in those high risk, high stake patients, it's good to get the collaboration early. And fortunately with emergency medicine, even if there's not a physician on site, there's someone you can collaborate with very closely nearby. But also having that mutual respect is something that's built over time, especially if you're a new grad, and I assume many of you are, you're newer at least to emergency medicine, that's why you're taking this, so you can build up those skills, is that it can take a little bit of time to help build that mutual respect. But again, that's something that can be achieved by doing these other steps, by sharing information, by working closely and coming up with goals, and overall having an optimistic attitude and being very can-do as far as how your behavior is. When it comes to collaboration, this is something I just kind of alluded to. There's essentially kind of three aspects. So there's prospective supervision, so that's planning in advance. That's through writing and reviewing guidelines or policies that, as the PA or NP in the emergency department, we expect you to see these types of patients and only these types of patients, or maybe it's you can see these patients independently, but other patients you need to see in collaboration. And then there's more of the concurrent supervision. That's when I'm talking to you in real time and going through this. This is something that can, again, be department-based or can be entirely ad hoc, is something that is decided by you on a case-by-case basis, which is how my department that I'm currently at works, is that, again, I can see ESI 1 through 5, I can do whatever procedures, and then I decide if I want to get physician involvement in that case. And usually it's one of those kind of just quick touching base, hey, this is what's going on, just so you're aware if you want to see this patient or if you have any suggestions. And that's something that's not set by our department, it's not a requirement by our department, and that's something that we get to decide on a case-by-case basis. The last one is retrospective supervision. This is usually looking at your chart after the fact. These can be helpful for feedback purposes, but if you're really wanting to know how to improve your care, generally speaking, you want to do that as more of a concurrent supervision where you're talking to them in real time, and that also provides the best care for patients, because ultimately that's what we care about. We want to be able to provide the best care for our patients, and part of that is understanding that our patients deserve the best. If it's one of those where we're in the situation we can adequately take care of this, we're not concerned about needing specialty help or assistance, then we take care of it. But if we recognize this maybe is outside of my typical boundaries or outside of my comfort zone, getting someone who that does fit. And that may not always necessarily be your collaborating physician in the emergency department either. That might be, if it's an OBGYN related case, is talking to the OBGYN. Depending on where you work at, sometimes though, that may be where you have to talk to your collaborating physician first before you talk to the OBGYN. That's required in some places. I've noticed more and more over time that's less of a thing, but that still does happen where people may have to talk to the physician in the department first before they can talk to a specialty. The other thing is that understanding that we're all responsible for all the patients, but the physicians, especially in that collaborative or supervision type basis, are in a much bigger predicament. We need to respect that, because overall that physician is taking care of all the patients, whether directly or indirectly, as we are in many ways under the law an extension of their work, which again can be a bit hairy and can sometimes make it hard for, if there's a lawsuit, about how involved is that physician, what amount of liability do they carry there, stuff like that. But just keep in mind that if there's any real possibility, if there's any real concern, it's probably best to get the physician involved early, because they can be on your side, you can be working with it together. Something that should be pretty standard, but is not always the case, and it's something that is good to check with your individual departments, is what's the policy for if I request a physician to see a patient? I don't do this a lot these days, but there are some times where I may be seeking some friendly advice or reassurance that, kind of just confirming that the care I'm doing is appropriate and that there's nothing else that they would do differently. And every now and then something will happen, they'll make some suggestion that I honestly don't think makes a lot of sense. And I'll talk to them about my reasoning for why I'm thinking maybe something should be done a certain way. And if they still say, nah, I think this instead, and it's something that I either feel like I'm uncomfortable with this because I don't think this is best for the patient, or maybe we're just not communicating correctly. Maybe what I'm trying to say is not the same as what is coming out and being interpreted by that physician. I asked them to go see the patient. I said, let's just go together. Let's just take a look at that. And 90+% of the time, once we are in the room together and talking, it becomes very apparent that, oh, this is what you meant, and now we're in agreement, or there's very little modification as far as the plan goes. And that's something that, again, getting that established rapport, a lot of times we'll take care of it. But I'm cautious, but at the same time, I do it when I find it appropriate, of saying, I really want you to see this patient because I think now we can get on the same page here. When it comes to the documentation level, this is also something that should be decided by your department, but a lot of times, most but not all my physicians will make their own separate note if that happens, if I have them see someone or they're involved in some way in the care. There are a few that would just prefer I make the note, but I make sure that they have the opportunity to review it themselves in case they want to say anything different. And it's really important, because what you want to do is you want to make sure you're both on the same page, because if something comes up later legally, you don't want to be in a he said, she said situation. Now attorneys are getting involved because they love those types of things. I have the unfortunate reality of both my parents are attorneys, and then my wife, after she became a teacher and then wanted to be a principal, after she was a juvenile officer, is now an attorney. So I recognize that I'm always wrong and I'm never right, and that's not only because she's my wife, but also because she's an attorney and she can argue every point she wants to. So with that being said, I recognize very much how attorneys can work things in a case, and your documentation can either protect you really well or it can totally hurt you. And that's something that, kind of skipping ahead here, that's a few things ahead. But again, your documentation is key, and it's all about providing the appropriate level of documentation, making sure you have things specified in a way that makes everyone sound like we're on the same page. As this also goes, sometimes a barrier to good communication or good relationships, although I'm seeing in the room here, I think pretty much almost every generation besides maybe the traditionalists in here. But we have, everyone from really young to much more later in career that's here with us. Notice I didn't say old, so don't count that against me. But we have people who are here with different levels of experience and background, and that's not just about being a PA or NP or physician. That's also about the fact that you come in with different life experiences. And so me up here on the stage is a little bit different than Diane up here on the stage, is different than Mike or Rick or anyone else. And so I try and be very mindful of that. I understand that some of my colleagues may not appreciate generational differences, but I try to, but also recognize the differences of our training. The fact that, while PAs are traditionally in a med school model, it is different than medical school, which is different than NP school, and so on. And so I try and take those factors into mind when I'm having conversations with my peers to make sure that we're all on the same page and that I'm going about this the best way I can to make sure that we're having a positive interaction. So something we've kind of beat around the bush and said a number of different ways, but it's worth saying it again. Know your hospital policies, know your state statutes. I can tell you in Missouri, where I live, there are some funky rules that exist, some funky laws. But by reading them, and knowing how to play the game, I can make sure that I'm still providing best patient care and making sure I'm within the boundaries of the law. And that's something that varies widely state by state, as far as even something as simple as how much time does your physician have to be around. For example, in Missouri, they improved the collaboration law in some ways, but one thing now is that I have to work, or the physician has to work a half day every 14 days I work. And it's not like a calendar fortnight type of thing. It is literally meaning that 14 shifts, that at least half of one of those shifts, the physician's also working. That is my primary collaborating. So that creates sometimes some scheduling nuances that usually, again, because we recognize it, it's pretty easy to work out. But is very different than any other state I know. I don't think any other state has this kind of funky law here. There's definitely ones about percentage of time and stuff like that, or they just say, hey, you got to be in so many miles of one another, or there's none of that. And again, this is something that's really important to know, because you want to make sure that even though maybe your employer should know this as well, ultimately, if something comes up and they say you didn't have adequate collaboration or supervision, that's going to be on you. So it's important to make sure that you follow those rules, those laws. Also, it's really good to know reimbursement and billing and stuff like that, not necessarily just because of the fact that there are some places, the first place I worked at, we did our own billing, like we had to decide our own CPT codes and stuff like that, which is a nightmare to try and figure out when you're fresh out of school and trying to know how you can bill for certain things. But it is important because it makes sure that you're doing the right things documentation-wise as well. But also, when you're being hired, make sure to clarify, are you an employer or an independent contractor? This is usually something that you're going to figure out right away anyway. But look at the IRS guidelines, because a lot of people who are being hired as independent contractors are not actually following the IRS guidelines for, you probably actually should be considered an employee instead. And that's something that can be pointed out and can be really beneficial for you to get benefits, or maybe to negotiate pay or negotiate, again, responsibilities and roles. Speaking of kind of the different things that you have to negotiate, one is going to be about insurance. Now, usually this is something that's pretty standard, covered across the board, like your employer should be taking care of that. Some people are getting their own separate insurance, or in the rare cases have to go find their own insurance. Especially in those cases, it's really important to understand the nuances of liability coverage. And so there's two main types. There's occurrence-based and there's claims-made. Occurrence-based is much better because you don't have to worry about tail coverage. Claims-made, it's the big thing there is that, let's say you recently changed employers, so you changed your insurance, but you got sued after you switched. If you didn't have tail insurance and you had claims-made, you're out of luck. But if you have occurrence-based insurance, when you made that transition, if it was still with insurance A and now you're with insurance B, but the alleged liability is back then insurance A will still cover you, and you're still protected there. But that is something that is a bit of a nuance, but it's really, really important to know. So double check. This is something that check with your employer, contact whoever, send them a quick email and say, hey, can I get my COI, which is a certificate of insurance? And that's something like email right after you talk, like after this talk or with the break or whatever. If you don't have that on hand, you should. And on your certificate of insurance, usually it'll specify if you're occurrence-based or claims-based. And that way you know what your liability limits are, because that's something else that's really important, is making sure you have adequate coverage, which is usually about $1 million per occurrence, and then $3 million aggregate is kind of the standard in emergency medicine. When it comes to coding and billing, again, we've talked about this, but it's important to be able to document adequately for not only to protect yourself, but also to promote billing. One thing to know is after January, is basically starting January 1st, medical decision-making, or MDM portion of the chart is going to be the part that matters the most. I don't know if we've already talked about that yet in this conference. I think it comes up at some point here. But this is really, really important to know because MDM is something that will help protect you in many different ways. It's helped me a number of times with things that have occurred later on, and it is truly something that's valuable and important to know. But something else that may sound silly and is probably something you've heard plenty of times before, but truly important is be nice. Be a good person. I've known some horrible, physicians, PAs, NPs as far as like clinical care goes that have never been sued because they're incredibly nice. And I know people who are incredibly intelligent have been sued multiple times because of the fact that they're not as nice. And having a sincere thought, being able to talk to people, and having that good demeanor really makes a big difference. Sometimes where they're going to be much more understanding of mistakes or if things happen, and that really does make a big difference. The other thing to also keep in mind when it comes to billing is that incident 2 part that I was talking about. So incident 2 is also known as like a shared visit, but basically where a physician also see the patient. Really important, they need to be able to reflect in the note about how the physician was involved in the care, whether they also saw the patient, if they did any procedures with the patient, so on. But there needs to be clear documentation there and a clear distinction of what the PA or NP did and what the physician did. Otherwise, instead of 100% billings, CMS generally recognizes that like 85%. There is an exception with the COVID emergency. Almost finished here with the liability claims. This is just another table showing that when it comes to lawsuits, emergency medicine is generally in the top 3. So welcome to a field that gets sued a lot. It's not unsurprising if in your career you get named in a lawsuit at least once. It's a very nerve-wracking experience. It can be very frustrating, but it is something to recognize. Also, it's one of the 3 highest payouts with successful lawsuits, and that's a beast all of itself, but it's important to recognize that this is a high-risk game. We take care of a lot of sick people. They don't always look sick at the time, but that's why it's so important to be able to document adequately that this is what's going on. Another thing that I'm just going to briefly touch on here is that there is this elephant in the room, if you will, about physicians, and there was an ACEP 2021 workforce study which depending on how you want to interpret it, can make PAs and NPs sound like the bad guys and taking away everyone's jobs. And what's realistically occurring is probably not that, because again, we're working in a team environment. We are fulfilling a very important role as PAs and NPs compared to our physician colleagues, but recognizing as well that because we are generally paid a lot less and there's a lot more of us in a lot of different settings, when it comes to especially for-profit agencies, they like that. They want to increase their profits. So there is a little bit of contention there, but it's important that we recognize that we're team-based and we're not here to take anyone's jobs. We're here to fulfill a very specific role, and this is something that can sometimes show up and kind of even fester in different departments and can create some apprehension, but this is something that you can easily address at a local level too. Overall, here are some additional resources that you can use later, including SIMPA and AAENP, which are the emergency medicine specific ones for PAs and NPs respectively.
Thank you, Chip. Always a good talk. That last slide I want to address a little bit because it did cause a pretty big brouhaha when the workforce study came out, and we had the first time ever actually at our program where we had residents who had trouble getting jobs out of residency, and it led to a bunch of anger. And the reality is that we are a team, but experience matters. So in fact, I have to tell you, after 30 years plus in emergency medicine and 2 residency trainings before all of that, I still am, and we'll talk about this, PE is probably one of the biggest ones, I am incredibly humbled and terrified on a regular basis walking into that emergency department, even with that much time under my belt. So part of our working as a team is for all of us individually to be as good as we can possibly be, keeping up on the literature, reading the things we need to know, asking our colleagues questions, finding the podcasts that help you, coming to conferences like this, and then really getting the experience under your belt. We've been teaching this now for a long time, almost 10 years. Actually, 10 years I think is this year. It's not infrequent that I will have somebody come to me afterwards who's a new grad who will ask me a question like, how do I get a job in a level 1 trauma center? And my answer is why? Because it is a really gnarly place to be in a level 1 trauma center. And one mistake is devastating to you and your patient. And the toll on you for making a mistake, especially once you really step back and realize you may have gone beyond where was your comfort zone or where you should be at the time, is really awful. So part of this is, and I will tell you, you are often put in positions, especially the advanced practice clinicians in the room, not infrequently put in, I have other questions that come up to me. It's like, what do I do if I'm put in a position I'm really uncomfortable with? Like, what if they tell me to do something I've never done before and they just say, go do it? Well, that's not okay. That is just really not okay. And for you to ever end up in a situation where you're taking care of someone you're comfortable taking care of, or you don't really know what the answer is, we have to collaborate. So this idea of workforce things, the workforce thing is going to go away because all of my colleagues my age that had 5 or 10 or 20 years left in their careers are quitting. They're done. They are fried. They have had it. So the reality is there's going to be plenty of jobs for everybody out there. ER numbers are still going up, where people still off, hanging off the rafters. So keeping this we need to be collaborative and respectful of each other. Anyway, that's my 2 cents worth of listening to that, because it is an amazing job we do, but man, is it humbling, and can it scare the crap out of you. Okay, that's live streaming. Get rid of that on the recording. Okay. Let's talk about PE, because frankly, this is the diagnosis that is the most humbling of all of them out there, I think. Because PE is really common, common enough, you will see them, lots of them. It is wily, it doesn't read all the textbooks, it doesn't do all the things we want it to do for it to make our job easier. And we can't miss it as far as somebody who has a significant PE. And if we try to just, let me just treat somebody because I'm not exactly sure, you can't do that, right? I can give you antibiotics for, I'm not sure if it's pneumonia or not. That's not going to hurt you. I give you a drug that is the most lethal drug I can prescribe, has the highest number of lethal side effects, which are these anticoagulants, either at home or in the ER, in the hospital. This is a tough one. This is a hard road to hoe. So let's talk about it, because you will walk out of this room at the end of this talk with a way to approach it where when you miss one, which you will, no matter how good you are going to miss at least one PE in your life. You will. Just absorb that into your DNA. When that happens, you will know you did a reproducible, explainable, defendable, medically solid approach to the person that might have a PE. So that's what you're going to walk out with at the end of this half an hour. So why do people get them? So people get PEs because of Virchow's triad, which we all learned in school, except that clinically it totally makes sense what Virchow's triad is and what it means for your history and your exam and your testing. So Virchow's triad means that there's some reason the blood isn't circulating particularly well. So it's that person in the cast that's at home in bed, or the person's post-op that's in bed. It's people whose blood doesn't circulate terribly well in the first place, or is kind of sludgy blood, so COPD or CHFers. That's the sort of the circulation part of this, the blood stasis part of this. Endothelial damage. Something has to happen to your endothelium is this lovely, smooth, slick, everything goes by it just fine until something nicks it or something interrupts it, where now the platelets go, oh, whoa, dude, I've got to fix something here. This isn't good. So trauma certainly does that, absolutely. Operations do that for sure. Smokers have irritable, basically, blood vessels. That's why they get atherosclerosis. Smoking is a risk factor for atherosclerosis. So those are the things that damage your endothelium, but we do it too, right? We put in IV lines. So, and little IVs are no big deal, but the one I send you home with, that one is a big deal. So the people that have PICC lines in are the ones going home with these, getting home antibiotics, et cetera, are the ones that have that endothelial damage that we do to them. So they're at increased risk for clotting. And then finally is the hypercoagulable states, which we know the 1, 2, and 3 is cancer. Cancer, cancer, cancer. Hypercoagulable states for sure, but other things will do it. Pregnancy is a relatively hypercoagulable state. Lupus increases the risks of clotting. Certain other infections do, including COVID. So we all know COVID did this, right? We were all seeing like, what the heck is happening with these clots everywhere in people? What is wrong here? And we know that you're increased risk of clotting for probably about 6 months after your initial COVID infection, or your recurrent COVID infection. So COVID is also a risk factor for hypercoagulable state. So these are the patients that you're going to think about somebody having a PE. Now the problem is that if somebody has a PE, their symptoms are pretty much non-specific. There are very few things that are specific to a PE. So they often are short of breath. There's a great sort of story of somebody in an audience like you watching somebody like me give a lecture, but the person up on the lecture stand was kind of seen just breathing a lot while they were giving their talk. Seemed just kind of short of breath. So the person in the audience came up afterwards and said, are you having trouble breathing? You just seem to be having trouble breathing. And by God, that person on the lecture dais had a PE. So it's shortness of breath is one of this. But shortness of breath is really common. We see this for lots of things. Chest pain. If it's abrupt onset, severe pleuritic chest pain, okay, that's great. But it's not always that. Sometimes it's vague. Sometimes it isn't always this sort of standard thing you learn about in the textbook. Syncope, they don't get syncope often. That's a massive pulmonary embolism, and there's plenty of other reasons to think about PE in somebody who has there are other findings in PE in a syncopal person if the PE is the cause of that syncope. But the tachycardia, lots of things cause tachycardia. Tachypnea, lots of things cause tachypnea. If they have a big fat leg, I love that. That would be great. I love that. But it can also cause wheezing or rales. Well, look at a jillion things that cause wheezing and rales. It makes it really hard. It can cause a low-grade fever. Temperature of 100, 100.5, if it's infarcting a lung, it can cause a low-grade fever. And massive ones can cause shock. So I would love it if every PE patient basically got off a 12-hour airplane flight with a gigantic leg, grabbed their chest with pleuritic chest pain, had a PEA arrest, and that's like, what else could that be but a pulmonary embolism? They don't do that, right? They don't do that. So we have to have some sort of nuanced way where we take the things that are helpful in making the diagnosis and apply them. Are the tests helpful? So I will tell you, a normal chest x-ray is the rule, not the exception in pulmonary embolism. In fact, if you have somebody who comes in who sure smells and sounds like a PE, sudden onset pleuritic chest pain, shortness of breath, tachycardia, and you get that chest x-ray and it's normal, that should worry you. That should worry you. It's like, why are they short of breath? Why are they tachypnic? Why do they have pleuritic chest pain in this totally normal x-ray? There's no pneumothorax there that's causing this. Why would they have that? Maybe it's a PE. So abnormal x-rays are not common. We still get them all the time. That's fine. The most common abnormal finding is atelectasis because it hurts for me to breathe, so I kind of splint when I'm breathing, and I get a little bit of atelectasis in the lung, usually the side that's hurting, but not, or that has a PE, but not always. So that's if you find that. But you will look for certain things that might help you. Of course you're going to look for certain things that might help you. Things like, the Hampton's hump that we learned about and the Westermarck sign. So Hampton's hump is basically infarcting lung. Non-perfusing, collapsing, infarcting lung. That's what that Hampton's hump is. Westermarck sign is the cutoff of a vessel where the clot is big enough that you can actually see on a chest x-ray that this vessel goes out and just stops. That's the PE that's sitting out there. And this poor bugger needs to come to Vegas. Whoever had this chest x-ray taken has both on their x-ray. That is remarkable. If you see this, you should come to Vegas because this is rare to see this sort of thing. This is just not common. But look for them because if it's there, it might help you. I'll tell you where these things get you in trouble though. Let's go back to this one, that one on the left. So you see this big old, what looks like, that looks like an infiltrate, and somebody's short of breath, and they have a temperature of 100.5, and they're a little bit tachypnic. You're going to call that pneumonia. You won't necessarily be wrong, but we're going to talk about the algorithms to make sure that we think about PE and when you should go further. But that's where we get burned on these things. And actually, Stuart Swadron, who is a fabulous educator, part of the MRAP team, great educator, tells a big story on himself about getting burned by an X-ray like that, calling it pneumonia when it wasn't pneumonia, it was a PE. How about EKGs? Will the EKG be your answer? And we learn in school, by the way, just as an aside, they tell you a whole bunch of lies in school. Just telling you. When you get out in practice, you're like, that's not true. So they tell you about this S1, Q3, T3 thing, right? They tell you about this S and V1 and the Q and the T, inverted T in V3, in lead 3. Like they tell you about that. And frankly, it does happen. It doesn't happen very often. It's another one of those go to Vegas and bet a bunch of money kind of things. If you get that, it's not common. If a PE is big enough, it will cause right heart strain in some of those findings. It will do this EKG this is if you had this massive PE. This is the kind of stuff you would see. You'd see the S1Q3T3. You would see right heart strain because, again, that right heart is saying, whoa, wait a second, I got this gigantic PE I'm trying to push against now. It's blocking me trying to pump blood here. But this is not common. EKGs are usually either normal or sinus tach. That's what you'll see on the EKG. So chest x-rays don't help me a ton. EKGs don't help me a ton. So, of course, and blood gas is going to help me, right? No. And this, by the way, this has been 20 years in the literature. Basically, blood gases, all they do is hurt you because people with PEs often have a normal blood gas. And what we do, just the way we think, the way we make medical decisions is, I'm worried about PE, but oh gosh, look, that EKG is normal, that chest x-ray is normal, oh look, that blood gas is normal. I don't have to worry about it anymore. Oh yes, you do. It's still, this test is normal in a lot of patients with PE. So this is, again, back to my internal medicine days, we would basically get all snotty about it if patients didn't have an abnormal ABG. And say, well, it can't be a PE. Of course it can. I was taught that. I was taught that you had to have a big AA gradient. You don't. We know people can get significant pulmonary emboli and never change their blood gas. So blood gas is out. In fact, don't get it. It may lead you astray. What is helpful, used correctly, is the D-dimer. Now, the key to the D-dimer here, the reason D-dimers go up is a clot, as it breaks down, releases this D-dimer thing we can measure. Cool. Lots of things, though, raise your D-dimer. Even just starting an IV in somebody will bump their D-dimer a bit. And we know that the list of things that can have elevated D-dimers as part of the condition or the problem going on with the patient is long. It's not just pulmonary emboli. It's anything that causes clotting somewhere that breaks down. So it's not specific to pulmonary embolism, which means that you have to use it in the right clinical setting. Do not order a pulmonary D-dimer in somebody who comes in with the following story. Hi, I'm 25. I've had asthma since I was 6. I'm having some asthma today. I'm feeling short of breath, and every time I get my asthma, my chest hurts a little bit when I breathe. That is asthma. If that person, however, says, I'm having some asthma, but it doesn't seem like my usual asthma, and, for the first time ever, it really hurts when I breathe right here. That's different. That's different. You have to make a clinical decision before you ever order that D-dimer in somebody, whether you think they even are on the possible PE treadmill. Okay, and that asthma person, that first one, that is not asthma. You're not even going to go there. You're not. That's not a PE. That is asthma. That asthma person, that's it. But if that asthma person has something that really is not typical for them, that really fits PE, now you're good to go. So never order a D-dimer until you already risk stratify the person first. Really important. Because and I'll tell you what happens a lot for us now, is because we're in so wacky clinical situation where people are hanging off the rafters, out at triage, it may get ordered in somebody trying to help you. Right, so they're trying to help expedite the patient's care. And, PE somewhere maybe in the differential. So I'm going to go ahead and order that D-dimer. This is that road to hell is paved with D-dimers, BNPs, and troponins that get ordered out in triage. Because then you're stuck in the back with these labs. It's like, it's not this. What am I doing with this stupid lab? If somebody has, it is that asthma young person. It's like, it's asthma. Somebody has ordered a D-dimer and it's elevated. What you do is you say, test ordered at triage, patient's clinical history and exam consistent with strictly an asthma exacerbation, highly unlikely pulmonary embolism, and you stop. You do nothing else. You do not pursue the number. Remember, the patient always rules. The patient always rules. So, no likelihood, don't order it. But they get into that, I need to think about it, let's do it. But how do you decide? Oh, by the way, the D-dimer itself, as you use the D-dimer, we know that certain things affect your D-dimer. For instance, age. So we have cutoffs that we all use for our positive or negative D-dimers at home. That's the general population. That's kind of all comers. But let's say it's somebody who's 65. That person's D-dimer, as they get older, or they're 75 or they're 85, that person's D-dimer, what's a normal level for that age, goes up over time. So if you take somebody who's 80, who has a D-dimer of 500, your cutoff of 500, that actually is normal for an older person. You can use an age-adjusted D-dimer when you use a D-dimer and apply it in an older person. And that is basically their age-specific. Is less than 50, you use the cutoffs that we use at home, our normal stuff. 50 and older, it's basically the age times 10. For a 65-year-old, it's 650. 75-year-old, it's 750. That's the cutoff you use. So if it's lower than that, that is a normal one for that person. That's very important. It'll keep you from pursuing the workup in people that don't need it who are a little bit older. Pregnancy is a little different story. We know that pregnancy changes your D-dimer, absolutely changes your D-dimer. And we're still, I'll tell you the data we have so far in a minute, but we're still searching for the right answer on D-dimer use and cutoffs in pregnancy. And I'll get back to that in a second. So your core concept here is do not order anything as far as especially that D-dimer until you risk stratify first. No likelihood, no D-dimer. But you get into it's on my radar, then you can consider ordering it with one exception. Let's go ahead and let me back up a sec on this one. So now I'm at the bedside. It is somebody who I think is a low likelihood of a PE, but I'm thinking about it. It's that asthmatic with the pleuritic chest pain, young, healthy, otherwise. I'm a little bit worried about this person. What I need to do at this point is decide if the PERC rule applies to this person. I think it's a low likelihood. I've done my decision aid here, or I've used my clinical judgment, and I've decided it's not a high likelihood here. It's not the big leg or the cancer person. It's just a young, healthy person. It's low likelihood here. I can actually apply a different rule to start with, and we'll talk about this. I'll show you the algorithm. But as far as these decision aids are concerned, you can use whatever you want. There are different ones out there, which tells you none is particularly perfect. The one that's accepted the most is the Wells. It has its own problems, which also tells you why it is okay to trump that, to basically override it with your clinical judgment. Let's show you why. Here's the Wells. So this is the Wells that we all use. It's actually really worth documenting the Wells in your chart. It's really worth putting it in there. But the problems with the Wells, the biggest one is this thing that I think it's actually asthma causing this young woman's shortness of breath and discomfort. I don't think it's a PE. I'm going to put my money there. That is a very soft call. That is a very debatable thing. I may think that, but if you saw the same person, you may not. That is a bit of a soft call. And what if it's this young woman, but her heart rate is 99? You know, she wouldn't get any points for that, but that's still up, and technically that's probably tachycardia for a young person. So this is still a decent tool. Use this, but if your spidey sense still says, yeah, her heart rate's 99 and her cutoff score is low, but I'm still going to work her up because this is not fitting for what I'm comfortable with here. That's totally fine to do. So first, you're going to, so that's getting them to the low risk, high risk, no D-dimer. Okay, I need to do something. I'm going to stratify them first before I order anything, because if that person's in the low-risk group, this young woman, she's otherwise low risk, I now have the option of using the PERC rule. Now, this is only to be used in the low-risk person, only. That's it. So she's perfect for this. And now I pull up my PERC rule on my handy-dandy MD Calc, and I go through all 8 of the things on that list. All 8 have to be negative. Okay, all 8. When you click this thing, if you don't have MD Calc, you can't have one that's an outlier. All 8 apply. They have to be all 8. This is not something where you can fudge it because it doesn't work that way. That's not how it was designed. What you're going to be able to do is peel. So maybe you do this in her. She's under 50. She's not tachycardic. She has a great SAT. Her leg isn't swollen. She didn't cough up any blood. She hasn't had any recent trauma or surgery. Never had a clot before. She's not on any kind of hormones. I can say, you know what? It's probably your asthma this time. I'm not going to have to work you up any further. I don't even have to order any more blood tests for you. Let's work on your asthma. It's called perking out. She's already low risk. I'm going to now put her through the PERC. If the PERC applies, all 8 of them, she gets to go home. We treat her asthma, she goes on her way. We don't even order a D-dimer. And if they fail any of those, though, now you have to get into the D-dimer group. So here's the algorithm to put it all together. It makes total sense. So I suspect somebody has a PE. Okay, I'm going to assess them as far as my probability here. What I'm going to do is I'm going to decide if they are high probability PE, oh my gosh, that big fat leg, and they're short of breath, and they have a low pulse ox. I'm just going to go right to CT. I'm not even going to order a D-dimer, because if it's normal, all it's going to make me do is feel like maybe I'm wrong, I shouldn't get the CT. I'm just going to go right to the CT. So that's the high-risk person. It's like, I think that's absolutely a PE. That's what's going on here. But if I'm in this sort of, no, I'm not so sure, I'm going to go ahead at that point. If it's a low likelihood person, PERC them out. If they PERC out, they're done. They don't get anything. But if they fail any of the perk, now they're back in the go ahead and get the D-dimer group. Okay, now I'll get the D-dimer. And if their D-dimer is negative and they're lower intermediate risk, I don't do anything more. If their D-dimer is positive, now I go ahead and get the CT. It's actually, and by the way, that D-dimer you're using is that age-adjusted D-dimer. Frankly, this is a very straightforward approach. This is actually very well proven approach. This is a very defensible approach. If you do miss that PE, which you will do, because this is not a perfect approach, but boy, it is pretty darn good. I highly, highly recommend sticking with this, highly, and do it every single time. So you're in that sequence, and the way you risk stratify, make sure you have a reproducible way of doing that. I do the wells every time. I use my clinical judgment. If I think that the wells isn't quite perfect for this person, that's how I risk stratify. So you will be able to, in the cases where you get the call, remember that patient you saw a couple days ago, you get that call, and you feel terrible that you missed a PE, you go back and you know you did exactly the right thing, exactly the right way, and you're going to do it again next time. Okay, really important because you will miss a PE, really important. The imaging, by the way, you can get VQ. That was one of the things that we talked about when the contrast scans were, contrast was a shortage. They talked about starting VQs in our hospital, which actually went nowhere. It was hilarious. It was like, it's just, we can't even get that, so that's not happening. So CTPA is the imaging study of choice, and here's some images if you're interested for what they look like. I'll tell you, it's pretty amazing, CTPA looks like. In pregnancy, it's a little dicier. So we know, I'll tell you why, right? So anybody in this room who's been pregnant or married to somebody pregnant or knows somebody who was pregnant knows the physiologic changes that happen in a pregnant woman's body are phenomenal. They are incredible. So first of all, they end up with an increased respiratory rate. So a resting respiratory rate in a pregnant woman is already a little bit high. It's probably progesterone related. And as you get pregnant up to here, your lungs are this big, and you tend to have an increased respiratory rate anyway. You also are tachycardic at baseline. Your baseline heart rate increases with pregnancy. It actually near term drops a little bit, but basically, so their heart rates tend to be up. Their respiratory rates tend to be up. Their symptoms of feeling short of breath, I feel short of breath, is common. Who doesn't feel short of breath when junior is pressing on your lungs? Of course you feel short of breath. So the wells, which actually hasn't been tested well in pregnant women anyway, really it falls apart quite a bit when it comes to pregnant women. And it's actually been adapted. These scoring systems, like the Geneva score, have been adapted for pregnancy, and they're actually a little more accurate. We'll talk about that in a sec. So we need to, and we know that pregnant women are more likely to get a PE, by the way. So we need to be aware of it. It's not common, but it's something to think about, like we think about in anybody. So we need to find a way to get at this because radiation in a pregnant woman is a problem. We just don't want to go CTPA them all. So we need to find an approach that is the safest in the big picture and still picks up what we can of the diagnosis. Now, the ACOG, the American College of OBGYN, they've actually been pretty silent on this for a while. I've been keeping track of their literature and their recommendations, and I'm not sure why they're dodging this. They're getting a little bit loose on certain things. So they initially said, do not use a D-dimer in pregnancy to rule out a PE in pregnancy because we just don't know what the numbers are. The reality is we probably can. The question is, what number do we use for that? And I'll talk about that in a minute. That may be changing. They do recommend, and this makes clinical sense, this makes physiologic sense, if they have leg symptoms, I've got a big fat leg, go for the leg first. If there's a clot there, I frankly don't care if there's a clot here. I need to treat them anyway, so I'm going to go ahead and treat them and not radiate anybody. Okay, I'm not radiating the mom's breasts she needs to breastfeed her baby and grow old with healthy breasts, and I'm not going to radiate junior. So if you can find the clot elsewhere, that's where you're going to go. If not, and the patient really needs the imaging study, you'll get an imaging study, but we'll talk about whether MR might be a replacement for this. But CTP, if you really need it, you get it. That's fine. If you really need it, you get it. So this is one of the approaches to PE in pregnancy. And one of the things you're going to find here on this particular approach, it's a little small, so look at it in your book, is that they actually have the D-dimer in this. And this is actually from an OBGYN publication that basically says we need to really think about using a rule-out protocol here for women. If a D-dimer is negative, we need to just send them home, that they don't have a PE. Well, I'll talk about how you decide that in a minute. But they do mention, and this is important to know, that even in somebody who you have a high suspicion who doesn't have leg symptoms, go ahead and get those ultrasounds of both legs. If they have a symptomatic leg, get it of the symptomatic leg. If they don't have symptoms, get it of both legs. Because you'll find about 15% of the time, if there's a clot there, if there's a PE, they'll find the clot here. So you, again, non-radiating kind of study, you'll go here first. Then if that's not the place, you'll go ahead and get a CTPA. So this is the sort of approach in pregnancy. MR is being studied. It does work. It is no ionizing radiation. It just hasn't been integrated well into protocols for us to know how good it really is. So I think literally that's on the horizon. It's just a matter of what you can get in MR is kind of the bigger issue here. So this is a slide for you to show how they've adapted the score, the pregnancy score for the Geneva score, not Wells, this is Geneva. And you'll notice that they have an age cutoff of an older woman gets a score, so women over 40, increased risk of PE. And the heart rate that's considered a positive heart rate is over 110. Again, this is because you change as you're pregnant. So this is the Geneva score. Probably the best algorithm to date to look at the cutoff of pregnancy score is the years algorithm. This was in the New England Journal of Medicine in 2019. It's been validated since, that basically looked at, depending on these years criteria. So if you look at this algorithm up there at the top, there are 3 criteria that are considered years criteria, one of which is, by the way, hemoptysis. Those criteria, you combine those plus a D-dimer level. And the cutoffs that they use here are 1,000 if your years criteria are no big deal, or 500 if you have one or more of the years criteria. And they looked at what happened to people if they basically followed this and did these protocols, the way this thing is laid out. What they found is that they diagnosed PE in 4% of the women they enrolled in the initial study. They avoided scanning women in up to 40%. That was a lot. They basically cut down 40% of scans, which was really nice. They only missed one clot, and it wasn't a lung clot, it was a leg clot. And this seems to be best in first trimester women. So right now, again, we're still searching for the right answer in pregnant women, but we're getting there. This is sort of one approach. It hasn't been uniformly applied, though. So just know that you're going to have to be a little careful. Always call the OBGYN if it's a pregnant woman. Get their gynecologist involved. It's really worth doing. But go ahead and consider using D-dimers. Be careful with the cutoffs. Use definitely ultrasounds of the legs. Now, treating PE, once you've diagnosed it, the treatment's easy, right? If they're hospitalized, it's heparin. If they're pregnant, it's low molecular weight heparin, inpatient or outpatient. It's low molecular weight heparin because that's the treatment of choice in pregnant women. And we do know that the novel anticoagulants are absolutely fine to use in PE. The fibrinolytics, do you actually break up the clot? Well, there really are only 2 accepted reasons to use that right now, basically for cardiac arrest and a PE causing shock. So basically that PE is so big that it's affecting their perfusion. It's actually causing shock. That's jamming up the system and causing shock. It really isn't indicated in either of those 2 situations so far. This is a soft target, though. This has moved back and forth in my entire career. But right now, that's really the recommended times to use something like a clot buster. And people can go in and get the clot. If you have the right kind of setup where we can go suck that clot out, you can. We do that at our institution. They actually will go get the clot. We have a PE team that can go get the clot if somebody has a thrombolytic problem. So that's the deal with treatment. Dispo is another thing. Should you admit them all? We did forever. We should not, but we need to be very careful which people we send home. In Canada, they send way more people home than we do here. In Europe, they send way more people home than we do here. There are scoring systems that help you with this. There's the PESI score and the Hestia score that basically help, and what they're really doing is saying, just make sure the patient is generally healthy. They have cardiovascular, cardiopulmonary reserve. If that PE, if they have worsening symptoms, they have some reserve. Make sure their social situation is good, and make sure that they have access to care, that they can get the drug that they need, the anticoagulant they need. Because we can send these people home on POs, right? DOACs, these direct anticoagulants, things that we can use. We can send people home on they're effective right now. You give them a pill now, and within a matter of hours, they're anticoagulated. So know that it is possible. Kaiser has been sending people home for years in this country, so it's absolutely fine to send somebody home who has a pulmonary embolism. The last of the things we're going to talk about is the other clot, right? The other big clot we worry about, which is basically the DVT, which is usually where the PE comes from. That's usually where it comes from. They are basically just a spectrum of the same disorder, venous thromboembolic disease. And the causes are the same. It's all Virchow's triad. It's whatever causes a clot. So they're very intimately related, these 2 things. DVTs, we know, tend to present with that sort of hot swollen leg or red swollen leg, and we know the biggest thing in the differential there is cellulitis versus DVT. I do want to throw one more thing into your differential to kind of have you leave here a little more knowledge than you may have come in with, which is basically a Baker's cyst. Throw that into your differential because that can also cause calf pain and swelling. And that's something that when you order your ultrasound, you may want to mention they might want to take a peek for to make sure it's not a Baker cyst causing the symptoms. But they tend to come in like this. And again, there tend to be people with risk factors. They come in like this. People are often sent to the ER, rule out DVT, right from somebody's office. That's when, or please treat for cellulitis. Your job is to decide which is which, and we have sort of risk stratification criteria here. I do want to mention one thing though. Every once in a while, I've seen 2 of these in a 30-year career, so this is rare but worth putting on your radar. You will see somebody with a swollen leg, but a really swollen leg. And not just a swollen calf, but a swollen leg up to basically the fold, and it is excruciatingly painful. That is a DVT on steroids. That is a DVT that's really pissed off. That is a massive DVT. That is basically, the leg can be either red or purple. That's phlegmasia, ceruleia. Okay, these are basically, it's called phlegmasia. Just type in phlegmasia, phlegmum, like phlegmasia. That is basically a clot that's caused a bunch of congestion in the leg that can't get any blood out. There's phlegmasia, ceruleia alba, which the leg is white. It's swollen, it's exquisitely painful, and it's white. That is a surgical emergency. That is a clot up here. It's usually iliac or higher. It's a massive clot, and there's basically congestion in that leg, and nothing can get in there or get out of there. That is a disaster. So just know, really, really bad DVT, gigantic, painful leg, know that yes, it's a DVT, but it's an extra special one that you need to pay attention to. The diagnostic criteria for DVT is the same as before, as it is for PE. Exactly the same thing. Do a risk stratification thing, D-dimer if it's indicated, and then go ahead and ultrasound. Okay, and frankly, get the reason we do the D-dimer is to have some people we don't need to ultrasound, and the rest go ahead and ultrasound. If they're positive, you're going to treat them, and you send most of the people home. So here's our Wells criteria for this. You know this. This is like old school stuff. It's in your MD Calc. Here's the algorithm. Very straightforward, very simple. It's likely or unlikely, super easy initial stratification, super easy sort of approach to this. Very easy stuff. Here's some images for your interest. We treat with novel anticoagulants. You do that absolutely fine, and we can send them home, most of them home. So I am done. I'm going to answer the Q&A up here, so stick around for Q&A if you want to. We'll do Q&A, but that's my last lecture. It's been delightful. I love this. Thank you for being here.
think I'm muted. Check, check. Woo.
Yeah.
Slide will be blowing up this morning.
I didn't see these questions earlier.
Let's go, Sharma. I heard your lecture this morning.
Do you have your mic?
You thanked everyone but your best friend right here.
Well, no,
I'm just saying.
What do you mean? I intentionally did not thank people because whenever you thank people in a list,
Mike,
you fail.
your mic. Mike, your mic.
Mike doesn't need a mic because his voice just like booms to the next state.
Are you going to stand?
You can hear him back in Texas.
Thank you.
There you go.
What's our first question?
Are we going to brunch at the Wynn?
Yeah.
Nice.
Yep.
You paying for the Uber?
Yeah, it's fine.
Drop in the
Just
bucket compared to the
casually
buffet.
throws it out there. Not as bad as was it Caesar's last time?
Yeah, that was brutal.
Yeah.
I'm pretty sure that was $100.
Yeah, something like that.
It was gross. Yeah. Okay. Yeah.
It was good food, but
If I'm back wearing different clothes after the break, so I went to the buffet after this.
Look, I wore fur today to make space, okay, so that you can't tell.
It's slimming.
Hi, guys.
Well, you know, it's here. Okay,
All right.
Diane, you're so cute with your response. Do you know what the tibia is for? Finding furniture in the dark. And you go, my little toe is too.
Yeah.
Oh,
I
yeah.
broke my little toe 3 times during COVID. During all the lockdown, 3 times.
Are you serious?
Yes,
toe?
chasing after my grandson though. That
Oh
was,
my
I blame
goodness
him.
gracious.
I blame him.
Okay. Let's start with what criteria do you recommend for the diagnosis of sepsis? Getting more and more insurance company pushback on sepsis diagnoses.
So I am going to mention that you will get a fabulous lecture on this from Jessie Werner, who will get into the nuances of all the changes they need to quit changing the damn thing, but she'll get into all the changes of what's happened. But so I think that what might help with this question, because it is confusing, right? I mean, you remember, you figure out one and then they change it, and it's like, what? They get rid of entire categories. It doesn't even count anymore.
Yeah, Jessie will be here this afternoon.
Like in an hour and a half.
Yeah, the talk
Yeah.
is tomorrow morning at 8, I think.
Yeah, talk tomorrow, 8 a.m. First talk.
I'm the first talk.
You're
Oh,
because
second
we're
talk.
starting early, 7:30
no, I
tomorrow.
think I'm
Oh,
the
that's
second
right.
talk.
We need to remind you we're starting early tomorrow at 7:30 a.m.
Yeah, so those of you that are in this room will be here at 7:30.
Okay, I'm the third.
Everybody else, come in at 8.
We'll make an announcement again
Yes.
later
Yeah,
today.
I'll make sure I say it
Put it in
on my
Slido.
talk today because I'll be the first one.
I also love this next question so much, and I wish Ken was still here too to talk about this.
Well, he is in spirit, right? So this question
Yeah.
about tetracaine use, right? I hope that if you're coming to this boot camp, you're here to learn about the most up-to-date evidence and to have some of the dogmas that we may have heard or have been passed down to us, these black pearls, right? These pearls, so to speak, from people who have been there for a long time, and they pass on these things like, hey, don't ever do this, and then the medicine has evolved, okay? So I threw a bunch of links down on that question here. So Dr. Clower, who is now the CEO, over all the DOs here, he wrote a great article in ASAP Now a couple years ago. Ken Milne himself had a episode of his SGEM podcast with Dr. Glaucomflecken, who is arguably the most famous ophthalmologist in the entire world. Okay,
If you haven't seen his TikToks, you have to see it. Or now I guess
So
it's on
funny.
YouTube, but he's hilarious.
That guy, it's crazy. He's died twice
Yes,
and has
he
come
has.
back. It's like ridiculous. So like he's got a crazy story, and he gave, I think, what standing ovation talk at ASAP
Yeah,
this
he was
year.
the
Him and his
opening-
wife, who
opening
saved his
session.
life.
Yeah,
You know, like she's the
amazing
one that
story.
did bystander CPR in the middle of the night when she
For
realized he was
9.5
having agonal
minutes.
breathing. Yeah, she's not that big either. I don't know how she managed to do it.
Tiny
So
person. Love.
so-
That's what did it. Love.
yeah, seriously. Yep. It's like lifting the car off of
Yep.
the kid, right? So yeah, anyways, there's that. And then there's another, I just threw on because I was a part of this discussion on Twitter. It's so funny. This ophthalmologist puts a picture of the box of tetracaine on Twitter And the box is clearly marked for ophthalmic use. So it's clearly ophthalmic medication here. And then the ophthalmologist says, ED docs, don't use this medication in eyes. And it's like, it says ophthalmic use on the box. Like, the manufacturer said it's okay to be safe. And so it was just like, it was almost like he kicked the bee's hive of emergency medicine clinicians.
People are
And
like running in the streets, like setting off alarms.
It was great. Like Outcomes Ken Milne,
Breaking
Outcomes
stuff.
Anand Swaminathan, Outcomes, all these people who are like, the evidence shows this. What does your evidence show, ophthalmologist? And he's like, well, there was this series of 7 case studies back in the 60s.
Yeah, I'll
That's
tell you
it.
what
Like,
we need, though.
Terrible.
Am I on? Yeah. What we need is ophthalmology to write the paper that says it's okay.
Good luck with that.
No, I know that. I know, but that's really what we need. Because frankly, if a patient does something that isn't quite right with that, and they scratch their eye, or they rub their eye, or they use it too long, or they end up with an ulcer, or they end up with something worse, they will be lined up to get those expert witness fees to testify against you. This is a tough one, and I'm not sure where. This one's a hard one for me. I find this one hard. I don't know.
I don't do it on a routine basis, okay? But so again, we're looking to do this in people who have confirmed just corneal abrasions, just a scratchy poo, and nothing else on their eyes, okay? And it was asked, what are these safety instructions here? In Ken's blog post, it was one drop every 30 minutes for no more than 24 hours. So it's a very time-limited use of these drops here, okay? I can think of a very compelling reason why to do this. Somebody comes in with a history of opioid use disorder, they've been clean for 5 years.
Well, that's one thing.
And they have really bad corneal abrasion pain. And they say, Doc, the last thing I want is to get hooked on these opioids again, but this pain is killing me. What do I do? Okay? I think there's a very good case to be made for like, hey, if this person is committed to, number one, not having oral opioids, and number two, being safe with his eye because he likes his depth perception, okay? And so you make it very clear that you talk to him at length, you write it out in the discharge instructions that you hand him that can be viewed later on by people who look at your reports here. Wow, he says he's told him, it's written in the discharge paperwork. At some point, you have to trust that people are going to do what you tell them to do and that they agree to do. What are we going to do, like stop prescribing ibuprofen? Because you could overdose ibuprofen.
Let's not get ridiculous. I mean, this isn't that common.
I know, but that's what I'm saying. Is at some point, if there's an agreement made between the clinician and the provider and the patient, you have to kind of like let them go and like let them fly.
All right.
True.
Did we beat that horse?
Not yet.
We beat it
We can
to
still
death.
beat it some more.
Okay. All right. I think they get the point, though. Very good. And it's a great conversation to have. Chip has confirmed what my wife has tried to educate me on all along. She's always right, and I'm always wrong. Okay, well,
Safe position.
Way to go.
Evidence-based.
Evidence-based.
N of 1. Actually, N of 3.
The live stream
And
is
of all husbands everywhere.
Yes.
Now.
Love that Amber, too. All right, and that Monica. If we attend this course, do we get a discount on the self-study advanced EM course? Yes. To answer that again, if you want to go out there and get a copy of the course at a discount, you can. Okay, moving on to Achilles tendonitis as far as treatment. Splint at dorsiflexion. We talked about this yesterday.
Plantar flexion.
It's plantar flexion. Plantar flexion. Period.
If you dorsiflex, the medical word is distracting. You're putting the points apart from each other farther. You want them to be closer to each other so they heal better.
Plus, good luck getting dorsiflexion in somebody who has a partial tear. They will hit you. It's painful. It really hurts.
Uh-oh, my battery on my computer is low. What do I do, Dave?
Talk fast.
Okay, here we go. I put some videos up there. I have about 10 different eye videos on real patients and the use of the slit lamp. You can take a look at those if you like. Actually, really great question here. Is there anything to worry about if someone's intraocular pressure is less than 8? And yeah, there is.
Does their eye look like a deflated balloon?
Yeah, what's it look like? When you push it, does it go to the back?
Well, don't push it.
Yeah.
Don't push it.
So I had this one time where like we suspected globe rupture in this patient. He had a Seidel sign. We're calling ophthalmology. Ophthalmologist goes, what's the intraocular pressure? And I'm like, I was told not to do that in patients who have suspected globe rupture here. So that's the concern. If number one, hopefully you saw, or at least in the history of physical, you're like, oh, that's weird, maybe globe rupture, that number one is don't push on those eyes, okay? Usually a tonopen involves some sort of physical pressure on the globe. You don't want to do that if the globe potentially is busted here. Number two, I mean, like, if the globe's intact and the pressure is that low, I'm curious to, like, calibrate your tonometer, maybe have someone else do it, because sometimes I'll get one weird reading, I'll go, huh, that's weird, and I'll kind of like redo it a couple times, it'll kind of normalize the reading. So I wonder if equipment issues are to play if it's a suspected not ruptured globe.
Yeah.
Anything
Sure,
else
but the
there?
key here to this question is that a low pressure can be caused if they have a post-surgical wound leak, right? So that's important to know. Chronic inflammation can cause that. Even retinal detachments can cause that. So these are big key diagnoses that you'll need to make. So yeah, check your equipment, check it a couple of times, and certainly don't just ignore it. We don't like to ignore those types of things. Absolutely.
You can also check your own eye.
And the comment was check the other eye. So I think it's fair.
Yeah.
Check the contralateral eye.
So,
Great.
and I mean, I'm only partially joking about checking, because at least with, depending on the tonometer, there are ones that, I can't remember the specific one we used, but it's very, very delicate, and it's...
Is it a Reinhardt?
The one that you shoot the little thing at their eyeball?
Yeah,
love that thing.
So, but they're disposable, and you can just use one, and especially with kids, like I'll show it on either a
Those are
tech or a
great.
nurse or
They're
myself or whatever,
great.
and show how gentle it is. But it's a great way of just double checking and make sure that the thing's working right, which I've never had an issue with that, but in theory, it's something that would be worth double checking.
All right, let's talk about AFib and RVR, Diane. In patients with AFib and RVR doing cardioversion as initial treatment, are they typically doing transesophageal echoes prior to cardioversion to make sure there is no thrombus in the left atrial appendage or other evidence of clotting?
Okay, big
Yeah,
topic
it
of
is.
treatment AFib and RVR. I tried to sidestep it, you guys.
Couldn't
So we're
get
only
away
talking
with
about
it.
rhythms here because it really is, honest to God, a huge topic. But so yes and no. If you have a really good, if somebody says, you know, it was 10 o'clock this morning, I was watching whatever on the TV in Las Vegas, and I felt my heart flip into AFib, and they see you 2 hours later, just do it. If you're one of those people who want a cardiovascular, have at it. The longer you wait, though, the higher the risk, and still the risk is frankly still relatively low, but the longer you wait, the higher the risk, and we don't want to cause that. So I know that at our institution, when people are brought in for elective cardioversion, they do a TEE as part of that workup.
Yeah.
So that's the other end of that spectrum, though. That's right. That's the person who's being outpatient treated and all that other jazz, and they're usually on an anticoagulant already and blah, blah, blah. In our window in the middle, I'm not aware of that being done in ERs, where you feel you need to make sure there's not a clot before you cardiovert. That person's probably safer to just put on an anticoagulant, get them treated as an outpatient, and not take the risk for you or them. Does that make sense?
Yeah. It's great.
The theoretical situation here I've heard of is like someone has AFib with RVR or prolonged AFib, and they need to go off to surgery. And it's like, I want to see if I can cardivert them before, like optimize them before they go into surgery,
Wow.
but I don't know how long it's been going on. Like that's a thing you could do to do a transesophageal or maybe transthoracic. Anyways, some
That'd
sort of
be a
echo.
TEE, yeah.
You know, yeah. So, how many of these patients are unstable that you've seen, like AFib with RVR?
But you know, most of the unstable AFib with RVR I've seen are people that have had it for a long time that have another reason to be unstable. They're bleeding, they're septic, there's something other reason. It's not the AFib with RVR that's the problem most of the time. And it's usually the acute onset. It's now just out of the blue, they have it, and they have some of the other reason that they end up, you know, they have AFib with RVR, and they are a person where that alone causes trouble. But that's rare. I really, honestly, I can't remember the last time I went crazy cardioverting in AFib with RVR.
Because that's where I would be worried. It's like, we got to cardiovert right now because they're unstable from their RVR, but that's the great
But then
point.
you
It's
still
like,
do that. But then you still, if they are that unstable, you feel you need to cardiovert, is there having a clock going to change that? It's not.
Right.
So, yeah.
Sorry, my computer's
Got
going
to
to
fix
die.
them
So
now and then worry about the
Yeah.
clot later on.
we're going to have to control Slido from
So,
a phone.
speaking of that, like treating the underlying cause there, if it is sepsis, is going to, you know, can help reverse the AFib as well.
Exactly,
And
exactly. So you
that's-
fix it.
Yeah, exactly. And I've seen that a few times where, you know, I'll have a patient like that and get them back out of AFib just simply by giving them fluids or treating the underlying cause or whatever else. And then I've seen other people who are a little more excited to use electricity, and then they go right back into AFib again because you didn't treat the underlying cause.
The problem, exactly.
So I know you're trying to dodge the topic here, but it's like, so what?
Since we were just talking about it.
Stop it, please.
Jeez.
So specific situation here, AFib and their septic, which is not uncommon combination
Right.
here, and like their pressure's a little soft, they're
Yep.
tachycardic. Would you
Fluids,
treat the
fluids.
sepsis first and then see what
Flat
happens?
out, because it will get better.
Yeah.
So their AFib with RVR becomes AFib.
Like I think you'll know very quickly if they're responding to like fluids
Right.
and
So
whatever else.
I think of it as their physiologic equivalent of my sinus rhythm. Their baseline is AFib. And then it gets faster if it needs to because it's stressed or it's bleeding or it's septic, like I would get faster, just sinus.
Just throwing out that ultrasound can be really helpful here,
Yes,
too.
it can.
Yeah.
Volume status for sure.
Touche.
Spoken by the ultrasound guy.
Oh, Chip, you made this comment about Diane.
Oh, look at Chip in
Would
there.
you like to read
Yeah.
it? Can you read it?
I can
I'm giving
read
you
it.
a visual acuity test right now.
Diane makes a very important point of triage labs and labs in general. Make sure to address the abnormal labs. If something was ordered in triage, it still needs to be addressed. However, that can mean simply what Diane said, which is, specify it is not a factor in this case and why. And Diane's mentioning this in there, and I just wanted to really, really emphasize that because that's something I wanted to make sure was somewhere afterwards too, that people can look at it because what you mentioned about like troponins, BNPs, and D-dimers can be, especially D-dimers, if they get ordered out in triage, can be a huge nightmare because of the fact that if it's positive, now you have to address it. Well, there's 40 plus different reasons why the D-dimer can be positive, and only one of those is PE. Mm-hmm. So, is this one of the other factors that's involved here, which it often is, and then specifying, like in your scenario with the asthma patient, is that this is an asthma exacerbation, this is what's going on here, this is a young, otherwise healthy person that doesn't meet any other of the risk criteria that I would use, like I strongly feel it's not this. And then a lot of times I'll say, I make sure I specify is that I've discussed this with the patient too, that a test was done out in triage, and especially nowadays, if you're not aware of this, your labs by federal law are now, like your labs, your imaging, everything is now available in real time, which can be a real pain if you have patients who they haven't even seen you yet. They know what their results are, and now they're freaked out because their D-dimer's high, and they went to Google, and D-dimers, means that they have a clot, and now they're freaking out. So now you get to explain to them, hey, it's okay. There are a lot of different reasons why this can be elevated, and this is why it's.
Let me show you on your Google the other stuff too.
Yeah.
Yes.
Did you scroll down?
Yeah, scroll
down.
Keep scrolling.
No, I hit the first result, which is also like a malpractice website.
Oh, jeez.
Have you been harmed by? Yeah.
By a D-dimer? No.
And it's been said other places, I think, but abnormal labs and abnormal vital signs as well. Like, how many flu patients am I discharging from triage with SIRS criteria vital signs, right? Now, if it's a young, healthy person, no comorbidities, they look good, I'm going to say all that stuff in my discharge paperwork and off they go. But if they have, I'm diabetic, I have whatever stuff at baseline here, I feel terrible, I have a fever, maybe you just have the flu. It sure does sound like the flu, but I'm going to do a couple more things before you go, just to make sure I'm not missing some other weird thing going on, like flu and DKA, flu and whatever else here. Okay, so if you're going to hand wave those vitals away, make sure that it's a patient where you should be hand waving the vitals away.
Yeah, it's always worth addressing the abnormal stuff in your note.
Yeah.
It's just always worth addressing. You don't have to do anything about it. You just address it in the note. Like, I didn't chase it because this is why I'm not worried.
So, Diane, we kind of talked about this yesterday regarding the PERC score, if there's sustained tachycardia as the criteria versus a one-time recorded heart rate over 100.
Well, it'd be nice if it were sustained. It's not.
It's one time.
It's one time.
And that can be the triage vital signs because it's a hot day and they're overweight and they walked 100 yards to get into the emergency department and they immediately check the vital signs like, that person's probably going to have a heart rate of 120, but in 10 minutes time when they're sitting in a room, their heart rate's down to 80. Well, the 120 still screwed you
counts.
over. Yeah.
And again, the thing about these decision tools for you is to use them exactly as they were designed. And actually, I will tell you one thing about the PERC that I probably should have mentioned, I didn't, is the one group that's falling out because they were not included in the initial study are pregnant women. So that's a group where PERC is not necessarily as robust. The PERC, you still miss PEs and PERC. You still miss 1.2% of PEs and PERC. And in pregnant women, it's probably higher. So it's something I've stopped using in pregnant women. I did for a while, thinking it was okay, but no, not anymore.
That's where the other options with adjustment goes.
Yeah, exactly. Yeah, exactly.
I like this next question. If suspecting DVT in iliac vein or intra-abdominal vasculature, what imaging would you recommend?
So this is where you don't do just a leg ultrasound. You actually need a CTV. So you actually talk to radiology and say, I frankly, if you ever in a situation where it's like, I've never dealt with this before, I don't know what to do, call them. Just say, I'm worried about an iliac something because of this physical finding I have. What do you recommend, Dr. Radiologist, Dr. Live in the Dark? What do you recommend for me to get as an imaging study? And they'll tell you, but it's usually a CTV. It's one of the, actually it's also one of the rare times venogram is sometimes done. Real venogram.
That's right, yeah. And they love talking to you.
They do. They're lonely in there.
Yeah, they are. In fact, walk over there and be like, hey, I'm so-and-so, and they'll be like, oh, you're the one that always calls me about whatever. And now you're going over to get their input. Don't you love it when you're specialized in something and someone comes to ask you your opinion or, how you know to do your job? So radiologists love to talk. They do. Don't be afraid of them.
We have a radiologist that I just have to brag about him for a second because he actually comes over and examines the patient and clinically correlates himself.
No
What?
way.
I know. He's a wonderful human being because he'll actually come over, talk to you, and he's like, let me just check this patient too. Like,
oh my gosh, that's awesome. Actually, the head of radiology at USC.
Yeah, this is a unicorn that exists.
Yeah, he used to do that all the time.
Wonderful, wonderful person.
Oh my gosh.
It's like a self-driving car. That's awesome.
Do you have his phone
Except
number?
for it works.
All right, when ordering an x-ray on a patient, what reasons would ordering a 2-view be better than a 1-view?
I love 2 views, and I urge you strongly, if someone is able to get both views of an x-ray, please get them. Yeah. So we get in the habit of hitting the portable chest x-ray, which we know sucks in general. It's hard when somebody's on a gurney, and they're just not the best studies by any stretch. As long as the patient can do it, having them stand up helps. They breathe better, the x-ray's better, they can actually sit in front of that thing just fine. And what you get on the lateral, I love x-rays, what you get on the lateral is you see the spine, you see the extent of infiltrates, you see the backside of the heart, so you see the posterior contour of the heart, which is only the left atrium, that's the only place you see it. You don't really see it that well on a PA or an AP. And by the way, PA and AP are taken from the front or the back, and you get a little different view depending on that. I just think they're fabulous. I just love them. Yeah. I love them.
Absolutely.
You can also see, by the way, the posterior lung fields, which we don't see very well on the AP or PA view. You can see little tiny infiltrates back there. You can see fluid back there.
You know what's funny, Diane, is at my institution, if you order a 2-view, if you order it, they still will only do a single view unless you specify.
Yeah. So when I work, they usually it's like, oh, she's on.
Yeah. Okay. And they're like, okay, all right.
It's like, just get the 2 views. She'll come over and bug you.
Okay. I wish Ken was still here because this next question is about sprained ankles and splinting. Why would you splint a sprained ankle? Isn't range of motion exercises, are they one of the most important things to do to get mobility back to baseline?
So I'll actually talk about this tomorrow too.
Oh, good.
Yeah.
So your soft tissue stuff?
Yeah, with the soft
Perfect.
tissue stuff.
Can you just give us a little taste and flavor?
Yeah. So just preview of it is that range of motion is good. There's been newer evidence to show early range of motion exercise is beneficial. But at the same time, if someone is in a lot of pain and splinting is helping, then doing that for the first 24, 48 hours can be very beneficial. It makes patients happier. It helps alleviate that pain because splinting, if you've ever broken a bone or really badly sprained something, you know that holding it in a specific position there helps tremendously with the pain. And so that can be hugely beneficial of itself and allow for that bridge to the early range of motion. And I do the same thing with crutches, is that I'll give them crutches, but I specify only do this for the first day or two because I want you to start, early weight bearing also has a certain benefit with it. Then again, there are certain patients that are probably not going to be the best candidates for it. But again, splinting you can do. It's just something that probably should be done early on and then released pretty early on too.
Yeah, and it's a good, you mentioned the pain thing. I think that's really important. It decreases the need for pain medicine.
Yeah. Personally, is there any harm really in an ACE bandage or just a fashion splint? Like, what if there was even a questionable fracture? Maybe there was something that was missed. We do miss stuff. Yeah. So I don't...
Ultrasound helps.
Yeah, okay. Plus, it actually, then the patient can take a picture of it and put it on their Facebook, and then, you give them a work note. They're like, see, I hurt my ankle. There's an ACE wrap on it. There's
more sympathy points. Yeah,
right?
You got a comment up front, I think. Didn't
Yeah.
Oh, make them a splint.
The question is, do you make them a split?
So I mean, there's different ways you can do this, right? So you could fashion like a custom orthoglass. What I'll do for people who are, whether it's just their individual pain tolerance or there's kind of like a lack of effort, maybe some body habitus issues here, here's a walking boot. I'll put them in a walking boot that's essentially a splint that keeps them from having to flex too much of the ankle here, and same sort of thing. Only use this for the first day or two, and if you can ditch it, as soon as you can ditch it, ditch it. However, if you can't ditch it after a couple days, that's weird. You should probably come back.
Yeah.
Okay, because yeah, I totally agree. Occult fractures can happen, and that's a good, that pain not going away as soon as you think it should is a good clue that something else is going on potentially.
Yeah.
There are also what are called gel splints, which
Yeah.
I used a ton
Oh,
as a kid
gel
myself.
splints.
Love those.
And,
Love
and
those.
they're
Ooh.
fantastic
They
because
go inside a shoe.
Yeah, you
Yeah.
can still wear a shoe. And especially with walking boots, they can get kind of expensive and sometimes can be hard to find. We actually have a shortage of walking boots right now, so the
my
gel
fault,
splints are being used a lot. Yeah, thanks
You're
a lot.
responsible.
All the way in Texas.
Okay, when can I allow a recommended child to return to school if I diagnose them with viral conjunctivitis? Great question.
So hard. I mean, this thing's gonna be contagious for several days, you know? But is there a medically compelling reason for me to keep a kid out of school, to tell them, you need to stay home from school for 5 or 6 or 7 days here? Like, I'm not really a big fan of that either. So,
But
like,
the school may not let them back.
and that's kind of, I put it
Yeah.
in their court. I'll say like, look, hey, stay home for 2 or 3 days. You probably got the sniffles or a fever anyways. And then after that point, it's okay from my perspective if you go back. But if the school has guidelines of, oh no, Jimmy or Johnny's not going to be in school with a red eye, okay, that's the school's decision. And every school is so different, especially nowadays with all the different, you know, COVID and fever guidelines.
So one thing I'd mention, and I don't know if anyone else has talked about this so far with like school and work notes and stuff like that, I tend to be a little bit more liberal. It has worked out really well for patients because we have fewer bounce backs, because people need an extended note or, you know, they get frustrated or whatever, is I tend to give them extra time, but then I put in the note they may return sooner if improved. So if someone comes in like that viral conjunctivitis where, yeah, you may only be out for a day or two, or you may be out for longer, depending on the school's policy and how the kid looks, then by giving them that flexibility of, hey, little Johnny can be out for the rest of the week, or they can come back tomorrow if they're better, it really has helped, and most of our local school and employers will accept a note like that where there's that flexibility there.
Okay. Next question. An eye spud tool works well for most corneal foreign body removals, too. A little less scary to use, too.
It is. I didn't even know eye spuds existed where I trained, because I trained in a county hospital. And all we did to take out things was use our tuberculin syringe or what are little needles. And so that's how when I started moonlighting, they had one of those eye spuds. I was like, wow, this thing rocks. It looks like a little shovel. It's like a little flat shovel. And you can, it's not pointy, it's not pokey. It looks great, but of course we don't have them where I work. We still use the needle.
All right, Diane, PR interval is normal or lengthened in second degree type 2?
Normal. It basically looks like sinus rhythm where every once in a while there's just no QRS after a P.
Okay, I sent you an article on SVT, hereditary SVT.
Which is not the most common.
It's not common, but it can happen.
It can. So usually is the active word in that. It's not usually.
Yeah.
It can be, but it's not usually.
Yeah. Okay. Someone had a question about running the EKG blog. That's Amalma too.
Yeah, and that's in there. There's a bunch of links in this. If you have Slido, check it. If you're interested in that, there's a whole bunch of links in there.
And if you just search
Rock
for the...
star. He
Yes.
is like the rock star of cardiology.
And he's just such a
And
wonderful
he's such
person.
a nice person.
You know, I mean, he's got the whole thing.
There's other EKG blogs out there as well. Just search for the names that I put on there. Stephen Smith, Ken Grauer.
Yeah.
Stephen Smith is kind of like, and his colleagues are known for this new thing about, you know, STEMI and STEMI may be a thing of the past. And I'm sorry if I'm overlapping a lecture here, but now people are thinking like, OMI, NOMI. And so OMI is obstructive myocardial infarction versus non-obstructive here. Because there's so many STEMI equivalents. Like every year there's a new STEMI equivalent. So after a certain point you have to go, maybe we should stop saying STEMI as our criteria. There's other kinds of patterns that go along with obstruction that need to be taken to the cath lab. So yeah, you can search for Stephen Smith, and it's called the OMI Manifesto. If
And actually,
you have a hard
frankly,
time
it
sleeping,
does. As someone who gets really irritated, I wish they would quit. Like, I like pseudotumor cerebri. Why did you have to rename that? You know, this is a rename that actually makes sense.
It does.
Because what STEMI implies is that only an EKG finding can tell you there's something bad going on in the heart. And it turns out that is not the case. And it has to be ST elevation. It's in the name. Like, we need to take the name away and get down to what the pathology is. So.
we covered on, have we covered it on TwoView? I think we did. If we haven't, we're gonna. But 2022 guidelines from AHA, I think with ACC about evaluation and disposition of chest pain in the emergency department.
Yeah, sounds
Jesse's
familiar.
got
We did
that.
that.
Is she gonna? Good. Okay,
Jesse has it.
Good. So we're gonna cover this new OMI-NOMI somewhat here, where there's other things that have just been recognized by the cardiology literature as these are cath lab criteria, and we have to know these criteria as well, not just the cardiologists.
All right, we're out of time for the Q&A. We want you guys to have a lunch. This person that wrote this last question, come and talk to me because I have some of the same problems, but I don't want to create any bias here. So if you have this question, this is clearly a personal question, come talk to me. It's in a young, healthy female with a history of SVT. Does that increase her odds of having future heart issues such as postpartum cardiomyopathy when she has children? I went through this whole thing. So
I know you did, but do not base your practice on anecdote.
that's why I'm not telling. That's why you yelled at me before, so
I did.
I did send you an article on low-dose steroids for pericarditis, which I hope you take a look at.
I will look at that for sure, but I still will probably not change my practice.
Okay, back in 45, is that what we're doing here?
Yes.
Back in 45.
See you soon.
45. Oh,
Isn't that that's our lunchtime, right? It's 45 minutes?
Yeah, 1 o'clock.
Yeah, okay, 45.
is it 1?
Yep.
1:30. Oh, did we change it?
Can we double check?
I
Let's
think
check.
it's 1:30.
Might need to go back a little. There it is. Perfect. Thank you. Hi, everybody. I am Jessie Werner, and I'm faculty at UCSF Fresno in Fresno, California. And I'm here to talk to you today about acute coronary syndromes, and we're going to go over the essential concepts. It is a true pleasure to be here, and thank you so much for joining us. So our goals in evaluating someone who's coming in with ACS is, of course, here. So ECG within 10 minutes, as quick as possible. Really, the biggest goal is we want to identify patients who are going to benefit from PCI or thrombolytics, who are going to benefit from reperfusion therapy. That's the big goal, and that's going to be the theme that we use in talking about the different concepts today, because some of the terminology is changing, and I'm going to address that as well. Of course, we want to initiate medical therapy for these patients who are demonstrating ischemia, and we want to use our risk assessment tools, things like the heart score, to try and identify and risk stratify our patients. Those are our sort of overarching goals when it comes to people coming in with chest pain or something we're concerned might be ACS. In this talk, we're going to identify STEMI and STEMI equivalent ECGs. We're going to talk about the medical management of ACS. This is absolutely bread and butter stuff that we all need to know. And then we're going to, again, talk about risk assessment for patients who come in with low-risk chest pain. There are some new updated guidelines. They came out in 2021 from the JACC, the JCC and the ACC, all these different letters, the cardiology groups that have some recommendations, changes in how we might address patients who are coming in with low-risk chest pain, and I'm going to talk about those. So the really important part of this slide, I think, is actually on the right side, where we're looking at the heart and the way that the EKG leads match up with the location of the heart. This EKG here at the bottom is a nice corollary. So I think if you're going to pay attention to anything on this slide, just spend a little time looking at that. Of course, when this is how the EKG matches up to the location of the heart, you can see that leads 2, 3 AVF. That correlates with an inferior MI because, again, that's the inferior aspect of the heart. And you can see that on the EKG, an inferior MI leads 2, 3 AVF. That matches up with the right coronary artery. So that's sort of how you can use that. And then septal, when we have a septal or an anterior MI, we're talking about really leads V1, V2, V3, V4, kind of septal anterior, and that correlates with the left anterior descending, going straight down the front of the heart. That's the anterior part of the heart, and also the septum. We have the lateral leads V5, V6, leads 1, and AVL in blue on the EKG. And again, correlates with that left circumflex, just coming off laterally around the heart. And so that's why we see the changes that we do. So I really like this. If you haven't seen it before, take a little time to get familiar with it. Let's talk about ACS. What is it traditionally? When we have said ACS in the past, it's really 3 things. It is STEMI, NSTEMI, and unstable angina. If you have any one of those 3 things, you can say that you have ACS. And this is the traditional terminology that we have used. Traditionally, STEMI on an EKG, of course, is ST elevation. You can see it on the EKG. It's in a predictable pattern, and it's in contiguous leads. We're going to talk about that. You also have troponin elevation. So the definition of STEMI is the EKG changes and troponin elevation. You have to have those two things to have a STEMI. It suggests full wall thickness. Again, this is the traditional idea behind a STEMI. We say if someone's having a STEMI, they have these EKG changes, they have a positive troponin, we're thinking that they probably have full wall thickness involvement of their heart. When we talk about an NSTEMI, traditionally, to have an NSTEMI, you have symptoms suggestive of ischemia, you have troponin elevation, but importantly, you do not have ST elevation on your EKG. Now, you can have ischemic changes, you can have T-wave inversions, you can have ST depressions, but you can't have an ST elevation on your EKG. So that's, again, the definition of an NSTEMI. And again, traditionally, what we thought of when we diagnosed someone with an NSTEMI is that this was maybe partial wall thickness involvement. Now, I want to just pause here and talk a little bit of a change. We're having a change in terminology and the way that we think about people coming in with acute coronary syndrome. Has anyone heard of the OMI manifesto? Occlusion myocardial infarction. That's what OMI stands for. This is a relatively new concept. I think 2018 is probably when we first started talking about it. And the idea behind this is that if we say someone has a STEMI and they need to go for PCI, there are a group of patients who we've diagnosed with a STEMI, they're going for percutaneous intervention, we've taken them to cath, and they have a clean cath. There's nothing there. But more importantly, and this is what we really worry about, is we diagnose someone with an NSTEMI. We say they don't meet criteria for STEMI, and we're not going to take them to get emergent intervention. We're going to treat them medically and maybe eventually take them for cath. Studies have shown that we're missing about 40% of patients who may benefit from PCI. So there is this group of patients who don't meet criteria for STEMI. They technically fall under this NSTEMI criteria, but they are having an occlusive myocardial infarction. They have an area that needs reperfusion. And so the concept of OMI, if you start to see it or if you start to hear it, it's really moving away from these very rigid definitions of if someone has a STEMI, we're really worried, we're taking them to the cath lab. If someone has an NSTEMI, we're concerned, they get admitted, but we're not emergently taking them to the cath lab. We're moving away from that to trying to identify patients who would benefit from reperfusion therapy. And we're using a number of different factors to do that. Of course, we're looking at the EKG, but we're not just worried about patients with STEMI. We're worried about STEMI equivalents. We're worried about ischemic changes with a clinical picture that's concerning. So looking clinically at the patient, and then of course labs and other biomarkers. So really taking a more holistic approach, less rigid definitions, and trying our best to identify patients who would benefit from reperfusion. Because again, with these rigid definitions, we're missing people. And so that's the way we're headed. Unstable angina. What is unstable angina? So really, this is all symptom-based. There's no troponin elevation. These patients just have really concerning symptoms. So they have a change in their angina where they used to say, hey, yeah, I could get this really predictable chest pain anytime I did this one thing. But recently, I've been getting new and different chest pain with different activities. Or now at rest, I'm getting that chest pain. I used to only get it when I walked up that hill, but now I'm at rest and I get that chest pain. That's unstable angina. So when it comes to the clinical presentation of someone coming in, they've got chest pain, are we concerned, are we not? How are we going to flesh this out? This is one of the 2021 updates from the JACC, and they basically tried to help us decipher who needs, who has a cardiac etiology for their chest pain. Like, is this person having a cardiac event and they need intervention? We all know that is very challenging. It can be hard. Okay, if they have a positive troponin, boom, slam dunk. But what about these people who look really good, they're complaining of chest pain, and you're just not totally convinced, you're not totally sure if this is cardiac or not. So here's a few things. These are really the key points out of a huge document. I think this thing is like 50 pages. Don't waste your time reading the entire thing. These are really a few of the things you need to know. First of all, they're changing the concept of how we define chest pain. They're saying we should no longer be saying chest pain. It's not really a good name. We should be saying chest discomfort because, again, studies have shown over and over again that patients, it doesn't matter how they describe their pain. They could say it's sharp. They could say it's pressure. They could say it's tightness, and it doesn't correlate with whether or not it is a cardiac cause. Now, there are a few words in this document. They put a few words out saying you should really worry about this, and they say pain, pressure, tightness, if they're having discomfort in the chest, in the shoulders, in the arms, not just the left arm. Both arms, either arm, going to the neck, the back, the jaw, if they have some shortness of breath, even if they have some fatigue, you should be concerned. But the big point here is that you cannot hang your hat on the way that patients describe chest pain. Studies have shown over and over again, it does not matter what words they use to describe it, it doesn't correlate with whether or not that is slam dunk cardiac or not cardiac. So that's the big takeaway. What about accompanying symptoms? So the other thing that they note here is that yes, chest pain is the dominant and most frequent symptom for both men and women. But importantly, women are more likely than men to present with accompanying symptoms, such as shortness of breath. So whereas a man might present in that very typical way that we think of, that we read about all the time, women may have some other symptoms going along with it. And we just need to clue in that this still could be cardiac. And just because they're, having some nausea and shortness of breath with it, it doesn't mean that they have an upper respiratory infection or something else. This absolutely, it could still be cardiac. Women may present differently than men. And this is a trend, again, that's happening in medicine. We're recognizing that women are often overlooked and undertreated because they present differently. They present differently than the sort of classic teaching. And so we're trying to, cover those bases and recognize that women also, they present differently, and we need to be aware of that. Symptoms may be gone prior to ED arrival. So just because the symptoms are gone when you see that patient doesn't mean that they don't have a serious cardiac problem that is going to need intervention. And then finally, the terms are changing. They have changed their terminology. So in the past, we used to say, this is atypical chest pain. I don't think that this is cardiac. You're having atypical chest pain. They say that they no longer want us to use that term. They would prefer that we use the terms cardiac, possible cardiac, and non-cardiac. Now, here's the thing. I do think that it's useful to get rid of atypical chest pain. Like, what is that? What does that even mean? That's not very specific. It's not very helpful. It is something we used to use with women a lot of times. We would say this, it's a woman presenting with atypical chest pain. It's not useful. I think it's good to get rid of that term. But it's not helpful to suddenly say that everyone has to identify that this is cardiac or non-cardiac, because we all know that you cannot say something is non-cardiac unless that person goes to the cath lab. If they go to the cath lab and they have a completely clean cath, then you can say it's non-cardiac. But until that point, you cannot say that this is non-cardiac. There's no way to know, and that's a dangerous thing to fall into. So you could just say this is low-risk chest pain. That's a much safer term to use. I think that this is low-risk chest pain. All right, let's get into it. So let's talk about STEMI. What are the EKG criteria for saying this person has a STEMI, we are activating the cath lab? It's pretty straightforward. Basically, it is a new ST elevation. Hopefully we have an old EKG to compare to. We don't always have that, but a new ST elevation, it's at the J point is where you're measuring it. And of course, that's relative to the PQ junction, the baseline. It has to be in 2 contiguous leads in sort of an electrical distribution, right? Those distributions we already talked about. Inferior, 2-3 AVF. Anterior, V2, V3. It's got to be in a distribution. And it's greater than 1 millimeter. ST elevation, greater than 1 millimeter, contiguous leads. Boom, slam dunk, that's a STEMI. The only exception here is leads V2, V3. So that anterior MI needs to be a bit higher. And so in men who are greater than 40, greater than or equal to 40, we need 2 millimeters. In men who are less than 40, we need 2.5 millimeters. And in women, we need 1.5 millimeters. That's the only other thing you need to remember. When we see someone with ACS, you all know how to do this initial assessment. IV, get them on a monitor, we get a chest x-ray, get some labs. What's that chest x-ray for? Is that going to help us diagnose that this person needs to go to the cath lab? No. That chest x-ray is really to help rule out other causes of their chest pain. You're looking for things that could explain why they're here, aside from needing to go to the cath lab. For example, do they have congestive heart failure? Are they showing us that they have signs of a dissection, big widened mediastinum? Do they have a pneumothorax? That's what we're looking for on that chest x-ray. If they have symptoms consistent with ACS and you don't think they're having a dissection or bleeding, then you're going to go ahead and give aspirin, and that person needs PCI, emergent reperfusion. They need to go to the cath lab or they need to get thrombolytics. Let's talk some more about those meds. So of course, aspirin. That has been shown to have a mortality benefit, and the number needed to treat, I think, is 42. So that is something you're definitely going to do for your patients. Aspirin, aspirin, aspirin. You're going to start them on unfractionated heparin, usually, especially if they're going to go to the cath lab. And then in discussion with your cardiology team, of course, some kind of other antiplatelet. So that dual antiplatelet is aspirin plus, one of these P2Y12 inhibitors, clopidogrel or ticagrelor, which is always a hard one to say, speaking with your cardiologist. And then plus or minus nitroglycerin, depending on their blood pressure, what distribution this STEMI is in, and if their blood pressure can handle it. So again, right here, dual antiplatelet therapy, that is aspirin plus. So just what we talked about, either the Plavix or the ticagrelor. It could also mean a glycoprotein 2B3A inhibitor, which are listed here. Don't make me try and say those. That's another option. This is all in discussion with sort of cardiology and also what your institution uses. Sometimes we give all three. What about this old regimen, Mona or Mona B? I don't know if anyone's ever heard of that. When I was in med school, this is what we were taught. Yeah, if someone's coming in and they're having a cardiac problem, they're having a STEMI, go for Mona B. Morphine, oxygen, nitroglycerin, aspirin, beta blocker. This is fallen out of favor. A lot of these are not good or used anymore for a patient who is having acute MI. In fact, the two that are useful are nitroglycerin and aspirin, and nitroglycerin comes with that caveat that we just talked about. So let's talk a little bit about it. Morphine. There's been a number of studies about morphine, and the big concern is maybe it has bad for mortality is one of the big concerns. And the other big concern that people are pretty convinced about is that the antiplatelet medicines are not going to work as well if you use morphine. And so that is all listed here. There's been lots of different studies, kind of the stuff about whether or not this may affect overall mortality in a negative way has been debated. Some of the evidence is not quite as strong there, but there is very good evidence that it may delay the GI uptake of the antiplatelets or may inhibit those antiplatelet drugs. And so generally, we are not reaching for morphine for these patients. If you cannot get their pain under control, you've tried other things, usually nitroglycerin is first line, you've tried other things, you can't get their pain under control, then yes, you could reach for morphine or fentanyl to make the patient more comfortable, but just know that it comes with these caveats. What about oxygen? So this is so classic. We have these patients who come in from EMS, they're in extremis, looks like they're having a STEMI or they're having chest pain, and they've got nasal cannula on. And, I'll say to the team, were they desatting? And the answer usually is no, it's just on there for comfort. Don't fall into that trap. That is a mistake because oxygen can be harmful for these patients. All these studies have been done. Increased overall mortality, increased infarct size, recurrent MI. You only should place oxygen on these patients if they need it, if their oxygen saturation is low, if they are hypoxic. Otherwise, no, take it off. Nitrates. So again, nitroglycerin. This is a beautiful drug for, especially if that person is coming in with pulmonary edema, they've had an MI, they're in flash pulmonary edema. I love nitroglycerin, especially when the blood pressure can handle it. If they're, of course, very hypertensive, they have refractory chest pain, nitroglycerin is great. A couple of things. IV and sublingual are best. The transdermal is always on my patients. It's really good to just wipe that off. I mean, you cannot measure how much they're getting. Is it an inch? Is it an inch and a half? How much are they getting? How quickly is it working? So just immediately wipe that off. You want to be able to titrate this. Things change very quickly in these patients. So IV nitroglycerin is a very quick on and off. It doesn't last very long. It's much, much safer. While you're waiting for the nurses to set up that drip, you can give them some sublingual. And I always like to do that because I like to see how they respond to it. You give them a little sublingual and you see what happens with the blood pressure. If they've handled that, then you can throw them on the drip. They're going to be just fine. Of course, you're going to avoid using nitroglycerin in patients who are taking sildenafil because they can get refractory hypotension. Remember that. So it's a sensitive question, but an important question to ask your patients. Avoid it in patients who are going to get alteplase because it can increase the metabolism of alteplase and then make it less effective. What about aspirin? This I already told you. We're going to give aspirin. If there's no concern for bleeding, give aspirin. It has a small number needed to treat to have a good mortality benefit. What about beta blockers? The story on this is that they can be dangerous. You definitely want to avoid them in patients who are at risk for cardiogenic shock. And if patients are really, really sick coming in with a STEMI, they are generally at risk for cardiogenic shock. Anyone who has CHF or low cardiac output, not good to start them on beta blockers in the ED. I really never grab a beta blocker in someone coming in with a STEMI in the ED. It's something that can be started later once they're a little more stable with the cardiology team. What about heparin? Yes, we're going to use heparin, give it as a bolus, and then start the infusion. There's a procedural benefit for patients who are going for PCI. It can help to prevent thrombosis, and it can be a bridge to definitive therapy for people who are waiting a little bit longer to get to the cath lab. Statins, those again, I do not usually grab a statin in the ED. That's something that can be started upstairs within the 24-hour period. Let's talk a little bit about troponins. So troponins are, of course, INT are exclusive to myocardial cells, but they don't just rise when you're having an MI. We know this. There's a lot of different reasons that you can have a troponin, and we call this, type 1 and type 2 end STEMI. Is this demand or is this primary cardiac? What exactly is going on with the patient? So usually we use the terminology, this is a type 1 end STEMI if someone has a rise in their troponin, and we really think it's because they're having ischemia, this person is having a cardiac reason for it. Sometimes we use the term a type 2 end STEMI, you may have heard that, when we think that it's secondary to something else, like an elderly person who's septic, really, really septic, their whole body's under stress. A lot of times they will bump a troponin, and it doesn't necessarily mean that they need to be going to the cath lab. This is the sort of rise. They have a very predictable rise and fall. Rise within 3 to 6 hours, peak at 12 to 24. It should normalize in about 7 days. At our shop, we're not using the ultra-high sensitivity troponins, but I will say that in the latest guidelines from 2021, the ACC guidelines that I keep referring to, they do prefer high sensitivity troponins. But we're not using them at our shop. These are all, a bunch of reasons that you can get a rise in your troponin that have nothing to do with having an MI. I think we've all seen this, especially patients who are really sick with sepsis, other sort of insults to their system. All right, what is the treatment? What are we going to do for these patients? Remember, the clock is ticking. Time is heart. Just like for stroke, where time is brain, when it comes to an MI, time is heart. And our goal is to get these patients to the cath lab so that they can get PCI within 90 minutes of arrival. As soon as they arrive, you've got 90 minutes. That's your door to balloon time. And if you're at a non-PCI facility, you need to transfer that patient. You get a little extra time. You have 120 minutes. If you're going to give thrombolytic treatment, you have 30 minutes from the time that they meet you, from the time of provider meeting the patient, you have 30 minutes. That's the door to needle time. So who should get PCI? Who should go to the cath lab? These are really the sort of formal definitions. And I would again say, use your clinical judgment here, because there are going to be patients who don't necessarily meet this criteria, who have ongoing symptoms, who maybe have a concerning EKG, and you're going to need to push for them to get at least a cardiologist, someone to look at them, and maybe even to go to the cath lab. That's the whole concept between moving towards this occlusion MI, idea that we're trying to identify patients in a more holistic way. But the formal definition is here. So STEMI, anyone coming in with a STEMI and having ischemic symptoms, or if they have ongoing ischemia, if they've been having pain for a while, they're having ongoing discomfort, those patients need to go. Patients who do not have a STEMI, so they have an end STEMI, so positive troponin, but no STEMI on their EKG, but they're having hemodynamic instability. So these patients are in shock, they're in pulmonary edema, they're in some, they're in having runs of VFib or something like that. Runs of VTAC really would be probably more survivable there. So, they're having some arrhythmia. That is someone who you should push for to go to the cath lab. And then again, an end-STEMI with refractory ischemia. So they're having ongoing symptoms of angina. They're not looking good. Their EKG is not showing a STEMI, but they don't look good, and you're very concerned about them. And maybe they have some concerning findings on their EKG. These patients, you should push to go to the cath lab. And then what about thrombolytics? We talked about door to needle time. So we're going to use thrombolytics if it's going to be more than that 90 to 120 minutes from the first medical contact to going to cath lab. So if there's a delay, they can't get to the cath lab in that 90 minutes or that 120 minutes, then consider thrombolytics. If they have a large area of myocardium that's at risk, if their EKG shows that it's a very acute insult, where they're still having persistent ST elevation, and it's going to be more than 90 minutes. If they don't meet that timeline where they can get to PCI, then you should consider thrombolytics if you're not going to be able to meet that timeline. Of course, you need to review the contraindications before you give thrombolytics, and there are a lot of them. I often have to look these up. The options for thrombolytics include tenecteplase or alteplase. Tenecteplase is much easier dosing, and then after that patient gets thrombolytics, they do need to be transferred to a PCI-capable facility. Sometimes they still need to get PCI even after they've gotten the thrombolytics. This is just showing the sequence of an evolving MI, sort of how you get those hyperacute T waves. You may have the ST elevation then. You can get a little Q wave, a little Qing out. The T wave inverts, and then how it looks when you get reperfusion with those very deep inverted T waves. We're going to start talking now about specific EKG findings of STEMI. This is how the EKG leads match with the anatomic distribution. I also love this slide. So you can see there, 2-3 AVF, inferior. They're down at the bottom. That's an inferior MI. That's how those leads match up. Right across the front, those precordial leads, those are your anterior leads, your anterior MI. Your lateral leads, V5, V6, where the left circumflex comes around laterally. And then, and also one in AVL. You can see those are part of the lateral leads there. And you can see AVR way off in the distance, doing its own thing. It's like the complete reverse of everything else. And that is why when you look at the EKG, AVR is always so weird. It's doing its own thing because it's the electrical opposite of all these other guys. So a nice coronary anatomy picture here. So if you just kind of want to think about what coronary arteries being affected with what kind of STEMI, inferior or anterior, here's the anatomy, and here's the coronary artery that's being involved, and again, how it correlates to your EKG. So this is a very normal EKG. It's always nice to have a normal to compare with. Now we're going to talk about an anterior MI, and straight down the front of the heart, the anterior part of the heart, that's your LAD. Unfortunately, we call that the widowmaker. This is the left anterior descending. And this is what an anterior MI looks like. So pay particular attention here to V3, V4. A lot of times it's anterior septal, so V1, V2. V3, V4 will be involved, and you can see that ST elevation. There's reciprocal changes. So if you think about that heart that we just talked about, the whole anterior part of the heart, what's kind of the opposite end of the anterior part of the heart? Well, it's down here. It's that inferior part, and that's why those inferior leads, 2-3 AVF, get ST depression. They're doing the opposite, so that's what's going on there. Let's talk about a lateral MI. So again, that left circumflex coming around the side of the heart, what does that look like? Here's the lateral MI. You can see the ST elevation in 1 AVL, V5, and V6. It's a particularly, on this EKG, you can really see it in 1 in AVL. And then, of course, you get that reciprocal depression. What's on the other side of the lateral leads? You can kind of look again at 3 in AVF, maybe, again, that inferior area. Let's talk about an inferior MI. I don't like MIs, but if I have to diagnose one, I like the inferior MI because it's usually very clear on the EKG. You can really tell that someone's having an inferior MI, and you can it's jumping out at us, that ST elevation in 2, 3, and AVF with some reciprocal ST depressions in AVL. Posterior MI, this one can be a little bit tricky. Don't be fooled, because when you initially look at this, you're seeing ST depression, right? You're seeing the ST depression, and you might not think this is a STEMI, but you have to remember that this is a posterior MI. So if you flip that EKG upside down, it looks like ST elevations. And really what you're looking at here is the R wave in V1 and V2 compared with that S wave. That R wave is tall. Very tall. And you have an upright T wave. That is kind of a tip-off. You've got this really tall R wave compared with the S wave, and you have significant ST depression in V1 through V4. In this case, you can't see it quite as much in V4. That is your posterior MI. And when you flip that EKG upside down, hold it up to the light, again, you can see the ST elevation. Instead of going to the right, you'll see it, you can see here it's going to the left because they flipped this EKG. This is with posterior leads added. You do not have to get posterior leads. You can diagnose a posterior MI without the posterior leads, but they can be a little bit helpful in just confirming your diagnosis. But be warned that if you get posterior leads, which is really just extending the EKG around to the back and then having them run it again, and you can see here V7, V8, V9 is showing that ST elevation. Those are now our posterior leads. Be warned that if you don't see ST elevation in the posterior leads, and all you saw was deep ST depressions anteriorly, that can still be a posterior MI. So getting posterior leads and not seeing a change, you can still have a posterior MI, okay? So it's like you don't need that for confirmation of the posterior MI. That's the big takeaway. The last thing I want to talk about are STEMI equivalents, and some things have changed here. So these are equivalents in our mind, things we should really worry about, where you want to get cardiology on the phone, you may be pushing for this patient to go to the cath lab. You should be concerned about your patient if you're seeing any of these. Posterior STEMI, hyperacute T waves, we call those de Winter T waves. Now, in the past, the AHA only recognized one of these as a STEMI equivalent, and that was a left bundle branch block with original Scarbosa criteria. And I just want you guys to cross out that last bullet point because this changed in October. In October, they changed this, and now they do recognize de Winter T waves as a STEMI equivalent, and they also recognize a left bundle branch block with modified Scarbosa criteria. Those are now STEMI equivalents, as well as pacemakers. It has to be a right ventricle pacemaker, but pacemakers with meeting modified Scarbosa criteria meets STEMI equivalent. Those are new guidelines as of October. Just remind yourself what these look like, the de Winter T waves. They're just tall T waves, prominent T waves. They're in the precordial leads. They also have an ST depression, a smiling ST depression at the J point. It's like an upsloping ST depression going into a big T wave. The modified Scarbosa criteria, just remind yourself about that because I'm out of time. Number one, there's three of them. Number one and number two are exactly the same as the original Scarbosa criteria. It is just the third one that's different. That's what makes it modified. And essentially it says if you have discordant, so if the QRS is going down and you have ST elevation, so discordant leads, basically QRS down, ST elevation going up, you have to have that, and then the ST elevation. In the past, remember they said it had to be more than 5 millimeters. That was the original Scarbosa criteria. The modified now says it's relative. So it needs to be greater than or equal to 25% of the depth of that QRS. The QRS going down, ST elevation, greater than 25% the height of that down-sloping QRS. That's the modified Scarbosa criteria. And ST elevation in AVR with diffuse ST depressions, that is concerning for an LAD occlusion. That is something we're worried about as being a STEMI equivalent, not officially recognized. There was one other one that I wanted to mention that I cannot remember off the top of my head. I'm going to look it up. I'm going to put it in the chat. There was one other one that was also concerning that we should keep in our minds, but those are the big ones. And, I'm sorry, I'm going over, you're here now. Okay, great. The last thing I want to say is about chest pain risk stratification and sort of how do we risk stratify. Remember to use your heart score. That's the big thing. Use your heart score. Find out if that person is low risk or moderate risk. And the new guidelines, these are the updated guidelines, essentially say if that patient is low risk, so less than or equal to 3 on their heart score, they do not need urgent follow-up. That means in the next 30 days, they don't need any extra testing, such as a CCTA, a coronary CTA, or a stress test in the next 30 days. You've got like 30 days to play with if they're low risk. Whereas, remember before, we were like, you got to get follow-up within 48 hours. Now, they're saying low risk, no, you don't need emergent or urgent follow-up in the next 30 days. They're good. For moderate risk patients, you just kind of risk stratify and engage in shared decision-making. Moderate, intermediate risk chest pain patients, they may benefit from imaging, like a coronary CTA or a stress test, sort of depending on their age and risk factors, and you can engage in shared decision-making with them about that. They don't all need to be admitted if you can get them close follow-up. Just remember, women and young people do have MIs. They do present differently. There's bias in our care, especially with women, elderly, diverse patients. Keep that in mind. People may not present classically. A GI cocktail, even if that patient has relief, does not exclude ACS. Keep in mind red flag risk factors, which are listed here. And that's it. Thank you all so much.
I just ate 90 minutes of food in 30 minutes. So this is a great chat for after that. Okay, I know it's sleepy time. I know it's 2 o'clock after lunch. It's sleepy time here. Can't go to sleep on this one. Okay, this is a banger of a lecture. I'm going to explain why in a second. So take a look at the upper abdomen. It's really important that you understand the lecture right now is about upper abdominal disorders, things that anatomically happen in the upper abdomen. It's important that if someone comes in with the complaint of upper abdominal pain, that you, if this is one of the 3 things I want you to walk away from my talk, this is one. If someone comes in with upper abdominal pain, I need you, your patient needs you to have a broad differential diagnosis. Because take a look at what's north of the upper abdomen. It's the heart, it's the lungs. What's south of the upper abdomen? It's that pesky appendix. I'm going to read a text that I got from a boss, my boss at an urgent care clinic I worked at recently. Sorry. Mike, a patient came back in this evening specifically asking for you. Front desk knows the name. I talked to him briefly. He wanted to come in and thank you for probably saving his life. You sent him to the ER last week with right upper quadrant pain, but mentioned could be gallbladder, but also could be a PE. The ER did not work him up for PE and said he maybe had pneumonia on CT on the lower lungs when they were looking at abdomen. He persisted with his PCP, who ordered a non-contrast CT, but when at the imaging center, he asked if he could please get a CT angio instead because you had mentioned a PE. He's now diagnosed with a PE and on Xarelto. He is very thankful to you and wanted to let you know in person. These are the stakes of this game we play with upper abdominal pain, okay? So number 1, again, most important thing you can learn from this lecture is broad differential diagnosis when someone has upper abdominal pain. My previous anecdote I used to tell at the start of this talk is at our YouTube site, the ccmelive.org. Listen to my video there. I have another upper abdominal pain patient I'll never forget. It turned out to be something not in the upper abdomen. When it comes to people swallowing things and them causing pain, patients are actually pretty reliable in terms of localizing where the problem is. If they say, yeah, I was eating something and all of a sudden I felt something sharp right here, that's probably where their thing is, okay, their esophageal thing. Take a look at all this important next door anatomy to the esophagus here at different places, okay, C6, T4, T6, T11. The aorta is next door. The tracheal bifurcation is next door. So, you know, if you have something sharp that is in the esophagus and someone says, well, why don't we just push it down? We'll just shove a nasogastric tube in there and we'll push it down into the stomach here. What if this thing perforates and dings the next door neighbor of the esophagus? You can also all of a sudden be dealing with a second problem you didn't like. The first problem wasn't that great in the first place. Now they got a second one. That's really bad, okay? So it's really important to understand the anatomy here and what is next door to the esophagus. Lots of important things. Really get a good look in the throat, especially if they're describing pain that is really superior, because you might get that patient, look at that color photo there, like, I put my dentures in like 5 minutes ago, and now I can't find them. I don't know where they are. It's like, I found them for you, okay? It's important to be, here comes an aviation term for you, it's important to be ahead of the aircraft when it comes to these patients. What does that mean? It means that ideally, you reach in there and you grab the dentures and you high five and that patient walks out the door. That's the ideal situation here. What's not ideal is you go reach for the dentures and the person shifts or you go too far and you knock that thing down. And now instead of having a pharyngeal form body, now they have esophageal impaction or worse, something in their airway. Okay? So reaching in and grabbing stuff out of the mouth is not a benign thing. It's important to be ready to take advantage of supplemental oxygen or whatever else and get them ready to move somewhere else quickly if this doesn't work out the way you want it to. Okay? Imaging is not always required in terms of locating a foreign body. And really what we're looking for is people who have some sort of a foreign body sensation, but it's just like mild pain. If we're thinking they had something and there's absolutely no respiratory symptoms, not even a cough, no shortness of breath, if the pain is very mild, they're PO tolerant, then what's also just as common as something lodged in the esophagus is something that's scratched the esophagus. And now you have an esophageal abrasion, and those are quite painful, but only briefly. Only briefly. Okay. So consider your imaging here based on what you expect to find. I love chicken salad. This person really loves chicken salad. They're saving this for later, apparently. This is a foreign body impaction, esophageal impaction, okay? What I keep in my everyday carry, so to speak, right? I have my stethoscope. I have some smart books. I have some alligator forceps, because you can never find those things when you want them, okay? I keep with me a small packet of something called Easy Gas. That's the brand name. The trade name or generic name is called effervescent granules. These are basically pop rocks, okay? I get them from radiology when I don't still already have them on my person, okay? And so when someone I'm suspecting has an esophageal food bolus impaction, number one, how do I think that? Because they look super uncomfortable. They are heaving, they are spitting in an emesis bag, they're just like really looking like I have a hard time. They're not mildly symptomatic with an impaction that is not allowing things to go down. They can't even swallow their own saliva, okay? So what do I do is this, I give them, I kind of do it a little bit differently, okay? Because the like textbook way to do this is with 240 mLs of water. And some of you are looking at the overpriced 240 ml bottles of water in front of you and thinking, that's a lot of water to come out on my nice scrubs here, okay? So what do? I'll get 2 medicine cups from the pharmacy closet in our ER, and I fill the one with water, and I put the pop rocks in the other one. And I go to the patient and I go, have you ever had an Irish car bomb before? Here's what you're going to do. You're going to, and I let them drive the train on this because they need to be doing it quickly. You're going to take this, you're going to take the pop rocks and go, boom, dump them in the water, and before you even see the fizzing happening, shoot it and start swallowing. Swallow, keep swallowing, keep swallowing. And the idea there is that these effervescent granules mixed with the water create enough gas pressure and dilate the esophagus just so that this thing falls down. And I've had good relief, in patients with this when it works, okay? There's a lot of other things you can do. Again, if you don't think it's food, if you think something else is going on other than food, then yeah, you probably want to get some sort of films going on. Regardless of how successful you or GI is in resolving the impaction, it's important to tell these patients, hey, I'm so glad this is fixed. it's really important you still see gastroenterology for a follow-up. One study suggested half or more of these patients have some sort of anatomic abnormality causing the food bolus impaction. Maybe it's a web, maybe it's a ring, maybe it's cancer, maybe it's a neoplasm, okay? So don't let them go home thinking this is all, it's the end of the story here. This is the beginning of the story. They've got to go get follow-up here. So beyond the easy gas, what are the things you're going to see in literature? Okay, glucagon. Glucagon is the gastroenterologist's friend when it's 3 o'clock in the morning and they want to get a little more rest, okay? Try some glucagon, and then you can try some Ativan, and then give them some glucagon again, and then maybe give them some Ativan again, and just see what happens, and then, like, if that doesn't work, like, I'll be right in. You'd be right in, like, 4 hours later, after this patient's been suffering for 4 hours, like, okay, all right. You can see that the carbonation is there as well, and the kind of like the textbook way to use easy gas. But again, I think it's too much water, to be honest. Both of these things, glucagon, carbonation, both of them can cause vomiting. In fact, if you look at the studies on glucagon, about 10 to 12% of people with glucagon have resolution of their esophageal foreign body. Okay, except when you compare it to doing nothing at all, about 10% of those patients get better. So it's like, why am I even doing this exactly? Other than the GI wants it, and they won't come in until we try it, okay? Plus, add to that, what? I'm going to make this person vomit. Vomiting is not an uncommon side effect of glucagon. And if I have a closed space, and now this person vomits, am I setting this person up for some sort of a Boerhaave or other sort of a perforation here of their esophagus, okay? So just given benign glucagon is not as benign as you might hope sometimes. So be very careful. Watch for worsening, things happening after you have the glucagon, okay? Not yet ready for prime time, but mechanistically making sense is nitroglycerin. And I've seen folks just straight up dissolve it SL, or they dissolve it in water and then shoot the slurry. And either way, I mean, nitroglycerin is what? It's a smooth muscle relaxant. That's why we like it for heart conditions. It can relax the smooth muscle of the coronary arteries. Well, why wouldn't it relax the smooth muscle of the esophagus and let things fall down? There are some case studies where it works. If some of y'all are in a rural shop where GI is a couple hours drive away, then might be worth considering, and if it saves someone a transport, then maybe it's worth considering. Talk to your collaborating clinicians and see if it's a good idea for y'all. This is what you don't want to see when you take imaging of a patient as they swallowed something, okay? This stacked pancake sign of a button battery, okay? Button batteries in the stomach are not that bad, and especially in the intestines, because they get coated with food and coated with poop, and that's fine. Those usually pass relatively harmlessly as long as they get in there pretty quickly, okay? But you can see, third bullet, 6 hours. We have a 6-hour clock after the swallowing before damage can begin, okay? And again, this is just the beginning of the story. Ideally, you recognize the problem, you get the battery out, everyone high fives, and the patient goes home. There's sadly enough one case study of a patient who 18 days after the button battery was removed, the child had esophageal perforation and passed away, bled to death, okay? So these are straight nasty, and if you catch this in a patient and it's like a sentinel event, it should be really talk to the patient. Don't scold the mom or dad, of course, but just express upon them like, this could still be bad. If the patient gets sicker after we go home, it's important you bring them back right away. Don't just think, oh, they're just upset from the procedure, whatever else. You got to bring them back if they're looking worse. I wish that, like EMRs are supposed to become more clinician-friendly, like helping us to make good diagnoses, right? Helping us choose medications at the right doses and such. I wish EMRs, like if you typed in esophagitis or gastritis, I wish that little like Microsoft paperclip would pop up and go, hey, it looks like you're trying to diagnose somebody with esophagitis. Have you actually scoped them to confirm that's what they have, or are you just kind of putting that in there? Okay? Because esophagitis is a very specific diagnosis. It's an itis of the esophagus. And I think it's very dangerous for us to assume somebody coming in with nonspecific upper abdominal pain, you work them up for all the acutely bad things, and it's negative, and it sounds like esophagitis, that you just diagnose them esophagitis with no history of same, okay? Because what if it is something else more serious? I think there is some medical legal discussion to be had here that, hey, if this person goes home and has a bad outcome, well, Mike, you sent them home telling them they had esophagitis. Did you warn them that this could be something else more serious, that they had to follow up with GI, with cards, with Pulm? Okay. So nothing at all wrong with just calling it what it is. You came in with upper abdominal pain. You came in with chest pain. And we don't know why. It sounds like esophagitis, and we're going to give you discharge instructions on that, but we still don't know what happened here. Okay? So be real careful with anchoring on esophagitis. And like Jessie said at the very perfect dovetailing into my talk, okay? Just like I set her up before her talk saying, hey, there's new AHA, ACC things coming on here, and she talked about it, perfect. She mentioned the GI cocktail. There are too many bad stories of people coming in with upper abdominal pain and the clinician on duty saying, let's give you a GI cocktail or a PPI or an H2RI, something for esophagitis, and the pain got better. And they go, oh, I gave you the treatment for esophagitis, your pain got better. Clearly you have esophagitis. And they go home and they have their MI and they die at home. Okay? So these tests are not, these treatments for pain are not diagnostic for esophagitis. Like the natural time course of certain emergency cardiac events is for the pain to go away. Okay? So don't anchor and say, oh, well, that's must be what happened. I gave them something, it fixed it, and they must have this GI etiology. Be very careful there. Again, gastritis, same thing. How do I know it's itis of the stomach and not something more serious like a cancer, like a gastrin-secreting tumor, like whatever else here? Just call it abdominal pain. And it's okay to be nonspecific in your diagnosis here. That almost cues them to be like, you need more tests done, dude. Let's talk vomiting. I mean, I feel incomplete when my shift is over and no one's vomited in my presence, honestly. It's like, wow, 11 hours goes by so quickly sometimes, you know? Such a common complaint for us to deal with as emergency medicine clinicians. So let's talk about vomiting a little bit, okay? So again, don't assume a benign cause for this thing that is usually treated relatively easily, okay? Lots of things can be going on here. I mentioned how glaucoma earlier I talked today can have visual disturbances, headache, nausea, and vomiting. Sometimes you can have bowel obstruction. Sometimes it could be an intracranial issue. Maybe some sort of electrolyte abnormality is either secondary or primary reason for the vomiting here. Maybe it's cannabis hyperemesis syndrome. Let's talk about it. Who here works in a state where they've legalized marijuana? Keep your hands up if you're thrilled about this. Right, exactly. It's terrible, okay? So many patients come in because there's enough people that have this kind of rare side effect where it really messes and causes a lot of GI distress, okay? The problem with cannabinoid hyperemesis syndrome is that the vomiting is very resistant to the typical things we give for stopping vomiting. And the second problem is patients who have cannabinoid hyperemesis syndrome are very resistant to the idea that they're vomiting because they're potheads. Okay? No, man, this is therapeutic for me. Okay? All right, that's fine. So I think about this a lot in patients who come back to the ED regardless of age, who come back over and over again, negative workups, and they keep coming back and describing how they just can't crack their vomiting. Okay? So how do I get a good answer from somebody about whether or not this is related? Okay? You got to kind of do a jab, uppercut approach. Let me explain. Okay, patient. How often do you use tobacco? And I don't care unless I'm assessing them for like cardiovascular risk. Okay? And I'm saying how often, not do you or do you not, like I'm trying to entrap them or something, okay? I just assume like, oh, you don't smoke? Okay, well, a lot of people smoke, that's cool. How often do you drink alcohol? Whatever, I don't really care necessarily. How often do you use recreational drugs? And not do you or do you not, and it's not do you use illicit or illegal drugs like I'm a narc or something, okay? Like I just want to know, you know? And if I still think, like if they say no and I look down and they're wearing like marijuana leaf, you know, Crocs or whatever, I'll say like, okay, the only reason why I want to know is that sometimes people who smoke a lot of marijuana, there are other medicines that I can give that help them feel better faster. That's what I care about, is making you feel better faster. And by the way, I think marijuana is a great drug, I tell them. I think marijuana is a great drug. And at some point, we're going to be prescribing marijuana in the ED. I want to let them know I'm on Team Green, right? Like I'm open to this marijuana thing, okay? And eventually, some people will be like, okay, I do smoke every day. I was hotboxing it in the car before I walked in here, actually. Okay, so yeah. So sometimes you got to ask the questions in a certain way to get the right answer you want, okay? What works great for that is haloperidol. Haloperidol, 5 milligrams IV. Be careful about giving it to people who already have long QT syndrome or who are on other drugs that could give them acquired long QT syndrome. Like if you just gave them Zofran, don't chase it a minute later with haloperidol because both of those drugs can prolong QT. Okay? I like sometimes to get a good history early and give haloperidol as the first drug. And often that's enough to turn my scream vomiting lions into little lambs after about 45 minutes of that. Okay, so it works really good. If it's not contraindicated, then there's capsaicin cream. This cream derived from peppers you can apply gently to the backs of the arms and the abdomen. Just watch for the eyes. But that is a way that we can help people with this cannabinoid hyperemesis syndrome feel better. Okay. Many of the drugs that are available here, we know about Zofran. Ken Milne, SGEM blog, did great discussion about whether or not we should be worried about this in first trimester pregnancy. And the answer is it depends. Who's the OBGYN? Okay, because some OBGYNs hate Zofran early in pregnancy and some are cool with it, okay? Metoclopramide, Reglan, great for different kinds of nausea and vomiting, safe in pregnant ladies. Prochlorperazine, fantastic for migraines and vertigo and pregnant ladies. Now, if you look at, let's say, oh, it's a category C in pregnancy, and it is for heavy use in the third trimester. So in the first trimester, that's when the majority of the hyperemesis is going on anyways, you can go ahead and give it early for that. Promethazine is tricky. Understand what your local guidelines are. Some places will only want it given intramuscular because it can cause this, vein necrosis if it's injected in a concentrated way. We recall the whole GI bleeding thing. If it's bright red, it's from a lower source. If it's black or melanotic, it's from an upper source. And that's generally true. Nice to peek back at the rectum and see, are there fissures, are there hemorrhoids that could be causing especially bright red bleeding going on. Good to do a good thorough physical exam there, okay? If it's upper, if it's more melanotic, then think about varices, okay? Why am I worried about varices, or how am I to be worried about varices here? If they have a known history, of course, but if there's a history of some sort of heavy alcohol use, or liver cirrhosis, whether it's from alcoholic cirrhosis or other kinds, hepatitis can cause non-alcoholic cirrhosis here. So any sort of liver history, I'm worried about somebody who is having upper GI bleeding as having varices, okay? Now, what do? Someone rolls in to your ED, and they look like my mom did when she went in to the ER a little while ago, and you peel her eyelid down, and it's white. It's pale white. Should be nice and pink. This is my quick, easy CBC from triage. I look under your eyelid. Is it white? You probably need a transfusion. If it's pink, you probably don't. Okay? And she was white. So you can give a little bit of saline up front. You don't have to crush them with liters and liters of saline. These people need blood and not pasta water. So if their pressure's a little bit soft, you can give like 500 cc bolus of normal saline. Get some coags going. You can do a type and screen early. You don't have to wait until the hemoglobin comes back low. Start that out of triage, okay? My mom, because she is well past her childbearing years, got emergency release Rh positive blood. We think of like, oh, the universal, donor is O negative. We really only care about that Rh negative positive thing in ladies who are of childbearing age. So gentlemen and ladies without a uterus or past childbearing years, it's okay to give them the O-pos blood as long as it's cross-matched appropriately. They can get that. What else can you do? I mean, there's usually people saying like, you got to put them on these PPIs. You'll see orders for pantoprazole. You'll do a bolus and then a drip afterwards. And that's a common practice, but not really supported by a whole ton of evidence. So you could pick your PPI, you could pick your H2RI. Those are things you could do, okay? And if we really think this is esophageal varices here, then maybe you call GI early, and you don't wait for them to continue to bleeding for the next hour and a half, and you finally get back to hemoglobin that's low, you knew it was going to be low, and now you call GI. Get them on the phone early. Okay? Warfare, if it's good for nothing else, is at least good for advancing the practice of medicine. And so we figured out early in GWAT is that when you have to really dump blood into somebody, a balanced transfusion protocol, so you're giving not just PRBCs, but also plasma, but also platelets. When you're doing large volume transfusions, you got to think about that all these things have been bled out of the patient, you've got to replace all of these things. If you're just doing 1 or 2 units, don't worry about that. But if you're giving, 4+ units or other, whatever your local criteria are here, understand it's more than just ordering PRBCs. If the patient comes in and they say, oh, I'm on these anticoagulants, understand there are likely some sort of reversal agents, and you can look into that as well. Early on in our 2-view career, we did an overview of pancreatitis and all the things that we thought we knew about pancreatitis maybe aren't true, okay? So why is pancreatitis bad? Briefly, the pancreas secretes enzymes that dissolves carbohydrates and fats. We're made of carbohydrates and fats, okay? So if we have this inappropriate secretion of these destructive enzymes, we are kind of eating ourselves from the inside out. And pancreatitis can cause a lot of things beyond just pain and nausea and vomiting, and you can see those things there, to include death, okay? It's about half and half in terms of the most common reason, alcohol and gallstones. Small amount of folks, triglycerides play a part. Too many drugs to list in this slide could be the causative factor, to include marijuana, so just be careful. If someone smokes it up all the time and they have rip-roaring upper abdominal pain and nausea and vomiting, it's poorly controlled, what did I say at the start of this talk? Broad differential diagnosis. Maybe it's not the pot. Maybe they're right. Okay. Lipase is the money. I wish they would just take away our ability to order amylase from the ER. Doesn't help us be any more clear in our diagnosis here. Good suggestion that ultrasound early is the key, especially when pancreatitis comes in on the first day. The things you find, if you're sure this is pancreatitis, the bad CT findings you find with pancreatitis come about 2 or 3 days into the course of pancreatitis. So if they're here on hour 6 and you're positive nothing else is going on here, you can spare the CT scan for the hospitalist to do. Lactated ringers. This is one of these places that maybe there is a benefit in mortality with giving LR over NS, and you just want to bring them back to volume neutral. Used to be that we would just hose these folks down with NS. Not as important anymore. Just bring them back to volume neutral. We figured out what? These people are third spacing because of the inflammation. So if I just shove all this fluid into them, we can put them at risk for things like abdominal compartment syndrome. That's nasty. Okay. Take a look at the second and last bullet. Our turkey sandwiches are therapeutic for these patients, okay? Early PO intake, even on the first day, whatever they can tolerate, get them eating again. It gets blood flow going to the intestines, and it kind of reduces mortality as well. So many things we thought about with pancreatitis are kind of being turned in their heads a little bit here. I recommend you take a look at that JAMA review and listen to our podcast, okay, episode 3. The old school way to risk stratify pancreatitis was the Ranson's criteria. There are many new ones now. I like the BISAP criteria, and you can kind of see how that works here. And what's cool about BISAP is you get every single one of these data points in the ED. So you know when you're done with your workup in the ED what they got to do in terms of their risk. Okay. You're not going to have somebody with mild pancreatitis and pull the sheet back and go, oh my gosh, and see Cullen's or Gray Turners. These are serious pancreatitis patients. These patients will be sick, sick, sick. These patients have been dissolved so badly on the inside that they've dissolved all the way into vessels. And now they're bleeding from this pancreatitis here. Okay. So look, document, pretty rare unless they're super sick. Hepatitis, generally milder in terms of the severity, and there's different reasons. We mentioned 2 of them already, viruses and alcohol. Overdosing on Tylenol is one, and there are other things, exposures that can do that. In general, you just kind of feel bad. You have malaise, there's some discomfort, but it shouldn't be rip-roaring terrible. Sometimes dark urine and skin color changes can be the key here. As long as there's no other reason to bring them into the hospital, a lot of these folks can go home, saying, hey, it looks like you have some mild hepatitis, important to follow up in GI. Okay? If you have hepatitis or person with history of alcohol use disorder and they're kind of out of it, consider this as not them being drunk, but them possibly having hepatic encephalopathy. And how do you know that? You run an ammonia on these people who are altered with an alcohol use history, or their LFTs are off, okay? We think of LFTs as our liver function tests, but really they're just like liver injury markers. What's a good liver function test? Our coags, okay? Liver helps us stop bleeding. So get coags if we're worried about the liver being off, okay? And then other reasons to bring them in here, they're just too dry to go home. Otherwise, some things are bad here. Elevated bilirubin, maybe we got to look and do an MRCP and make sure there's no occult stone in the ducts here, that sort of thing. Okay. Speaking of biliary stuff, almost all the time biliary disease has to do with stones. Okay. So maybe you're wondering, okay, well, how do I know in triage or upon first contact this person has cholecystitis versus just cholelithiasis? Lithiasis being painful stones, itis being needs surgery today or tomorrow, okay? A lot of it is in the good history. If this pain has come up and it's already coming down by the time they come into the ER and it's brief, like 30, 60-minute exacerbations here, this is probably just lithiasis, okay, just the stones. If it's been 3 or 4 hours of constant pain, no breaks, no matter how mild it is a presentation, I would suggest not a bad idea to get an ultrasound at that point. This constant not colicky pain could be beginnings of cholecystitis, okay? If I could impress 2 points upon you during my lecture, the first point is keep a broad differential diagnosis. The second point is serial examinations. Serial examinations. Because what's the other thing we're going to do after this patient here? I think you have stones. I'm going to give you some pain medications, do an ultrasound. I'm going to come back in an hour. I come back in an hour. Oh, you're not better. Your pain's not better, or it's migrated, or there are now you have peritoneal signs. Okay? That's your cue that maybe something is evolving or something is changing. Okay? So a broad differential, do serial exams on your abdominal pain patients. Okay? You can see here how there's many, many places these stones can get hung up. Ultrasound is your first line on the ED, but there's other things like HIDA scans, ER, and MRCPs. These are kind of rare things you're probably not going to see, but if you see them, the patient's going to be sick. So if they're really, really sick, expand your differential to maybe it's these things: acalculous cholecystitis or an infection of the biliary tree itself. If there's absolutely no signs of inflammation and your patient's getting better with typical treatment in the ED and their labs look okay, then they can go home with clear precautions. If I could impress 3 things during my lecture, it's going to be broad differential diagnosis, serial exams, and give them appropriate time-critical discharge instructions. Hey, I think you have gallstones. Go ahead and go. And if you're worse, just come back. No, I want you to come back in 8 to 12 hours. 8 to 12 hours if your pain is not better or worsening, or even sooner if you want to come back, okay? Timing is important. Those are my 3 things. Broad differential diagnosis, because this could be anything, anywhere from PE, MI, down to appendicitis. Serial exams, make sure they're getting better before you send them home. And timed discharge instructions. Thank you so much.
Thanks, Mike. All right, a couple of quick housekeeping things here. If you may notice, there's a lovely diesel smell in the room. Apparently, Planet Hollywood decided to do their generator test, and the exhaust fumes are through the AC system. We're told that it should be clearing out soon, but if it is too much for you, you need to step out for a few minutes. There is the live stream. If you go to ccmelive.com, is that right? .org. See, I knew I was going to screw this up. I kept practicing it, and I said the wrong thing. So, but ccmelive.org if you need to step out of the room and want to watch me remotely or whatever. So, otherwise, without further ado, we're going to try and keep things rolling here, being a little bit behind. So, asthma and COPD, this is always something that is hard because while they very much complement one another, it's a lot of information to process. I'm going to warn you in advance, there are slides that are here more for reference purposes and not things that we're going to go and dive in detail, mainly because of time. So when I'm going to point out those slides as we go and say, hey, this is a reference point, this is something to look at later, or as we're talking about, severity of disease, those kind of things. All right, so asthma is an inflammatory disorder with the lungs. It is something that is chronic in nature, and a lot of times, in early childhood or when it's not certain the diagnosis isn't definitive yet, it's called reactive airway disease, and that's truly a separate condition, but quite a few children who have reactive airway disease will morph into asthma. Asthma exacerbations are when there are episodes of worsening of symptoms. There can be obviously the shortness of breath, the wheezing, the chest tightness, but also cough. The cough is something that sometimes people forget about, and that might be the only symptom. There's cough variant asthma, and cough variant asthma can still lead to exacerbations and can still be a good source of why people are bouncing back. So if you have someone who keeps bouncing back, shortness of breath, especially when they've already had the cardiac workup, they've already had the PE workup, and they keep coming back. And I speak out of experience. This happened to me a few months ago where this person's now back after being seen by 2 of our physicians and 1 of our NPs, and then I'm talking to them and realize that no one's giving you a breathing treatment yet. Well, let's try that first, and sure enough, symptoms clear up. And so then we give her a steroid, and everything goes well from there. A lot of times people who have cough variant asthma, they will just have these vague symptoms until they get diagnosed. So something to keep in mind if you have someone, especially who's bouncing back, who's short of breath, who's only maybe complaining of coughing and everything else in the workup looks okay. With the pathophys here, so there's kind of more the acute early stage, and that's more the bronchospasm, the sympathetic and the cholinergic response, and then there's this airway inflammation that develops hours to days into it, which leads to all these kind of hyper-responsive issues, which is why oftentimes we're giving steroids to try and help calm that down. So a big part of asthma and COPD management is early intervention, which requires early recognition. And again, the being able to tell us, a lot of your patients who have asthma are going to know that they have asthma. Some may not, and for those that aren't, this is obviously a little more tricky. But if they come in with the classic symptoms of wheezing, shortness of breath, and especially if they're younger, then that makes this a little bit easier. The goal of the therapy, though, is to reverse the bronchospasm and to reverse the inflammation. So that's where we give our albuterol, our steroids, stuff like that, which we're going to talk about more here in a moment. And then the goal for chronic therapy is to modulate that immune response. So things I like to ask people when they come in, they're short of breath, they're wheezing, and I'm trying to figure out, is this asthma? What symptoms are they presenting with? Again, wheezing, shortness of breath, chest tightness, and or cough. The cough, again, is going to be common in kids, and a lot of times can be associated at night or with upper respiratory infection. It's good to ask about severity of symptoms, and that's not just about how often you use your inhaler or if you have other kind of just vague symptoms, which can be fever, chest pain, that can be from other stuff too, but also the really important things. Have you had to be hospitalized for this before? Have you ever had to be intubated before? And those are things that I usually ask with people who are a little more severe, and I'm trying to get an idea of gauging, okay, how severe is this exacerbation compared to previous, and do I need to already kind of prep for potentially more airway involvement or at least more interventions early on. So these are, again, risk factors of death from asthma. This is something that's just kind of more of a table here to look at, but essentially bounce backs or people who have had to be intubated or they have certain comorbidities like drug use, stuff like that, all puts them at higher risk of death from asthma. And then with differential diagnosis, there's tons of different things that can go on here. So not everything that wheezes is asthma, and not all asthma is wheezing. So this is, again, something to keep in the back of your mind, especially if you have someone who's starting to have other things with it, like stridor, in which case I'm more concerned about some kind of upper airway issue. And again, this is something to be more of a reference for later as something to pay attention to. Now, with asthma examination, not only is it going to be, again, listening for that wheezing, but also what's their speech pattern like? Are they speaking full sentences? Are they speaking in 1 to 2 word sentences? There's some movement as far as some people are more recommending, instead of judging off of words, how many words can they speak at a time, is having them count. So have someone count and tell them like, hey, I want you to count to 10. And as they count to 10 out loud, how many numbers can they say before they have to take a breath? And that's supposed to be a little more standardized approach. Again, the concept's still the same. The other thing to notice is that if you have someone who has a silent chest, so you listen and there's nothing moving in there, this is very concerning for a severe exacerbation. And that severe exacerbation, if you start treating it, re-listen to their chest. A lot of times now you'll hear the wheezing because now they have more airflow. But if they have very, very minimal airflow at first, they're going to have this silent chest. But also, what else do you think about if you hear a silent chest? You can think about pneumothorax, which can be another complicating factor. People can have an asthma exacerbation and a pneumothorax going on, terrible luck. But also there can be other things that are going on with it too. So this is something where I'm going to just kind of plug here real quick that ultrasound is super helpful, because chest x-ray is not bad, but may not help you pick up some of these more subtle differentials when you have someone who's coming in with shortness of breath. Is it asthma? Is it COPD? Is it pneumonia? Is it a PE even? And there are different ways of doing that. It's something that I love teaching about with point-of-care ultrasound or POCUS is about the lung examination is something that can be pretty quick and easy to do, and especially if you're working in a rural or remote setting, or if you are working in an environment where maybe it doesn't make as much sense to be able to get a chest x-ray right away. But even if you have a chest x-ray available, it won't always share all the data with you. The other things to watch for: respiratory rate. Are they breathing fast? I get really concerned if they have a silent chest and they're starting to slow down their breathing, because this is someone who's an extremis and is someone who's going to tank really fast. And these are one of the very few people that I'll intubate with asthma exacerbations. If they're to the point that they're tiring out and they're starting to slow down their breathing on their own, and they've got a silent chest, this is someone that, generally speaking, we don't want to intubate these patients, but this may be the person who needs the intubation. Also, do they have retractions or accessory muscle use? Are they diaphoretic? Again, these are things that would be concerning for more severe cases. Cyanosis, it's often a later sign. That's not something that we want to see. And then mental status change, again, it puts that at a more severe disease, and also someone who might be a higher risk, who might need intubation. Pulse oximetry should be a big thing along with the rest of your vital signs. This is someone who should be on continuous pulse oximetry. This is someone that should be in a spot that's better to monitor than, say, your kind of fast track type of rooms. Although a lot of staff will like to put them in the fast track rooms, thinking it's a quick in and out. Many of them are, but not all of them. Also, measuring their PEF and their FEV1, and by checking that, this can give you a lot of information. Who actually, just by a quick kind of show of hands here, who is doing pulmonary function testing in the emergency department is like trying to figure that out, like that percentage? I see one hand. Okay, and I totally believe that because that's something that we don't usually do. It's something we probably should do, but we don't usually do. And there's a good reason why. I mean, we can usually clinically kind of establish that. But it is something that I'm trying to do more, the peak flow, peak expiratory flow, that's what the PEF stands for. And I do that because if I have someone who's in a little more of a severe episode, I can see clinically how they're improving, and if we're on the right track, that maybe this is someone who's on track to maybe still go home, or maybe just needs a brief observation period, something like that, versus needs admission. And that's something that, again, is a quick tool to use. It can help you with classifying the asthma severity. Oxygen, obviously, if they're hypoxic, giving them medications to help with the initial events. And then if you have someone who's in a more severe case, this is someone you want to get IV access on because they might need more than just a little bit of albuterol and steroids. This is someone who might also need a higher level of evaluation in the hospital, so they might need ICU or at least a step-down type of setting. So again, these are things that we want to figure out early on. With albuterol, we talk about albuterol. That's the most common one to use. You can do it as an inhaler. You can use it as a nebulizer. If you use the 2 puffs, that is pretty consistent with that 2.5 to 5 milligram range that we're giving via a nebulizer. Nebulizers are just easier and also makes it a lot easier for doing the longer treatments. So you can do things much higher than that. A lot of times if we do an hour-long nebulization, we're usually doing more like 15 milligrams at a time. A common question I get asked is, can you give someone too much albuterol? The straightforward short answer is no. You just keep making smoke until they start breathing better. It's kind of one of those things that even with pediatrics, their heart rate will increase, but it'll only increase so far. You won't make their heart explode. I've never heard of that, kind of happening sort of thing. But it is something that if I'm using that much albuterol and it's not improving the situation, we need bridges for other things. We need 2 other medications because that's obviously not enough. So some of the things that we can do here, again, talking about nebulizer equivalent versus the albuterol inhaler equivalent. But some other things that we can do here, we can do ipratropium bromide. Almost all my asthma exacerbations when they're coming in will get this as well, usually as a single dose, but I'll do it multiple times if needed, again, trying to help bridge them until the steroids are kicking in and or other medications. There are other beta agonists besides albuterol that you can use. Levalbuterol is one. There's also epinephrine that you can use. The levalbuterol is supposed to help decrease the amount of tachycardia that can be going on. The epinephrine is something that is usually, basically the way you kind of dose it, if you notice that 0.3 to 0.5 milligrams is very similar to how you do it with anaphylaxis, and it's the same basic approach there. There's a couple of thought processes as why, but one of them is that this might be underlying anaphylaxis that could be going on with it. But the epinephrine, again, can help, and it can be a bit of a bridge. You can also use other medications like terpbutylene, which is used subcutaneously. That's an important kind of one to remember. So both your epinephrine and your terpbutylene, if you're going to give those, are given sub-Q. When it comes to the steroids, there's lots of different options. So oral is just as effective as parenteral in the right dosing, but if I have someone that's going to end up staying in the hospital or who's in extremis, they're obviously going to get the IV or IM steroids instead. If this is someone who's going to bridge to home, usually if we're talking about prednisone and equivalent dosing, it's often about 40 milligrams a day or 1 to 2 milligrams per kilogram for kids, and that's usually for about 3 to 5 days in kids, 5 to 7 days in adults. I usually split the difference and do 5 days for everyone. Also, there are other steroids that you can use, which the idea there with the steroids is kind of more of ease. A lot of people don't tolerate prednisone as well as maybe dexamethasone, which you can use instead. Usually that dose is like 12 milligrams orally because they usually come in 4 or 6 milligram tablets, or doing 10 milligrams IV IM, which if you had this like the Croup lecture, you can do that 10 milligrams IVIM formulation, mix it with something or just have them shoot something right behind it, but mix it with something that tastes better than steroids, which is not hard to find, and then have them drink that, and that dosing is very effective for that role. And usually if you're doing it, it's that same kind of Croup dosing of 0.6 milligrams per kilogram, up to 10 milligrams. And then pretty much if you come to the emergency department with asthma acting up at all, you're going to get a steroid. I think the only time that maybe I don't give it is literally someone's here, they got lost on their way to urgent care and they just need a refill of their albuterol, but they have no symptoms going on. Or they lost their medications, they recently moved and they don't have a PCP. Okay, you probably don't need a steroid then, but let me just make sure that you're not in exacerbation. That's why you came in. The other thing with the inhalers that makes life a little more complicated is that inhalers tend to be quite expensive. If you're fortunate enough to work in a spot where you can get them a nebulizer and supply that from the emergency department, that can make life easier because the different nebulization vials are much cheaper to do than, say, actually getting an inhaler, which can be $100, $200 quite easily. These are all the different steroids that you can look at here. Again, great table, not enough to talk about right now. So what are some other things that we can use for someone who's in impending respiratory failure? The one that I will reach for if my terbutaline, my epinephrine, obviously my albuterol, my ipratropium aren't working, and we haven't quite got the full effect of the steroid kicking in, is doing magnesium. It's a shorter bridge, but it's something that can be quite effective. Usually I'm doing 2 milligrams in an adult. In kids, it's anywhere from 25 to 75 milligrams per kilogram, up to, again, 2 grams. It has a shorter half-life. There's lots of things to be careful with magnesium, though. There's a certain way you need to dilute it into a certain amount. It depends on the concentration that's there. It also matters about how quickly you give it, because it can induce hypotension. You have to kind of keep in mind the electrolytes in the background going on as well. So magnesium is not to be taken lightly, but in a critical care situation, if everything else isn't working, the magnesium truly is the next step there. Drugs not to use in asthma. So the methylxanthines, they have a lot of side effects with them. Antibiotics, unless you're suspecting that this asthma exacerbation is from a bacterial pneumonia or another bacterial infection, don't just give them antibiotics. And then, the other things that really don't have proven benefits are like aggressive hydration. It's good to help someone if they're dehydrated, but not too aggressively. Mucolytics, and then sedation. Overall, most people, especially if their peak expiratory flow is 70% or higher from their baseline, and they're able to tolerate PO, they're ambulatory without shortness of breath, those people can go home. That's pretty straightforward. Make sure that they're getting started on steroids, they have proper albuterol, and very careful instructions about return precautions. If they're not quite there, either this is someone who needs to stay with you longer, potentially more in an observation state, or get them fully admitted to the hospital. With the medications, we've already kind of talked about this. Steroids are a big part with this. You can also do inhaled corticosteroids with it, but usually we're going to do an oral steroid and then making sure that they have that albuterol available. COPD. So there's a lot of crossover with COPD and asthma, which is why obviously it gets put in this lecture. COPD is essentially emphysema, chronic bronchitis. We think of those kind of two classic ones, the pink puffers and the blue bloaters. If you're remembering way back in school, if it's been a few years, like it has been for me. As far as how, again, you take care of this, it's quite similar overall, and it has a lot of the same underlying pathophysiology where there's airway inflammation, and we're trying to calm down the airway inflammation, but also there's a certain amount of parenchymal destruction that's going on as well. And in combination, this will lead to an obstructive airway process that, again, we're trying to reverse, or at least trying to help avoid with the exacerbation. Just like the people with asthma, I'm asking them a lot of the same kind of questions as you may see here, as far as, what's their medical history like, how do they have certain risk factors with them, if there's certain other things that put them at higher risk, that's all good to ask about. Their presentation is again going to be similar. It's going to be this like cough, shortness of breath, wheezing type picture. They may also have fever, especially if it's been induced by like say pneumonia or COVID, flu, RSV even this time of year. We've admitted quite a few older adults who we would traditionally never test for RSV, and this year we are, and finding that quite a few of them are having RSV. We've had a couple die in our hospital, secondary to complications from RSV. So this is something that, again, traditionally we're not testing for, but when they test negative for flu and for COVID, we end up doing that test, and sure enough, it's positive. Also, keep in mind chest pain. They could have something else going on. They could have ACS. So examination is going to be very similar. We're auscultating for wheezing or rhonchi or any kind of rales. We're also looking for, again, that airway movement, accessory muscle use, those types of things, as well as other things that we expect to see in older adults who may have multiple comorbidities, such as signs of heart failure, that pitting edema, for example. This is, again, something we've kind of talked about, the blue bloater, pink puffer type of picture, and this is talking about, the heart failure part. This is something that's kind of a classic thing. It's good to just kind of have as a reminder. For examination purposes, we have the chest x-ray. Again, I will use lung ultrasound if I really need more detail, and especially if it's someone who they're sick enough I can't get them over for a CT, but otherwise I would want them to get a CT, and my x-ray is really not telling me a lot. The ultrasound can be super helpful here. Getting an EKG, doing pulse oximetry, maybe an ABG or a VBG, and this is less emphasized in asthma because it usually doesn't change our management, but in COPD, it has a little more of a role here because of their, having hypercarbia, or if they're very acidotic. That's something that we want to know about because that's something that we also need to address at the same time. The gold therapy, this is again a very helpful table, a lot to go through, something that you'll look at separately. And then same for all these maintenance medications for COPD. There's a ton of them, and it seems like there's more medications coming out all the time. This is something that's more just good to know as a reference. These are usually not things you're going to prescribe from the emergency department. And then when we're talking about inhalers, it's the same kind of thing. There are certain ones that we're going to use relatively frequently. Again, that's like our albuterol and whatnot. But it's good to know this, and also it's really good to, with patients, especially if they're coming back quite frequently, asking them if they know how to use their inhaler. And usually I don't ask it like that, do you know how to use this thing that we've prescribed you a dozen times? It's more of, can you just show me how you use the inhaler? And a lot of times I'll have this with RT, and so that way RT's there watching them do it, make sure, like coaching them through it all, and it puts a lot less emphasis on the patient and, hey, you're doing things wrong, to now it's an education point, and it can sometimes really avoid some of the complications we get. If you've ever had to work in like true primary care, family medicine, internal medicine, stuff like that, you'll very quickly find people who are incorrectly using their inhalers. I've had people like sniff the albuterol. I've had people like spray to the sides because they didn't like the taste in their mouth, so they thought if they just aerosolized it was working. So there's all sorts of things that people mess up, and it's worth that education moment. You think like, there's no way you can misunderstand. You put it in the mouth and you squeeze. Like, yes, there is. There's plenty of ways to screw this up. So it's good to make sure that there's that education moment. And again, I like to do that with RT because then they can really kind of coach people through. And also, in talking about those cash-strapped patients, we've just given them an inhaler from the emergency department. That's something that they can take home with them. So management of exacerbations, again, it's a lot of the same stuff as asthma. So we're doing the albuterol, the ipratropium, we're doing the systemic corticosteroids, possibly antibiotics, depending on the situation. This is something that's become, I think, actually more controversial with time. Is it used to be pretty standard that you'd give a COPD exacerbation like everyone who came in, antibiotics. Now it's maybe only certain circumstances. It's kind of interesting point of debate that's changed over time. Again, methylxanthines, I always screw that up, sorry, but they are also not recommended. Again, side effect profile, minimal benefit. Otherwise, something that you can also do with asthma, but really we do this a lot more, I feel like, with COPD type patients, is doing that non-invasive positive pressure ventilation. So that's CPAP or bi-level. And some people may not be familiar, but bi-level and BiPAP, that's the same thing. BiPAP's just the actual kind of brand for it. This is usually best in people who are like hypercarbic, they're in severe dyspnea, they are very hypoxemic, and they're not improving with the breathing treatments or regular oxygen therapy, like a little bit of a nasal cannula. And the settings are important to be mindful of if you start giving someone a non-invasive ventilation, to make sure that you're keeping in mind how bi-level works, which that's its own separate lecture, and don't have enough time to kind of explain vent settings, but just be mindful when you are setting someone up for bi-level how you're watching your vent settings. Again, antibiotics, controversial. There are some different options that are recommended if you decide to go that way. I really think, again, it's important to keep in mind what the source is. This is pneumonia that you're treating for. Is this an I'm not sure kind of thing? Trimethoprim sulfamethoxazole or clarithromycin are used. I tend to use personally just more doxycycline. There are some people who might benefit more from amoxicillin clavulanate, but again, that varies. Quinolones, probably not as good an option, because a lot of people who we'd want to use quinolones in are also people who are not good candidates for it. They're elderly, they have certain comorbidities such as kidney disease or other stuff that puts them at higher risk. So why do that when you can use something better? There are multiple black box warnings for fluoroquinolones, so including one for like myasthenia gravis. It can exacerbate that, but there's just a lot of kind of things to be careful with those. So it's good to kind of shy away from those and try and use other antibiotics when possible. Also consider hospitalization. Again, if there's a marked change from their baseline, if they're requiring oxygen when they normally don't require oxygen, or they're requiring a significant increase in their baseline oxygen, or if they're requiring a lot of treatments, these are things that really, this is someone who should stay in the hospital for at least some time. But if you can get them controlled quickly, like we do with the asthma patients, then they can also go home. So as far as follow-up, I try and encourage everyone to make sure to follow up closely with primary care. If they don't have a pulmonologist, I try and refer them to a pulmonologist. That's true whether you have asthma or COPD, because it's good to have those people involved when you can. Understanding that some of us, and myself included, especially early career, the closest pulmonologist can be 100 plus miles away. Okay, is there someone in the area that can function like a pulmonologist for this purpose? Someone who can do the right testing, who can really help manage the care more locally. Making sure that they understand how to use their medications. Again, the inhalers, it'll blow your mind if you start asking them, if you aren't already doing that, how many people use their inhalers incorrectly. And again, just looking for other possible causes as far as what led to this in the first place, what exacerbated these symptoms. So I've actually caught up on some time. You're welcome. And it looks like we have Martha. Makes minutes earlier.
Good job, Chip. Thank you. Oh, I'm so glad that Chip got to talk about asthma and COPD, so I did not have to. Whew. But we're going to stay in the same vein, and we're going to talk about colds, influenza, and more. Not so straightforward. A lot of things on the market, a lot of things off-label, a lot of different illnesses going around. How do we treat them? Cold, flu, upper respiratory, pneumonias. Whew, it's just a lot coming in. In fact, our emergency department right now has multiple admissions for RSV pneumonias. COVID's still out there. and more. So these patients that are coming in with flu-like symptoms, right? They come in, they've got a headache, insomnia, they could have toe pain, and be, oh, by the way, I got some flu-like symptoms, right? Fever, wheezing, body aches, chills. Could be a lot of things. Even just simple rhinorrhea. I've got a runny nose for a week. What's wrong with me? Do I have sinusitis? But of course, did you consider the coronavirus, right? Certainly, absolutely, could still be COVID. Even in our vaccinated patients, COVID is still a thing. But this talk is not going to be about COVID. The following illnesses that we talk about should be considered when dealing with COVID. Could you have COVID and influenza at the same time? Sure. Is that really what you see every day on a day-to-day basis? No. What's really important here, if you want to ask patients to get a better idea about their history with COVID, you ask them if they got the vaccine. Which vaccine did they get? We know there's some literature out there that says some are a little bit better than other ones. And you can always get a rapid COVID test. In fact, in my emergency department, we still have to get COVID tests for every admitted patient. Anybody remember the show Ren and Stimpy? This is how I feel when patients come in with flu and cold-like symptoms. What is it, man? I don't know. Could be so many goddamn things. I don't know. Upper respiratory infection, acute bronchitis, influenza, something else. It's very, very, very difficult some days. But what I like to do, one rule of thumb, that I teach all my students and I live by when I work those triage shifts, right? I come in for my 11 to 11 shift. The 7A person is already pulling out their hair. The docs in the back are like, good luck. I mean, there's already 50 in the waiting room. I don't know where you want to start. It's like, how can I help? They're so happy to see me, right? I love those mid-shifts, for those of you that work mid-shifts, right? You come in at 1 o'clock. It's like, oh, I could finally take a lunch. You're here. This is my mnemonic to help you cut through the patients, right? Cut through the drama, make your shift a little bit easier. Slice, dice, and slit them. You say, I'm here to slit the patients, okay? What that means is that you go through the waiting room, okay, if you're in the triage area, or even the rooms, there's patients still to be seen. Read a little bit of the HPI that the nurses put in there. You get the subjective, right? What are they telling you? Then you listen to their lungs. That's the L of this. Do they look ill? And the timing, how long has this been going on, will tell you a lot about what type of respiratory illness this patient has going on. So let's try to slit this patient right here, right? The upper respiratory illness are URI, the typically not so sick patient, right? So remember this as we go through each of these. This patient doesn't really look that ill. In fact, you probably look worse than they do, right? Because you're at work with some horrible cold that you can't get rid of, or COVID, or whatever that's fatiguing you for the last 20 years of your career. So basically, these patients are like, I'm sick, and never underestimate the power of a work note. Listen, if any of you want a work note right now, I will give you one, okay? You just ask. Send it right off tomorrow. So basically, upper respiratory, they're from the neck up, right? Runny nose, sore throat. They don't usually have muscle aches, vomiting, and diarrhea. Their lungs are clear. Their lungs are clear. And in addition, it's pretty self-limiting, just a couple of days of these symptoms. So typically what I tell these patients, symptomatic treatment, we'll talk about those snake oils in a minute, but essentially, this will get better on its own. If you are worse, I want you to come back. Rest. There is some literature that supports nutrition and hydration for all of our illnesses that we see in the emergency department, except maybe CHF. Don't overload those. Symptomatic treatment with over-the-counter meds, like I said, the only ones that really show any effectiveness here, honey, a few antihistamines and decongestants, which we'll go through here. There is some literature that has gone out over the past couple of years about zinc, vitamin C, and echinacea, but they have to be taken within a certain window. They have to be taken in certain doses, and they're not very good studies, and if Ken were here, he'd tell me to stop talking about them immediately anyway. Antibiotics and antivirals, they do more harm than good for these patients. Please don't give them a Z-Pak. They don't need it. Acute bronchitis diagnosis. This is one of the top 10 diagnoses that we get in the emergency department. Now, when you hear a buzzword like that, right, you should think to yourself, well, shit, I should know about this, right? Because it's in our top 10 diagnoses. So you need to know acute bronchitis. You need to recognize it when it comes in, and you need to slit that patient and know that this is what to do with them. So this is what we do. On average, these patients are getting 2 prescriptions and they miss 2 to 3 days of work because they're a little sicker. Their symptoms have been going on. They're coughing, coughing, coughing. They can't sleep at night because they're coughing, coughing, coughing. It's persistent. And you can't just tell these patients, whatever, you'll be better in a couple of days. Additionally, they might have some variable symptoms, simply depending on if they're a smoker. Now, I know when my smokers are really sick with acute bronchitis because they're too sick to smoke. Because you know those hardcore smokers that are dedicated, they'll smoke in -2-degree weather, they'll smoke when they're sick as shit, and they'll smoke in the ER if they could, and they do. So, these are the patients I take pretty seriously, and I occasionally will treat with antibiotics. But the best thing that you can do for these patients is give them an albuterol inhaler. They might complain of chest pain. You definitely are going to hear a wheeze, right? So their lungs aren't clear. Subjectively, they're telling you that they've had some shortness of breath. They've been hoarse. They've had body aches. Maybe some rhonchi and rales. And the timing, like I said, right, when we're slitting these patients, is about 2 to 3 weeks. They've been having symptoms for quite some time now. So typically, I don't get an x-ray. I get x-rays in some of the higher risk patients. If their lungs sound really junky and they have some underlying comorbidities, sure, x-ray's fine. And as Diane said earlier in the question and answer panel, if you're going to get a chest x-ray, can you get 2 views? Get the second view. You can see so much more with that lateral view. You should definitely get it, in my opinion. I was mentioning that in my hospital, when I order a 2-view, they still only do 1 frickin' view. And I'm like, what the heck? Like, my order doesn't even matter to you people over there. So I got to call and say, yes, I really do want the lateral view. These patients also might have a little fever, a little tachycardia. There might be an underlying influenza, pneumonia, COVID. So I would say, if you're going to get the chest x-ray, not a big deal. To me, an x-ray for a patient that maybe has a history of, obviously, cancer or tuberculosis or prior pneumonias, heavy smoker, sure, why would we not? The medical literature provides very little support for providing antibiotics, but certainly if there looks to be something that looks a little fluffy and you're concerned about pneumonia, if you can get this patient breathing a little better with an inhaler while you're in the department, then you can do that and discharge them home. Now, of course, if this patient has a raging pneumonia and acute bronchitis and they're febrile and tachycardic, you may have to proceed with some more additional imaging or even an admission. Every patient's going to be a little bit different. There's no blanket statement here for how do I tell the difference between an upper respiratory, acute bronchitis, and a PE or severe pneumonia. It's going to be the patient. You got to look at them. You got to see, got to go through the whole history, physical, and exam. But generally speaking, as we've already talked about, upper respiratory illness and acute bronchitis are patients that are pretty easy to identify and send home. Pneumonia patients might be a little bit more tricky. So these e-cigarette or e-valley vaping-related illnesses, they were a real big thing a couple years ago. If you remember, they were in the news all over CNN. These are these acute lung injuries that occurred from smoking the e-cigarettes. The problem with these e-cigarettes is not just that, you know, it's a chemical into your lungs, but they were laced with a lot of vitamin E. And the lungs, they don't like vitamin E. So that was what was causing these really severe acute lung injuries. A lot of them were in young, otherwise healthy men. They'd come in with this bilateral pneumonia, young people, trying to figure out what was going on with them. What we found out is basically that there are just so many chemicals in these cigarettes that the lungs just couldn't take it, and they developed really severe illnesses. We treated that with steroids, and you can still do that if you are suspecting someone who vapes a lot and has a pneumonia, a bilateral pneumonia. As of 2020, the deaths and the cases have gone down, but these are the patients that will come in with similar symptoms as our upper respiratory and then acute bronchitis. However, the difference about the timing of this is it came on like that. But it's not like the flu, because with the flu, they tend to have body aches. They might even have some nausea, vomiting. But with these the e-cigarette acute lung injuries, they're essentially telling you, within 10 hours, I couldn't breathe. Lungs get really tight. And of course, the key here is that they're smoking the vape. So again, steroids and maybe some high flow oxygen. I don't want to spend too much time on influenza. You know, even now, there are still people that are choosing not to get the flu shot, and you know, that's fine if they don't care about their health, that's fine. But there are other reasons why patients don't get flu shots, so never make anyone feel bad. It may not be what you're doing. You can just give them the information. You never want to make someone feel bad about that. However, we do know that vaccines work. So a lot of data out there shows that anyone over 65 years old should be getting this higher dose Fluzone. So some of our older patients, for those who are working in geriatric medicine and nursing, you should consider offering that. There has been a documented rate of lower risk of hospital admissions and it being more effective than the standard. So that's the flu zone. Then, of course, there's the live versus inactivated. It doesn't really matter which one you get. They both do a pretty good job, except we don't like to give the nasal one to pregnant women, children under 2, adults over 50, and the immunocompromised. So take that into consideration with the live vaccine. Children with acute, moderate, or severe COVID-19 should not receive the influenza vaccine until they've recovered. This is a CDC recommendation or guideline. I don't know how much merit is in that, how much time and effort we put into studies for that, but that is their recommendation. Children with an egg allergy can receive the live vaccine, okay? So if someone tells you that they have an egg allergy, it doesn't mean that they can't get that live vaccine. And as we already talked about, the pregnant women can get the inactivated at any time during their pregnancy. Doesn't matter if it's first trimester or the last, they can get it at any time. And of course, still safe to breastfeed. Often, you can get your flu shot while you're on shift, which I think is really convenient at most hospitals. Every hospital I've ever worked in, it's like, oh, I see the flu nurse walking around. I'm going to be documenting, and she'll come up and she'll be like, do you want your vaccine? I'll be like, yeah, put it in this arm. I'm still documenting. She gives me my shot, and I go right back to work. No change at all. And the American Academy of Pediatrics, in regards to children, in regards to vaccination, they suggest that anybody working, it's not on the slide here, but anybody working in a peds environment, it's a mandatory vaccination for them. Now, I know in some adult critical care, it's not mandatory. In some hospitals, it's not mandatory. But the AAP suggests that it be mandatory in their pediatric units. And lots of other accrediting boards have suggested the flu vaccine. There are a couple of random reports that I put in here from the CDC. You know, I like the CDC for a couple of reasons, and I don't like them for other reasons, but they do have this really cool mapping system called FluView. So if you want to get really nerdy and go in there and take a look at some of their statistics, you can see what the flu is doing all over the country and the world. Well, what does the flu look like? So let's split these patients, right? Subjectively, man, like it's been a full day of just like, I feel like I've been hit by a bus, is a common complaint. They have fever, they have a cough, they have body aches, they have the whole Pepto-Bismol commercial, right? Everything. Sometimes it's pretty difficult to determine what this is with COVID out there. I know, it's difficult. But if you want to get a flu test, if you want to do a rapid test, there's a PCR test you can do, and you can get results within 15 minutes. Pretty useful stuff. Very good literature to support that they're very accurate. And you can also test for multiple strains with these different cards. So remember, just ask which one you're using in your hospital, and you can use that one to test pretty quickly. Now, I'm just your messenger, you know. I get in trouble with Diane sometimes when I put in my own personal opinion, which I'm not going to do. But I will tell you that it's difficult when a governing body, I'll repeat what I said the other day, like the CDC gives you a recommendation and you don't do it. If that patient has a poor outcome or they die, some lawyer's going to get up there and say, well, a national governing body called the CDC has said this is what you were supposed to do and you didn't do it. I mean, that's a tough battle to fight, right? I'm not saying that giving antivirals or not giving antivirals, or neither one of those answers seems to be correct to me. I think it's every patient that comes in, you have a shared decision making, you give them their options, you document it, and then you guys can come to a decision. There are some people that I just give it to because they're at higher risk, and the studies somewhat support our higher risk patients with antivirals. Excuse me. But the CDC suggests the following. If their test is positive for the flu, if the symptoms are less than 48 hours, and there are no other contraindications, treat with antivirals. That's all I'm going to say. You can decide what you want to do. Okay, let's say you've decided to treat with antivirals. You got 3 to choose from here. I don't need to go through all of these in regards to the dosing and the timing and the age restrictions, but what I can tell you is Tamiflu is still pretty popular. It's a pretty easy medication to take. And you can give it to a lot of different types of people. It comes in a pill or a liquid. The other ones, you've got an inhaled, and then you have an IV. You can preserve those for those particular types of patients who they may benefit from. Biloxavir marbovil. Yeah, they keep getting better with these names. This was a newer antiviral. It's otherwise known as Xofluza. And it's a single oral dose pill. The cost may have come down slightly, and of course, GoodRx may have more coverage for this, so you can take a look at that. But Michael Sharma let me know that actually now it's been approved for children 5 years of age and older. Same dosing, but you can give it to kids. So if you could make that correction in your book, that would be great. 5 years and older. That's a lot of extra ages, right? Woo, like that. And it's a single dose oral pill, and it can be crushed. Claims to be more effective than Tamiflu for resistant strains. So, hey, why not consider it? Why not consider it? There is some literature behind this one. But I bring my friend Ken back into the discussion. You should still be skeptical. There are people that you shouldn't give antivirals to. There can be some side effects. A couple of medical legal things. Remember we talked about how, okay, Joey has the flu, mom isn't checked in, but she kind of is like, oh, I might have a runny nose. Can you also write me for some Tamiflu? No, don't do that. First of all, does she really even need it? Is she a pretty healthy otherwise person? How sick is she? How did she do on her slit exam, right? Medical legal, you should never treat anyone with a prescription or anything else unless they're signed in somewhere, just to protect yourself. Now, have I ever done it? Of course I have. Of course I have. But just be very careful about what you do, and especially if you work in a hospital that says, if you prescribe outside of these hospital walls, we will fire you. There's not like, 3 chances and you're out. This is a one and done. I remember when I worked for EMA, who is now Alteon. If anybody works for Alteon, that's one of their rules. Okay, so now we're going to get to the hard place here. Well, should I say between a hard place, a rock and a hard place. Because I'm going to give you some information, and then I'm going to basically tell you it's all crap. So this is the problem. Does anybody recognize this face? Well, she's only part of the problem. There's so many problems, I don't even know where to start. But this woman right here, she was a Dallas cheerleader. And she got the flu shot. And all of a sudden, she started walking backwards. And there are all these videos of this woman walking backwards from the flu vaccine. And she was like, I don't know why, but all I can do is walk backwards now. I mean, cool. I kind of like that. I'm like, I want to try it. Give me one of those. Anyway, after all of this, it turned out that it was a big lie and a hoax. And she wanted some kind of whatever career. But unfortunate, because people saw that and they go, oh, that poor cheerleader, she can never cheer again. But what about this fake news? There's so much stuff going on. Oh my God, I just can't stand the fake news. The flu shot or nasal spray can cause the flu. Can it? False. The shot does not cause the flu. The nasal spray does not cause the flu. Period. The flu shot can cause body aches and a low-grade temperature, possibly. But in these randomized double-blind studies, there showed no difference in side effects from the flu shot versus a saltwater injection. People be like, I'm getting a shot, so it's going to hurt and I'm going to have body aches, right? No. You made that up in your brain, right? We do things sometimes. That's why there's this thing called the placebo effect. It's a thing. And the placebo effect has also been studied, which is a very interesting topic if you ever want to go down a rabbit hole. How about this one? The flu shot causes Guillain-Barré syndrome. Actually, maybe. It's very, very, very rare. But yes, it can happen. I have seen it in the pediatrics department. There's usually a lot of other things going on with patients that get that, but I'll tell you, it can happen to otherwise normal, healthy people. Very, very rare, though. Other fake news. Children who have never been vaccinated before need only 1 flu shot. False. They need to get two flu shots. That's what the AP recommends. How about the flu shot works right away? No, it's not like if you guys got your flu shot right before, like the day before you came here, you might get the flu, sorry. Egg allergy, we already talked about this. You can definitely get a flu shot even if you have an egg allergy. Okay, myth busting, milk consumption during colds. It does not worsen the symptoms or thicken secretion. So you tell grandma she can go suck it, all right? She's wrong. What about the color of the sputum? You can also tell grandma that she is 100% wrong, okay? It can be green, orange, black, brown, purple, sparkly. I don't give a shit unless it's bloody. Then I care. Then I want to investigate blood. On average, you swallow about 1 liter or 1 quart of snot a day. That is true. Hey, look, this is my drawer at home. Look what I got. Scissors, prescriptions from 1985, some extra work notes, some saran wrap, some condoms. What else we got? Some hydrocodone. All right. Over-the-counter medications are definitely a mixed bag. Look at all these things we can take. Just look at, this isn't even all of them. Look, this is my pharmacy. And this is just one section of the shelf. Big old pharma. Do you know where the term snake oil came from? Originally, in the 1800s, early 1900s, maybe even back to the 1700s, there were these salespeople that went around selling these elixirs. Sometimes they worked. They'd give them for a little bit. And then they'd come back and they'd supplement them with a little cocaine or a little opium or some other amphetamine. And they'd get these people hooked on these snake oils. And they're snake oils because they don't work. They were actually called liniment oil or snake oil liniment oil. And they'd get them hooked on their train, sort of like Rodin and Fields, you know? Sorry, people. Nasal decongestants, there is some merit in that, and we will get to that, and some antihistamines. But all these other things in the other column, yeah, NSAIDs and acetaminophen can help you with your fever and body aches, but some of these other home remedies, yeah, I don't know. Sudafed. I'm going to say yes to Sudafed. First of all, I took 3 just for fun right before this talk, and look at me go. Decongestant, absolutely. Makes me more awake, oh yeah. But what is really great is people with eustachian tube dysfunction, ear problems in general, just those people who get on a plane and immediately their head feels like it's going to explode. They don't have great drains in their ear areas, right? So as we get older, right, when you're born, your ear tubes are like this. And then as you grow, they slowly bend down and drain better. That's why kids get so many ear infections, right? Because their tubes are flat. Now, some people, they just have shorter heads and faces, and I feel bad for them. So, you know, they still got those shorter tubes that don't drain well. And something like Sudafed can help them. In some of these studies, at least 7 crossover studies, just a single dose of phenylephrine, 10 milligrams, was considered effective. The only side effect is, again, it can cause some tachycardia and some bad jokes. So, nasal decongestants, also neosynephrine and Afrin, you got to be careful with these. Yes, I can put these up my nose, and they might relieve my runny nose for a little bit, but I can't even tell you. I wish, you know what, I'm going to take a video next time, and I'll have it for this talk, that basically you can use these. They'll clear out your nose, but you want to be careful of the rebound rhinitis that can happen. Medicamentosa. So basically, if you use this for more than 72 hours, your nose will run like a faucet. I'll never forget the last time I used Afrin for like 5 days straight. I just put one finger on the nose and then I let go and it just dripped straight down. It was disgusting. But it was clear, you know, and I felt good for 3 days. So yeah, be careful. Even the news, you know, they warn the consumer about this. It's on the box that it can cause this rebound rhinitis. And these are the phenyllephrins and oxymetolazine, otherwise known as neosynephrine and Afrin. What else can I put up my nose? I can tell you some other things. But the literature supports Flonase as being a really nice glucocorticoid spray to help with those who have asthma, really severe colds or rhinitis, people with nasal polyps and inflammation. And believe it or not, this is the treatment for rebound rhinitis. And rebound rhinitis can last a long time from the Afrin or neosynephrine. So this might be something that you might want to introduce. Some people take Flonase every single day for their allergies. The only problem is that it can cause the nose to be really dry. And so I tell people to shove some Vaseline up there and then be wary of epistaxis. Cromolyn sodium, great studies in kids. This is a mast cell stabilizer. This helps control rhinorrhea, throat pain, and cough. I think it's a great drug. I've used it. I tried to go away from the Afrin and the neosynephrine and go to this because it's more of a clean out. Mast cell stabilizers are a little less toxic to the nares. What about I'm tired and I need to sleep? Oh boy, look at all these crazy snake oils. Anything that comes in a combination package for $15.99 is some bullshit. You do not need to be buying that. NyQuil, waste of time. ZQuil, waste of time. That other medication by the generic pharmacy, waste of time. If you're going to take a drug, take the drug that you want to take, and then add the next drug that you want to take, right? So if you want to take Tylenol, and then maybe you're going to add some phenylephrine. Fine, okay? You don't need like a big combination anything. Excuse me, you'd more likely add Sudafed. But these NyQuils and other sleep aids, they put Benadryl and some other crap and garbage, and you just don't need it. And in fact, has anyone ever taken one of these? Because if you do, you feel worse the next day. I never feel better after taking these. Antihistamines may assist with sleep, so take a straight-up Benadryl, 25 to 50 milligrams might help. Here's some words on zinc and echinacea. So many mixed studies. The current study suggests that possibly zinc lozenges, if they're used within the first 24 hours, multiple doses of this, 100 milligrams a day, maybe it can help you. But the FDA actually issued a public health warning against nasal sprays because they can cause that permanent anosmia or the loss of smell forever. Echinacea, there have been studies back and forth over this. The last randomized review trial might help benefit in preventing colds in some way, but it doesn't lessen the symptoms. So once you get sick, echinacea is no good. So if your friend calls you and say, oh, I'm homesick and I'm taking lots of echinacea and zinc and vitamin C, you could be like, well, that was a waste of $30. You could have taken me out for drinks. In fact, we could have had tequila shots and maybe like a codeine pill, and neither of us would be coughing, right? Other ideas. Vitamin C, look, I'll let you read through this slide. If you're really healthy and you're one of these fitness people, those are the trials that they did. These really healthy people already didn't get sick taking vitamin C. I'm not sure those really healthy people already would have gotten sick anyway. So you can take a look at these studies. They all say something different. How about these expensive essential oils and rubs? Well, you'll smell real good. But at $23 a pop for something this big that's gone in 2 days, I don't know. Oh, look, Grandma's rubbing that Vicks Vapor on the chest. Okay, look, you can still use that. It's just so cute when you do that with the kids. Onions in the socks? No, it doesn't work. But you can try. You'll have no friends. Antitussives? Okay, what about that cough, that really annoying cough? So Tessalon pearls are benzonatate. Oh, God, that's Michael Sharma's one of his favorite drugs. He loves that drug. Again, I think he took that just for fun today, too. Albuterol and other inhalers, they can be expensive. As far as dextromethorphan, it can come in a tablet, syrup, spray, lozenge. It can be addicting. You can get real high off of it. Don't get any ideas, people, all right? Do not take it with MAOIs. And the SSRI people, you might want to throw a little caution to as well. And you don't want to take it with multiple cups of grapefruit juice because that doesn't allow it to be able to be processed well. There's this thing about grapefruit juice and a few studies that suggest you should avoid that. So just maybe let patients know that in a little smart phrase. The thing, though, is codeine. Codeine's still a great antitussive. I mean, when I was 12, 13-year-olds and I got sick, my dad, who was an emergency physician who actually recently passed away this year, he gave me a shot of tequila and a codeine, and I slept like a baby. He said I didn't cry at all. And look, I turned out okay. One for you, one for me. One for you, one for me. No, I joke, but actually, really, that is what he did. Children and antitussives, the American Academy of Pediatrics basically says that quieting a cough is not needed in healthy children with a cold. Let them cough themselves to sleep. When it starts to bother mom or dad or the guardian, maybe then we need to look into it because you're really treating it for them. The kids don't care. How many of you have had kids that just cough, 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 and they're like, they just sleep. They just sleep. Older children, I like Delsum. Delsum's a good drug. You can use that, but a caution in kids under 4. And the codeine, yeah, like I said, 12 or 13. You don't want to be giving codeine to kids under 12. What's really interesting is that honey and pineapple, recent studies have shown, extremely effective. I put a little slide in here about honey because I like it so much. I know when my daughter's super sick, even now she's 8, but she'll be like, oh, I have a cough. Does that mean I can have some honey? I'll just be like, nom, 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 nom. She wants to eat all the honey because she's like, she loves sweets. I've done her wrong. How about expectorants? Mixed bag. Sometimes when combined with the dextromethorphan, an oral dose, that guaifenesin might be useful for that patient. Maybe they've used it before and it's been helpful for them. You can ask them. That's another key thing that you can ask patients. What did you use before the last time that you had a cold like this? Or what did you use the last time you had acute bronchitis? Did you get inhalers? Did you get steroids? You know, these types of questions, again, these patients are all going to be variable. The mucomist, inhaled formulations for expectorant use may be helpful with those who have emphysema, chronic bronchitis, some of our lung patients, but usually these people, they tend to be a little bit sicker. I'm very careful with them. Our cautions, multiple reasons to do nothing at all. Watch out for hypertension with our decongestants. Watch out for prolonged QT syndrome with macrolides like azithromycin or diphenhydramine or phenylephrine. Be very careful. Acute narrow angle glaucoma patient might want to consider that antihistamines might affect their pressures. Caution, I warned you, polypharmacy, it's dangerous. It's like if you start with beer, you just keep going with beer. If you start with whiskey, you can have a tequila, but you stick mostly with whiskey, all right? Don't change too much. Polypharmacy, ugh. Antibiotic diarrhea and dehydration can certainly occur if these patients are very sick. And I'm not going to be the first to tell you, but the man flu is real. I have experienced it firsthand. And I'm sure I'm going to experience it again. All right. I'm 2 minutes behind. I'm sorry. Thank you very much. Oh, we have a break. You get yourselves a break. 15 minutes, please.
Should we wait one more minute to be exactly 15 minutes late? Here's a reminder, if you're going to leave early tomorrow, that you still have access to all the lectures that are going to be given tomorrow by going onto that website, and you'll be able to see them. In addition, I ran about probably 10 minutes short, maybe a little bit longer than that, at the PEDS talk, and I wanted to talk about PEDS fluids, one of the things that really comes up all the time. So I'm going to do that at the very end of the course, and just to have it recorded kind of thing. And you're welcome to stay or you're welcome to go, because it doesn't matter. You'll have access to it on the website. So now let's talk about pediatric infectious diseases. This is kind of an important topic in that most hospitals see, maybe 30% kids, and of the kids who come in, a good subset of them have a fever. And so the idea is, how do we work it out? Would be a reasonable workup for a kid who has a fever? Now, we're going to exclude the kids who are from 0 to 3 months, because that's a totally different topic, a much more kind of nuanced topic about, ultimately, it comes down to getting a urine and who gets the LP and who doesn't get the LP. But beside that, let's just talk about kids who are generally classified between 3 and 36 months of age. Some people say 2 and 36 months, but 3 and 36 months of age is what we're going to be dealing with here. One of the first things that comes up is what is a fever, and it's 100.4 or 38 degrees centigrade. And the reason that's important is because once we know somebody has a kid has a fever, we're going to go down the fever track. If a kid's sick, if a kid comes in and they're afebrile and they're sick with something, it's a little bit more difficult, because I feel better when they have a fever, because now I know where I'm headed in terms of the diagnosis of this child. One of the issues that comes up is, and my son, who has now she's 10 years old, had the heebie-jeebies about doing the rectal temperature. They felt real uncomfortable about doing it. They didn't know how to do it. They were kind of afraid to do it, kind of thing. And when she was a little kid, it was important to know whether she had a febrile illness or not. And it was like, people were doing by all unreliable methods. They were sticking thermometers under in people's armpit, things that were clearly not. We don't need to know how high the fever is. We just need to know fever, no fever. It doesn't matter whether frankly, it's 104. And if it's 104 in the ER, you will be moved to the front of the line. So I would advise that people don't give any Tylenol or any ibuprofen before you come to the hospital, so that you can have as high a temperature as possible, so you will be moved up to the front of the line. But it frankly doesn't matter how high the temperature is. The vast majority of the people who have 104, 104 and a half, they're all viral, vast majority. So in any case, there is this issue about trying to determine by the parents whether they have a fever or not. And we basically can reinforce this concept of fever phobia by doing things that make it look like fever is really dangerous and fever needs to be treated, and here's how we're going to treat it. And so a lot of us basically would recommend, here, let's alternate acetaminophen and ibuprofen. Let's alternate, because that sounds like physiologically we'll use two different drugs to attack the area in the brain that causes temperature regulation, and let's do that. And I think that that's a problem, and the American Academy of Pediatrics specifically says, don't do that. Don't basically do this alternating thing. It doesn't necessarily work any better as long as you use a totally appropriate dose. Now, the appropriate dose is 15 milligrams per kilogram for the acetaminophen, 10 milligrams per kilogram for the ibuprofen, and if you use the right amount, that's what you're looking for. And the question is, well, if the temperature really doesn't come down, does that make it more clear that this is a serious infection, this is a bacterial infection? I gave the medicine, it still has a fever, or the fever hasn't budged very much. Got nothing to do with it. Some people, this is really weird. When you go to the emergency department, they would not let the little kid out until the temperature had come down. Not necessarily to normal, but to a number that they felt a lot more comfortable with. And if you work in a department where they won't let the kid out until the temperature's down, come on, we're all friends here. Well, that was a very unenlightened aspect of nursing care, where they basically said, well, the kids still have a fever. That's not ridiculous. You just basically want to find out serious, non-serious, non-serious, out the door they go. But here's American Academy of Pediatrics, their newspaper, talking about our influence of reinforcing the concept of fever phobia. Yeah, there are some things to do in kids who have fever that are not controversial. Like when kids are febrile, they burn more calories metabolically. They also, may need some additional hydration, because that's an issue. But really what we're checking is, we're interested in the behavior of the child. And the other thing is, we all know that fever makes you feel uncomfortable, because fever means that your thermoregulatory center there says your body needs to be hotter. Your body needs, and how does that result come from? Maybe these bacteria or viruses cause this thermostat to say, by exotoxins or whatever kind of thing, that basically says we're going to raise the temperature here. And so we're raising the temperature. How do we raise the temperature? We shiver. You and I shiver. We want to get under blankets. We want to retain heat, and that will generate our fever going up. And when the fever is going down, we vasodilate, so the kids are flushed and sweaty. Flushed and sweaty means you are dissipating heat. That means the temperature is coming down. So basically, the thermostat, we can tell really where you're going. Are you going up? Are you going down? Child is flushed and sweaty, temperature's coming down. Child is pale and wants to be covered up, shivering, temperature's going up. I think that the other thing about this treatment of fever is how aggressive to be. Any of you use IV acetaminophen for the treatment of fever? Any hands? Good. That'll save 4 slides right there. But what I wanted to show you is this graph. This is a graph of a study that was done with IV acetaminophen versus PO acetaminophen. And it was, these IV acetaminophen studies are usually produced by those who make IV acetaminophen. IV acetaminophen is $35 a gram. $35 a gram for, it's pennies at Costco for, 2 containers like that is $35 a gram. And one of the things that, one of the tricks that you can use to make people appreciate that your drug is far superior to its comparator is to do a graph like the top here. The top graph basically says, wow, the temperature is lowered much more effectively by the bottom line than the top line. The top line is oral acetaminophen, bottom line is IV acetaminophen. Wow, this is terrific. But the trick is, when you look at the left-hand column in terms of the, what is that called, the axis or the vertical line, and you look at the increments on the vertical line, the increments on the vertical line are 1/10 of a degree different. So basically, the difference between the top line and the bottom line on that graph is 0.3 degrees. 0.3 degrees. Now, do we care about 0.3 degrees? Of course not. It's clinically irrelevant. But when people look at this is far superior drug to the IV versus the PO, when in fact the difference is clinically inconsequential, which is often done in studies. When you have a large enough population in studies, you may be able to show that there's a statistical difference between this drug and that drug. It's statistically superior. But the difference is so small that it is irrelevant. Same thing on the bottom. This is another one, same thing, where basically the chart and the absolute numbers are very deceiving. So what we're really into is we should be grateful to the immunologists. They have basically been the ones who have stamped out most pediatric significant diseases. When I was look at this. There's 375 cases of meningococcal meningitis. That's the meningitis that you get when you go to college or you're bunched up in the barracks in the army kind of thing. 375 cases. Well, you can't get into college now without a meningococcal vaccine, and that's perfectly appropriate. But we're talking about 375 cases out of a population of 340 million people. We're also talking about 4,000 cases of bacterial meningitis. When I was a younger physician, we did spinal taps all the time. We also saw multiple cases of bacterial meningitis. It's still around, but it's rare. It's a rare disorder. And as a result of it being a rare disorder, particularly in the kids that are under 3 months, the question is, how many of those need a lumbar puncture when they have source unknown fevers, given the fact that this is what we're talking about. Here's another example of how statistics can be used to be deceiving. So it says the average age of meningitis in the United States is 42. You know any 42-year-old people who've got meningitis? No. Who gets meningitis? The very young and the very old. When you take the very young and very old, the average is 42, which is basically nobody gets it at 42. So it's very, again, misleading. This is a great chart that shows the effect of immunizations against pneumococci in the United States. It basically slammed this thing down. Then when you introduce, now we have 23 valent immunizations against pneumococci. Takes care of all, virtually, I'm sure there's more variants, but if you get 23, that's a lot. So that we want pneumococcal immunization for people who are older than me, of course, because of the risk of getting pneumococcal pneumonia when you get more elderly, and how effective these immunizations are and how long they last. So basically, when I was a younger doctor and kids came in with source unknown fever, the idea was, do they have pneumococcal bacteremia? That was the scare. Pneumococcal bacteremia came in, kids were source unknown. They had bugs floating around in the bloodstream, and the idea is that going to settle in the brain? And we got a meningitis, pneumococcal meningitis, which was by far the most common cause of meningitis, or is it going to land into a joint, or is it going to cause osteomyelitis or something to that effect because of the bugs that were just loose in the bloodstream? So we had a protocol was developed that was generally embraced by most of the emergency medicine committee, where, in fact, a community where you would do a CBC. And if the CBC was over 15,000, then you would get a blood culture on these little kitties and send it off, and in the meantime give them a shot of ceftriaxone, because we're waiting for the blood cultures to come back in a day or two. And that was kind of the routine, and there was 55-gallon drum of ceftriaxone in the emergency department with a lure lock on it, and all of these little kids were getting shots of ceftriaxone while we waited for the blood cultures to come back. Some of them came back positive, most of them did not, but in the meantime, bacteremia from pneumococci was cured not by us, but by the immunologists. So now, basically, pneumococcal bacteremia is kind of gone. And if you've gotten your baby shots and all those and the like. So where we're looking for the source of this fever, it's primarily now going to be, now that everybody's looking, it must be the urine. How are we going to check out the urine? When they're in the era of pneumococcal bacteremia, we didn't even think about the urine. It was like kind of it wasn't considered to be anything worth talking about. But now it is. Now everybody's making a big deal out of the urine now that we got rid of pneumococcal bacteremia. And so the idea here is they talk about UTIs in kids. And I think that I don't understand it. Because a UTI, you know what a UTI is. Like it's urinary frequency, burning, urgency, no fever. It just hurts maybe a little bit over the bladder, and that's a UTI. And it's an easy diagnosis to make, and we see it all the time in the ER. UTIs are not associated with fever. I mentioned earlier that a UTI with fever, we call that pyelonephritis. Why don't we call it pyelonephritis in kids? When you look at all of the literature that's written about urine infections in children, they use UTI. I'll give you $1 for every time you find the word pyelonephritis in association with febrile children. But it is about pyelonephritis. And one of the concerns about this is, well, is pyelonephritis going to result in the scarring of these kids' kidneys, and they're all going to be on dialysis when they're 50? So that was the fear. The American Academy of Pediatrics came out with some guidelines that were pretty old, 2011. And then they reaffirmed these. They said, yeah, our guidelines that we came out in 2011 are still okay in 2016. And some of the key points, they said that the overall incidence of bacterial UTIs in source unknown fevers is 5%. 1 in 20 kids who has a source unknown fever. Well, what's source unknown? If the kid's got a cough and runny nose, then maybe that's the cause of the fever. So that's not a source unknown fever. We're going to say that's due to low-grade fevers associated with this respiratory infection. Or what's not associated with fever is, and this is one of my pet peeves, I don't think otitis media causes fever. You know, many people say, oh, this ear's a little redder than that one. That must be, there's the source of your fever. That's a little tiny abscess behind the eardrum, and you're willing to say that caused 102 fever? When in fact you see these abscesses from shooters and boils and this and that. They never have fevers, but you're willing to say, well, this abscess is special, and that's why it's got 102 fever. I could take the time to make the case, which I think is pretty compelling, that maybe they have a concomitant viral infection that is associated with this otitis media. And yeah, maybe the viral infection is causing the fever, but this, no. You see a 5 or 6 year old kid come into the emergency department where you are, and this kid's crying and because his ear hurts so badly, and you look in and it's bright red, and it's an obvious diagnosis. Does that kid have a fever? Never. And that is a case where the diagnosis is unequivocally true, because kids point to it, you look at it. Now, in a little 2 or 3 year old and a toddler, you know, they're not really able to point to their ears. Well, people said, oh, I saw the kid touching his ears. Well, these kids have basically Brownian movement. If you wait long enough, they're going to touch everything in their body. So the idea of, well, touching their ears is a kind of a sign of otitis, when they look at it, it's not really true. So I'm going to tell you, in my belief, is that otitis does not cause a fever. Maybe a concomitant viral infection. Okay, fine. So, yeah, and then the other thing that they mentioned on this slide is, this is kind of easy. If a kid is so sick that the kid appears toxic, dehydrated, that kind of thing, well, that's a no-brainer. You don't need to think about that anymore. The kid gets everything cultured, and you begin, you know, the ceftriaxone and rehydrate, and the kid gets admitted to the hospital. What is the source? Well, we're going to look at the urine, we're going to look at the lungs, and hope though it's in one of those 2 spots, we're going to get the blood culture. Those are easy, knee-jerk, in they go. I don't worry about the kids I admit. I worry about the kids that go home. Those are the people I worry about. And yet, we've got to send people home who've got disorders that are appropriately treated at home. One of the other things they talk about here is, don't even think of culturing a bag urine. The bag urine's contamination rate is as high as 88%. So if you're going to do a culture on a kid, there's only 2 ways to do it. A suprapubic aspiration, which is basically, you took a vacutainer tube and you stick it in the suprapubic area, and there you go. It gives me the heebie-jeebies. Or you do a catheterization. That's it. There's only the 2 ways that are viewed as acceptable by the medical community who's kind of into this. So I'm going to ask you, how many of your places routinely are cathing these kids for urines. Can I see your hands? Can I see your hands? I don't see very many hands. I don't know how you're getting this urine out. You only have two choices. You're all going to have to get urine. Many places, particularly pediatric hospitals, where they ought to know better, are routinely cathing these little girls for their urine specimen. And I'm going to tell you that that is ridiculous, ridiculous. The only person who should be catheterized is those who basically were about the culture, where we're looking for the 50,000 colony count, or if we do a suprapubic tap, maybe even 10,000 colony count. Because a positive culture is a requirement in terms of making the definition of a urinary tract infection. So how do we get urine out of a kid short of doing a catheterization, especially a young kid, 6 month, 4 month, 3 month kind of thing. This is called the chicken. I've named this the chicken technique. Basically, you grab the chicken underneath the arms, underneath the wings. So that requires one person to hold the kid up underneath the arms. Then you have a second person who is the tapper. The tapper is tapping over the suprapubic area, over the bladder, at a rate of 100 per minute. You need the tapper who has like a good rhythm. That's number 2. The third person is rubbing the area over the lumbar spine. In the north of the equator, you do it in a clockwise manner. South of the equator, you do it in a counterclockwise manner. And the fourth person has got the cup. And this basically said 69 of 80 kids peed within 5 minutes by doing this. Of course, it shuts down the department because you need 4 people to do this. But if you want urine out of a little kid, try this. And the younger the kid, the more likely this is to work. And this is not the only paper on it. I have another lecture on this stuff that has all of the references on it, because this is not just one wacko study. So then you catch it. And once you catch it, you dip it. And the dip is negative for both nitrate and leukocyte esterase. Your screening test for a urinary tract infection says it's not likely to be a urinary infection, and you're over. You don't have to catheterize the urine. The only reason that you're going to catheterize urine is because you're going to culture it. You don't necessarily need to look at the micro. Yeah, we like to look at the micro, but I'm not going to catheterize a kid to look at the micro. In fact, I'll take a look at the micro and a clean catch that I got out of this little kid. But more important is nitrates and leukocyte esterase. If both of those are negative, you're going to have a difficult time making a case that this kid has an infection. Now, here's the other thing. They have come up with what they view as a way to stratify the risk. Who are the people who are most likely to be in this 5% of kids who have a urinary infection? And they talk about how long the fever lasts, how high the fever is, whether it's a African American or non-African American, and you're not going to remember any of this. So I'm going to show you something a little bit later that helps you stratify the risk, which is much more amenable to being remembered. Low risk UTIs. Yeah, here's what I said basically. Just get the urine. It doesn't matter how you get it. There are studies out of England where they take nappies, their word for diapers, wring them out, and dipstick the urine. It doesn't matter how you get it, where it comes from. Try not to get it into the poo. But basically, if a nappy's urine is negative on dipstick, it's negative. Here is a risk calculator that you can get. It's basically called UTI Calc. And it's a app that is developed by the University of Pittsburgh, where they basically said it is better than the AAP risk stratifier, and it is from a couple points of view. One of it in that it decreased the amount of testing by a little bit, 8%, and decreased the number of missed UTIs. When they did a study, 1,600 patients they used to develop the criteria, and they validated on another 384 kids. So this is what I would get if I was trying to find a risk stratifier. However, risk stratifiers are good for populations. We have 100 people, and the risk stratifier found the 5 who had a urinary infection. But in any one child, a risk stratifier is kind of like a waste of time, because ultimately, you don't know where this, you can't really rely on that risk stratifier to exclude or include these children. So it seems that the easiest way to do this, the source unknown child, is to get a urine, and dip it. And if it's from a little girl, just dip it. If you clean her up, just dip it. And if it turns out that it's not negative for leukocyte esterase, well, then you can get a UA and a cath and culture, which is going to be in the vast minority of cases. So this idea of routinely cathing these little girls for their sample that you're going to be sending over to the lab, which is, when we do this course for exclusively emergency physicians, it's disheartening, the number of them who think that that is the way to do it. In terms of, I told you, basically you need a positive culture. Usually we're talking about E. coli. Look at that. The initial treatment is equally effective orally versus IM, but everybody thinks, oh, man. The fact of the matter is that all of these antibiotics that we're using for UTIs are concentrated in the urine, concentrated. And how long does it take to get from the mouth through the small bowel into? Not enough time to make a difference unless this kid is really pretty toxic. So the idea of shooting up this kid with a ceftriaxone shot or starting an IV on a kid who's basically going home is kind of like, geez, it's painful. It's not necessarily easy to do because they're small little kids. You stick them a couple of times, mom's crying, the baby's crying. You're making a big project out of this thing when you could have given medication by mouth. It also depends on your antibiogram in your neighborhood. Like, what is the antibiotic that's going to take care of, E. coli on an outpatient basis? There should be an outpatient antibiogram and an inpatient antibiogram. An outpatient antibiogram, this is what we use. So the American Academy of Pediatrics says if you want to give one thing a day, and it's by shot, it's ceftriaxone. But if you want to give pills per day or capsules, the only pill that you can give once a day is Cefixime. Now look at the price of Cefixime there. Suprax, you've all heard of that basically. It costs, the retail value for that is $215 for a dose. But look at GoodRx. You all need to know about GoodRx. This is basically will tell you what this drug is selling for at Costco, Walmart, CVS, etc. And with their discount coupon, which is easily, you just print it out kind of thing, take it with you to the pharmacy, and that's what they charge. And even if you don't have it, if you say, would you give us the GoodRx price, most of them have already done that. So GoodRx coupons will be $65 for something that it could cost $215. So you really ought to advise your patients about using this all the time. And I can tell you that if you were to say, what is the most commonly ranked drugstore for the least expensive of these agents, it's Costco. Costco has a standard pricing method that basically talks about 10% kind of thing. So if you're not sure, you can't find out, you don't have your computer, and the Costco's nearby, that's the place to get this stuff. Now the issue was, we're kind of concerned that this kid may have renal scarring and develop, and that's why we got to find these cases, and that's why we have to catheterize all these little girls, because we don't want to miss this thing. This is a study that looked at kidney damage in what was thought to be pyelonephritis, UTI, quote. A review of 10 studies plus their own data at this one place said that the incidence of this occurring is 0.3 to 0.6% is causing kidney damage. Now, not all kidney damage is going to mean that you're a pilot, that you're on dialysis. So this is 2 per 1,000 children or 3 per 1,000 children. But the most important phrase here is at the most. At the most. I think most of us treated UTIs in the past by diagnosing otitis media as the cause of the fever. They got their amoxicillin for their ear infection, which really wasn't the source of the fever, and they treated their bladder infection. Pediatric pneumonia, Clinical Infectious Diseases have published the guidelines for pediatric pneumonia from the Infectious Disease Society of America and the Pediatric Infectious Disease Society. So Clinical Infectious Diseases is the New England Journal of Infectious Diseases, and this came out in 2011. They said, well, we're going to update it. I'm surprised that it isn't out yet, but in any case, the one to admit is obvious. Everybody's going to use those criteria. You know, the kids struggling, the kids hypoxic, the kids not taking fluids, obvious. What kind of testing? They're not into blood cultures, don't do blood cultures. When you talk about non-toxic kids, there's really not much to do. They're not into sputum on patients who are going to go home. They're not into blood cultures on patients who are going to go home. They're not into any urinary antigens to determine what's wrong with the kid in terms of, this bug or that bug. They're not into that. They do like you to do a flu test in kids who you think have a respiratory illness that is febrile at source unknown, especially if it's in flu season. Although sometimes in flu season, the cases are so obvious that the idea is everybody's going to have the people say that the area of where these flu tests are most valuable are on the shoulders of the season. But if somebody, like an adult, comes in with fibromyalgia during flu season and the prior person had it and the next person has it, what's the point of measuring for a flu test in the place where there's basically an epidemic going on? Mycoplasma is basically for the atypical pneumonias. We'll talk about that in a second. Those are the walking pneumonias. Those are the people who got a cold for a couple of 4 or 5 days, and next thing you know, they're coughing for like 2 weeks thereafter, and they have a chest X-ray, so there's little fuzzy stuff here and there, walking pneumonia. They basically also say, please do not try to distinguish bacterial from viral with procalcitonin, Cedrate, or CRPs, or anything like that. Don't do that. But the most important part of this entire slide is like revolutionary. It says a chest X-ray is not necessary for the confirmation of suspected community-acquired pneumonia in those treated as outpatients. Have you ever heard of such a ridiculous thing? You don't need to do a chest X-ray to make a diagnosis now. It's like a gift from the gods. I think you have a little touch of pneumonia there. It replaces otitis media as an opportunity to give antibiotics. I think you had a little touch of pneumonia. Well, don't you want to take an X-ray? No, it doesn't really. I think you got a little touch. I think I heard a crackle on the right lower lobe. I think I heard a crackle. I'm not sure about it. It's like every study that talks about pneumonia, 99% of them use chest X-ray as the gold standard. Now we're having them say, you don't need to take a chest X-ray. You can just diagnose it clinically. And the other 1%, we're doing CAT scans instead of chest X-rays to show that CAT scans are much better in picking up pneumonia than was a chest X-ray. And then now we have ultrasound. You can pick up pneumonia on an ultrasound. Here's the typical from atypicals. The typicals, like pneumococcal pneumonia, high fever, maybe rusty sputum, pleuritic chest pain, pretty toxic, and the walking pneumonias, Legionella, chlamydia, and mycobacterium. So the idea here is trying to distinguish, because maybe the antibiotics would be a little different. So here's a normal chest X-ray on the left, an obvious lobar infection on the right, which would not be viewed as a viral pneumonia, because that's kind of not. At the bottom we have a normal chest X-ray. You see right upper lobe. Right upper lobe pneumonia is kind of disconcerting because, what kind of pneumonia do alcoholics get? They get they get right upper lobe pneumonias and from Klebsiella, but this is a little kid, so that's not that. And the rest, and the one on the far right is this fluffy stuff, not limited to any one lobe, which we're going to call that viral. These are all pictures of the various virals. Outpatient treatment, yes. Basically, they'd say, if the kid's not in school, you don't need to give an antibiotic because the kid's got a viral pneumonia. That's what they say. But if you don't feel real comfortable with that, you can give them their amoxicillin 90 milligrams per kilogram in 2 or 3 divided doses. And if they're school-age kids, basically they can get their doxycycline for their walking pneumonia kind of thing if they're clearly able to go home. Inpatient treatment is ceftriaxone, doxy basically is still fine for everybody. And this chart is really great. So we had to make it in pieces, but this is the AAP, American Academy of Pediatrics advice regarding what to do and what not to do for mild, moderate, and severe pneumonia. And the next one's the explanation. And lastly is a chart for basically urine, lungs, and in the middle is bacteremia. But they're all talking about bacteremia in people who have really not been vaccinated adequately. So we'll stop here, and now we're only 20 minutes behind. My friend, yes, what are you going to talk about?
Back pain.
This is Jessie Warner. I introduced her to you when she wasn't here a couple days ago. Jessie is a UCLA...
UCSF.
Well, she's at UCSF now, which is, you talk about UCSF, which is in Fresno. Isn't that weird?
It's in Fresno.
But in any case, she had her teaching fellowship with somebody by the name of Mel Herbert. You may be familiar with him in MRAP. She's still very active in MRAP. You'll see her on the videos that they do all the time. Thank you, Jessie.
Thank you so much. Thanks for that intro. Yeah. Good job.
That's
for you. That's for you. Always for you. All right, so we're going to bring it home today with back disorders, my potentially least favorite complaint. I don't know how you all feel out there. Back disorders are kind of frustrating because they are challenging. It's hard to know. There's a lot of things that are really benign and not going to hurt you. And then, boom, there's these terrible red flags that if you miss them, there's huge medical legal implications, and the patient may have terrible morbidity and mortality, and they're just like hiding in there, you know. So it's a challenging one. And the anatomy is kind of challenging too. So I'm going to try and break it down and just make it a lot more accessible. That's the goal of my talk today. So we're going to go through a little overview. We're going to talk about the back exam. We're really going to touch on red flags. Like if you see these, you should be concerned and you should do more. Talk briefly about imaging. You know, the big teaching there is that you should just be judicious with teaching. Not everyone with imaging. Not everyone needs imaging. And then how to treat various conditions. And we're going to go through all those specific syndromes really quickly that are all listed right there. We're going to talk about them. So there's a lot of different causes of back pain. We know this. They can be mechanical. The person has degenerative disc disease or, you know, joint deterioration. They could have an injury, some sort of trauma, acquired disorders like arthritis or osteoporosis, various other things that may cause their back pain. Infections are the big one to worry about. Tumors are another concern, less common, but those are big concerns that you really need to watch out for, and we're going to talk about when to identify those and how to identify those. So when we're talking about back pain, it's important to remember that this is an incredibly common complaint. It is second only to URIs for people coming in and seeking care from a physician. So you are never getting around it. You're always going to see back pain, and it's probably going to be something that you see multiple times a day. A lot of times it's unsatisfying because we don't have a specific diagnosis for the person. Just like, you know, it doesn't seem to be anything dangerous. This is what I think it probably isn't, but I can't tell you exactly what it is. The good news is that a lot of it does get better on its own. It can be challenging to get adequate pain control for these patients, and we'll talk about different things you can use. But the good news and the reassuring thing you can tell patients is usually with time, it will just improve on its own. It may take several weeks, and nobody really wants to hear that, but generally it will improve. So we are going to talk about don't miss diagnoses. We're going to talk about treating pain. We're going to talk about the judicious use of imaging and just what to counsel your patients. So this is the really important slide. These are the red flags concerning diagnoses that you cannot miss. These are the things you should always have in your mind and know how to rule them in or out, which is what we're going to talk about. So spinal cord compression syndromes. Huge cannot miss diagnosis. And those include things like a spinal epidural abscess, which of course is an infection different from other forms of cord compression that might be caused from something like a tumor or disc protrusion, cauda equina syndrome. Then we're going to talk about things like vertebral fractures. Can't miss those. Those are really important. Vertebral metastases, so anything from cancer. Discitis, also caused by infection spread through the blood, and osteomyelitis. And then aortic catastrophes. So those should always be on your differential when you're thinking of someone who's coming in with back pain, because an aortic dissection, a rupture, AAA rupture, those can send pain straight to the back, and it can be misleading. So always keep that on your differential. So history and exam. How are we going to be able to differentiate among these terrible red flag diagnoses? Let's start by talking a little bit about discitis, or spinal cord compression syndrome, as we've listed here. If you see any of these red flags, this should be on your mind. The patient has a fever. Anyone who comes in with back pain, and like real back pain, not just a 20-something-year-old, I was playing and I twisted, but someone who you're concerned about, anyone who looks uncomfortable, anyone who has a concerning story, you really should get a core temperature. And that can be challenging to obtain in the ED because we're always doing those temporal temperatures, which are not useful, not reliable, not accurate. You really need a core temp, because if that patient has a fever, then your concern for something like this, like a discitis or a spinal epidural abscess, just went a lot higher, and there's a lot of bad things that that patient could have. So check for fever. Are they immunosuppressed? Are they taking chronic steroids? Do they have things like diabetes? Those really do put your patients at higher risk, so always ask about it. Any history of IV drug use. And the classic story is the patient will say, well, I did used to use drugs, IV drugs. I haven't used them in like 3 weeks, or I haven't used them in 3 months. I used to. I want to trust my patients, but with something that's this dangerous, you should assume if they're telling you they had a history of IV drug use, you should be very cautious. Any sort of history of IV drug use, that puts them in the high-risk category. Lower extremity neurodeficit, so true deficit. They have weakness. They have weakness on their exam. They have trouble with walking. Incontinence. Now, normally, actually, what you really should worry about is retention, because remember that urinary retention is the first thing that happens with a spinal cord compression syndrome. Usually you get a urinary retention, and then when the bladder becomes so full that you have overflow incontinence, that's when you get the incontinence. It's late stage. So you're not always going to get incontinence, but you should be thinking about retention. And if you're concerned about the patient having a compression syndrome, I highly recommend getting a bladder scan and seeing if their bladder is very full, over 100 cc's, 150, 200. That's all very concerning. That's urinary retention, big red flag. And then anything with bilateral symptoms. So unilateral, there's some not dangerous things that can cause unilateral problems. But if it is bilateral, both my legs, something's going on in the middle of the spinal cord and affecting all the nerves coming out on both sides. That's very concerning. So that's discitis, spinal cord compression syndromes. Oh, and then of course, saddle anesthesia. We all know that. Just have the patient kind of rub in between their legs. They can do this. You can be there, you have a chaperone, but you can have the patient actually touch in between their legs and behind and say, does that feel normal to you? And they can tell you whether or not they're having saddle anesthesia. What about vertebral fractures? Think about that when you have a story of trauma and they have midline tenderness. Now, in kids and younger people, it's usually a higher mechanism like a car accident, but in elderly people, it can be a simple fall on their bum, fall in the bathroom, fall out of a chair, just hitting their bottom can send pressure up the spine, and then they can end up with vertebral fractures. So very small mechanisms. Vertebral Mets, history of cancer, night sweats, weight loss, B symptoms. That's when we're going to think about that. And then aortic catastrophe. So someone comes in with syncope. Someone comes in with terrible pain that is shooting to their back, radiating to their back. They have risk factors. They're a smoker. They have a history of hypertension. Consider that. And then abnormal gait, that's the big one. Always walk your patients. Another really challenging, another thing that makes back complaints so hard is walking your patients in the ER. They're in a hallway, or, they're partially dressed, or they're not wearing socks and shoes. It can be so challenging, but it really does pay off with this diagnosis. You do need to get the patient up. You do need to walk them and assess their gait, because it will tell you so much. And if they can't walk, they can't go home. They're not walking out of the ER. So it's very important to make sure that that patient can walk. When you're taking a history, these are all the things you're going to ask about. You just need to do a very thorough history. Ask about trauma. Ask about chronicity of the pain. What triggers it? Is it movement? Where does it radiate? Consider that patient's age. Like I said, are they very young or are they very old? If a pediatric patient comes in complaining of back pain, I'm concerned. That's weird. You don't usually see kids complaining of back pain. Something is not right there. And then all these red flags that we kind of talked about and went through already. So when you're doing the back exam, it's very important to just be consistent. It's like any other neuro exam. I think when you do your neuro exam, I know for me, I have a very sort of regimented way I go through it, head to toe, always, that way I'm hitting everything I want to hit. Same thing for the back exam. Just be very consistent. Make sure you look at the back, because a lot of times, like I had a patient the other day who was like, oh yeah, my back is really hurting me. I don't know, I think I twisted something. And I looked at her back and she had zoster. So that absolutely can happen. You want to look at the back, make sure there's no rashes. Palpate, feel the spine, feel for muscle tenderness. Sometimes they're not tender in the middle of their back, they're off to the side, and you're like, does this hurt? And they're like, actually, that feels good. Yeah, right there, press harder. And you're like, you have a muscle inflammation here. You're having a muscle spasm. So the exam can be really helpful when you're actually pressing on the patient. Do range of motion exercises. Make sure you do a good neuro exam. Remember, you're testing for sensation and you're testing for motor. If you're really good, you're doing reflexes. Although, to be honest, I think it's hard to find a good reflex hammer in the ED. We're not always doing reflexes, but if you're going to be doing it right and doing it thorough, you should. Oops. These are just, I just kind of like this slide because it's like a straightforward way to approach the nerve roots in the legs, L4, L5, S1, and looking at the reflexes, the sensory, and the motor, which are components you're always going to evaluate for every patient. A couple things to think about. When you're thinking about L3, L4, L5, here's a couple tricks. We have the sensory dermatomes, this guy. It's all twisty and all different angles, but you can test L3, L4, and L5 all at the knee. So L3 is medial, L4 is right over the knee, and L5 is lateral. So just one little exam. Can you feel here? Can you feel here? Can you feel here? It's all intact. Boom. L3 through L3, L4, L5, it's all done. You just did your whole exam right there for the sensory components. And then when you're thinking about motor, remember that L5 is what allows you to walk on your heels. So if you have your patient do that, they have good strength, L5 is intact from a motor perspective, and S1 is tippy toes. So if you have them heel walk and tippy toe walk, then you've got L5, S1 are intact, motor's intact there. So very easy things to do, a quick exam. What about lab work? So labs are not always indicated for someone who has back pain. If you have a patient with those red flags, the fever, the immunosuppression, someone you're worried about, the important labs are right here. So of course a CBC, ESR, CRP, inflammatory markers. I don't always get a calcium, but you can think about getting a calcium. If it's very elevated, it might be a sign that that patient has bony mets. And again, patients with red flag symptoms, they need imaging. And the imaging of choice is a CT or an MRI. It is not an X-ray. X-rays are essentially useless. The only time that we sometimes get X-rays is in kids. Kids with like a, we expect the spine is going to look pristine, and we're trying to save them the radiation. But any sort of adult who has a serious back complaint, you really need to get a CT or an MRI. Remember, the CT is good for looking at the bones, especially if you're concerned about a fracture or traumatic injury, and the MRI is great for the soft tissues and for the spinal cord. So spinal cord compression syndromes, anything where they have weakness or neurodeficit, that person needs an MRI. I think we just talked about that. So let's talk about spinal epidural abscess. How do we know? When are we going to suspect it? What are we looking for? This is something that is insidious. It usually is not immediate. It's not like I was fine yesterday and now all of a sudden, boom, I'm out. I can't use my legs. I have terrible pain. It's a little more insidious usually. It's often missed on the first visit because sometimes all they're saying is, yeah, I have some pain here in the middle of my back. It's bothering me. And if you think it's not dangerous or you didn't ask those red flag questions, you might be inclined to say, you know what, most back pain gets better in 4 to 6 weeks, so just take some ibuprofen, come back. So it's often missed. You really need to think about it, and you need to ask those questions, looking for those red flags. Definitely get a temperature for this one. They don't always have a temperature, but if a patient does have a fever, you're definitely going to be more concerned about this. Remember that spinal epidural abscess is usually spread via the bloodstream. So in someone like an IV drug user, they inject at a different site, and they may then get through the bloodstream, they end up with an abscess in their spine. So that's generally how that can happen. And they might not, even if they're complaining of lumbar pain, the abscess might actually be in the thoracic area. So don't be fooled by exactly where they're complaining of back pain. The really thing to remember about spinal epidural abscess is when you order the imaging, you have to get a full spine MRI. So the common mistake people make is they just get the L spine. They're like, this person has lumbar pain, I'm just going to get an L spine MRI. But again, the abscess can be hiding in the thoracic spine. This is an indication to get a CT and L spine MRI. This is really one of the only huge indications that I can think of. No one likes ordering that. It takes a long time to get done. But if you're worried about spinal epidural abscess, you have to get a full spine MRI. If you just get lumbar, you will get burned. You will get burned. Some other findings here, SED rates are usually elevated. So usually what I do is I have a patient, they have some red flags, concerned about them, they're an IV drug user or they're immunosuppressed. I get my labs. I always get my SED rate and my CRP, my inflammatory markers. If those are elevated, you move on to imaging. Now, if those are not elevated, it's pretty unlikely that they have something like this. But if those are elevated, that's an indication to move on to MRI. Just red flags for infection in general, if we're talking about like discitis or epidural abscess. Again, persistent fever, no other good cause. The patient has had a fever for a while. Those red flags, history of IV drug use. The person has severe pain. It's very uncomfortable. If they've had any kind of spinal manipulation or surgery in the last year, think about this. Other things that can sort of fly under the radar, any other recent bacterial infection, even something like a UTI, an immunosuppressed person. They recently had a UTI, they're immunosuppressed, now they're coming in with back pain. Think about it, because again, this can be spread through the blood. Cellulitis, decubitus ulcers, anyone on steroids, diabetes. This should be on your differential. This is what it looks like. Anyone could read this imaging, right? I'm not a radiologist, but this is pretty easy to see. There's a big abnormality there at L2. We've got osteomyelitis of the bone. It's kind of eaten away and a big epidural abscess. What about cauda equina? So that's epidural abscess, okay? That's infection spread through the bloodstream. Cauda equina syndrome. Remember that the spinal cord ends around L1, L2, and then you have these nerve roots coming down. That's the cauda equina. And you can get a compression syndrome. It can be from a tumor. It can be from, most of the time, it's actually from a bulging disc, and it's pressing on those spinal nerve roots. That is the cauda equina and cauda equina syndrome. This is the one where you're really looking for urinary retention, and you're getting a bladder scan, and you're asking them about incontinence, but again, that's much later stage. You're checking for saddle anesthesia, you're checking for anal sphincter tone. Usually these patients have bilateral lower extremity weakness, so they have true weakness on your exam, and their exam generally is getting worse over time, so they're telling you that I've been getting worse. This is a neurosurgical emergency, and again, you're going to get an emergent MRI. Now, unlike the spinal epidural abscess, you don't need a full spine MRI for this. We know where the cauda equina is, so usually a lumbar MRI is adequate. This is a picture of it here. It's the horse's tail. What about spinal stenosis? Okay, so those are the two huge ones that we're always trying to rule out. Is it an abscess? Is it discitis? Is it cauda equina? Now let's talk about a few things that are not quite as dangerous, not a neurosurgical emergency. Spinal stenosis. This is more common as we age, happens to older people. It's caused by facet hypertrophy, and the ligamentum flavum gets thickened. Remember, that's the thing you're sort of punching through when you do a lumbar puncture. Patients will present with pain, mostly. They may have some numbness, some tingling with walking. It's really worse with walking, and they get a lot of relief when they sit and bend. So it's worse with extension when you're up and you're extending your back, and it's better with sitting. They have a lot of relief when they sit because they can then bend their back. So that's how you can usually diagnose this. CT and MRI are diagnostic. You don't always have to get these. It doesn't always get better on its own. This is something that usually needs some kind of intervention. A lot of times it gets worse, and you do need to see a neurosurgeon or an orthopedic surgeon who can operate on backs. So if you can refer them out, that's a really nice thing to do, and probably a good idea. You don't have to get imaging to confirm this, because this is not necessarily an emergency, and you're going to treat it with NSAIDs and physical therapy and exercises. And this is, again, a picture of that sort of narrowing and the facet hypertrophy, and you can see this is actually up in the C-spine, unfortunately. Let's talk about fractures. So this is usually axial loading with flexion. So you can imagine if you're in a car, you've got your seatbelt on, and then suddenly come to a stop and you flex forward and your spine is just flexing and things are bending and crushing, and that is how you get a vertebral fracture. And I had a kid the other day who was, maybe a 12-year-old complaining of terrible T-spine pain after a car accident. So, red flag, something's not right. This is a kid, he had a vertebral fracture. I also had an elderly patient, just fell to the ground, fell on her bottom, vertebral fracture. So simple mechanisms in the elderly, more significant trauma in young patients. And it's usually in L1, L2, sometimes in the lower T zones. Usually they're stable, but think about unstable fractures. So for example, a burst fracture where you have loss of height, more than 50%. Remember that basically that vertebra is squished. That's concerning, and that is an unstable fracture, and you need to call your specialist or transfer that patient. So this is an example of a compression fracture. You can tell that this is a young patient because this is an x-ray and it's beautiful. So this is definitely a young patient, and you can see the little compression fracture there. A chance fracture, it's kind of like a burst fracture, but just in a different plane, also an unstable fracture. There you have the burst fracture. You can see on the full spine there, it's completely squished down. Again, unstable fractures and need consultation. What about cancer? So you're going to ask about a history of cancer, and you're going to have it on your mind. If someone has a history of cancer and they're coming in with back pain, this should certainly be on your differential. You can ask about B symptoms, things like weight loss, but this should always be on your differential in any patient with a history of cancer and back pain. And it can happen in young children, and it can happen in people over 50. So usually over 50 and under 17, you're worried about this. These patients are not improving with NSAID. They'll tell you, I've been taking ibuprofen, I've been taking Tylenol, it's getting worse, it's not getting better, I'm having pain in the night, it's waking me up, it's persistent, or I'm just resting and I have pain. Very concerning symptoms, so think about it. Aortic catastrophes, aortic dissection, and then something like a thoracic aortic aneurysm rupture or abdominal aortic aneurysm rupture. When are we going to think about this? So for dissection, it is sudden, and it is severe, and it is maximal. These patients are uncomfortable. They have tearing, ripping pain going straight to their back. They usually do not look good. So this is pretty severe, and it's pretty sudden. It's between the shoulder blades. Definitely consider it. The diagnosis is going to be made with a CT angiogram, CTA. For the aneurysm rupture, the classic triad that we are always taught is abdominal pain, hypotension, and a pulsatile mass, but it is rarely there. You certainly cannot count on that. It's good to do an exam, see if you feel a pulsatile mass. If the person is hypotensive and they have abdominal pain, it's definitely a concern. And what I like to do is bring over the ultrasound machine, because you can diagnose this a lot more quickly on ultrasound than waiting for that person to get to CT. But again, if you don't have an ultrasound, or if your surgeon wants one, you might get them to CT. But these patients are usually unstable, and they might crash in the CT scanner. So ultrasound is your friend here. Let's talk about sciatica. So this is a very, very common complaint. The sciatic nerve is made up of the lumbar nerves. It's L4, L5, and then the sacral nerves, S1, S2, S3. And it's shown here in this picture. And what happens is you get compression of some of these nerves, and that is the sciatica. That's sciatica. And basically, patients complain of pain from their bottom all the way down their leg for the most part. So how are we going to diagnose this? They have pain. They may have a little bit of weakness. They may have a little bit of numbness, but it's usually a pretty classic story of pain from my bottom going down my leg, and it's this sort of shooting pain. It's aggravated by small movements. You can do a straight leg test, which is quite sensitive. You have the patient lie down, and then they have a straight knee, and you extend. So let's say it's my left side that's hurting here. You extend that left side. That hurts. I'm having a lot of pain with that. So I've just elicited the pain with a straight leg test. That's pretty sensitive. And then if I actually lift the other leg, so the non-affected leg, the crossed leg, and lift that up, and that's reproducing the pain on the left. That is called the crossed straight leg test, and that is very, very specific. So those two together, you have high sensitivity and high specificity, two really good exams to sort of confirm that this is sciatica. This is just a diagram showing you some tests you can do, again, for the reflexes, the sensory, and the motor, and give you a sense of what nerves are involved there. Piriformis syndrome is almost like sciatica, because basically what happens is the piriformis is this deep buttocks muscle, and it allows you to rotate your thigh outwards, put that first position for any dancers out there, so it allows you to rotate your thigh out. And sometimes in some people, the sciatic nerve actually goes through that muscle. And if you have any spasm or swelling of that muscle, then you're basically going to get a sciatic nerve pain, because it's, again, compressing on that sciatic nerve. So usually people with this will have increased pain after sitting, or after lying down, or after standing for a while, and they actually have decreased pain with walking. So they feel better when they're walking. It's kind of the opposite of the stenosis, the spinal stenosis. Spondylolisthesis. So this is slippage. Listhesis is slippage, anterior slippage of one vertebrae on another one. And in kids, in pediatrics, it's thought to be from like repetitive hyperextension. So this is your athletes, your gymnasts, weightlifters, cheerleaders, those are usually the kids who are going to get this. And the treatment is really just stopping the motion, so giving them rest, saying stopping the hyperextension. And kids never really want to hear that, and adults never really want to hear that, but you want to just let them rest. In adults, it's usually degenerative disease that's causing this, and you're going to refer them to a primary care doctor or an orthopedist. It's not, an emergency, but they're going to be a little bit uncomfortable. What's the difference between spondylolisthesis and spondylolysis? Well, again, slippage is the listhesis. Spondylolysis is really just a degenerative, these are all hard words to say, degenerative disc disease. So that is age-related, and it's really just a matter of terminology and vocabulary. This is the spondylolisthesis, the slippage, and you can see L5 slipping anteriorly there over S1. That's the most common location where this occurs. Neuralgia paresthetica, what is this one? This is the lateral femoral cutaneous nerve. It gets compressed when it is coming out between basically the ilium and the inguinal ligament. So right here at ACES, where you can feel your hip bone, that's where patients have pain. They generally have pain right there. The nerve comes out, and they have pain, and they have tingling and numbness right down the side of their leg. It's kind of a strange thing, and so that's why we're talking about it, because you don't always think about it. It's tingling, numbing sensation, burning pain right down the side of their thigh. It's neuralgia paresthetica. And it's usually because something is, again, compressing that nerve as it comes out, usually something like a belly. It could be a pregnant belly, could be a beer belly, could be a worker's belt. Patients sometimes who wear too tight clothes, their clothes are a little too tight. So you can tell them that they can make those interventions if possible. You know, maybe need to lose weight or deliver the baby, which that may be a long wait. They can change wear more loose-fitting clothes, but those are really the only interventions to address that. And then, of course, you treat this with like NSAIDs and rest. So what about imaging? We talked a little bit about that. You don't need to do much imaging unless the patients have big red flag symptoms. There's been a lot written about this. The Choosing Wisely campaign and ASAP has talked a lot about it. So generally, you do not need to image people unless they have these big red flag symptoms and you're really worried. It has not been shown to give them better outcomes. Again, X-ray is not the right choice. They have poor sensitivity. If you're getting imaging, you really want a CT or an MRI. And what about treatment? How are we going to treat these patients? So usually we're doing supportive care with things like NSAIDs, Tylenol. If it's really bad, you can try some ketamine. I have to say I haven't really done that because usually I want to send these patients home, and it's like, well, what am I going to do if I give the patient ketamine? How am I going to send them home on something? I'm really trying things like ibuprofen, Tylenol, lidoderm patches, Voltaren cream, like a topical agent, some short-term opiates is okay, just be careful about how much you're giving them. Short term is okay. Or a benzodiazepine. Now that is a sedative, it's not actually a muscle relaxant. We often call it a muscle relaxant, it's really a sedative, but it can give the patient some relief, especially something like sciatica. So again, short course of those, just not too many. Encourage the patient to ambulate. Some people think, oh, I need bed rest. Actually, no, that is not going to help you. You do want to ambulate, and tell them that it should get better in the next few weeks, and follow up with their doctor or with an orthopedic surgeon. All right, we finished on time. That's it. Thank you so much.
You know, lidocaine patches are a funny thing. You can buy a box of lidocaine patches that are 4% strength for like $10, although supply chain inflation is probably 12 now, okay? That's 4% lidocaine strength. But if you want to give them 5% lidocaine strength, those are prescription, and they cost like $100 per box. What's in that extra 1%? I don't get it, you know? So understand that lidocaine patches can be bought just over the counter by patients here. Another thing I've started to advise patients is better living through electricity for back pain, okay? You can buy a TENS unit over the counter. My wife has one, $30. The pad is reusable, and it's great. She really enjoys it for her back pain here. A couple of housekeeping things. Tomorrow we start early, 7:30 in the morning. If you need to stream, it is at ccmelive.org, and Martha will wrap up the day with everything you need to know to get your CME, okay? All right, well, Dave, you're going to run our Q&A here. Is Jessie on camera? Does she just scoot over? We're good? Everyone's good? Okay, very good. All right.
I'm going to space out a little bit.
So we'll kind of do this a little bit rapid fire. There's a lot of great things we can go over here, and I'm just going to kind of throw them to whoever I think has a compelling answer. So first one is this, okay? So I'll throw it to Chip just because I think you already had answered it on the slide anyways, right?
Yeah.
Someone's got COPD exacerbation, and we've heard that, hey, you probably should prescribe them azithromycin or something on the way out the door. Of course, we're trying to balance that with antibiotic stewardship here. What do you think is the right answer here?
I for one, if you're going for the anti-inflammatory effect, there's a lot better things like actual steroids and stuff like that to use. I'm not as big a fan with this. It's the same argument that's been used for, we'll give them oseltamivir, that's Tamiflu, and azithromycin to patients with influenza because the azithromycin has the anti-inflammatory effect. It's weak evidence at best from anything that I've seen, and all you're doing is really increasing resistance, which is already high. It's different if you are saying, I am treating for specific types of atypicals or something. If that's what you're really going for, I think that's reasonable. But just to say, well, I want the anti-inflammatory effect, I think there's better options there.
Does anybody know of any sort of hard criteria as far as when you'd use outpatient azithro for COPD exacerbation, especially if you're discharging from the ER? Any hard and fast agreed upon rules?
The first time that I read about this was in the GOLD criteria, which is sort of the criteria for how to manage COPD. And they just updated the GOLD criteria, and honestly haven't read about the azithromycin use on that in the most updated version. But I think where this traditionally came from was the old GOLD criteria, where they were saying if the person not only has not just a COPD exacerbation, but you also think that it is a bacterial cause and they have worsening sputum, and there are a few other indications, then you could consider using azithro. But I think it's hard. Like, how do you know that you think that there's a bacterial component? That's challenging sometimes to know.
Next question here, how to handle abdominal pain in urgent care, okay, in the Wild West of urgent care. This is frankly a tough one. We could spend all day talking about abdominal pain. Like I do a 1-hour lecture on pancreatitis alone, okay? This is one of those times where if you have no means to assess the patient beyond your hands and your eyes and your mouth here, you've just got to kind of ask yourself, like, how lucky do I feel? How skilled do I feel? How high risk is the patient? And especially in things like advanced age, more comorbidities, more medications here, really serious things can be masked by age or polypharmacy or comorbidities here. And the more risk factors that happen there, I say the more likely you send. And if you just don't feel really good about how to assess an acute abdomen here, I think you just send them and just say, hey, this is outside of the scope of our urgent care practice.
You'll also have a lot of patients that are going to be resistant to that with going to urgent cares or immediate cares or whatever you want to call them. But I think the biggest thing is, if this is someone that you'd want to send or you're hedging on, but they don't want to go, is making sure that's very clearly documented. And because that can come back and save you later, because especially when I work in the emergency department, which I don't work urgent care or immediate care anymore. I did that very briefly, and to be totally honest, I hated it. But that, that realm is so hard to handle because of the fact that it's hard to get that information, and you're really quite limited. There are some things you can do at point of care, but it's very limited at best with most abdominal pain complaints. But if you put that time in to document it, when they do come to the ED later, I at least have an idea of what the thought process was, and that I understand that you weren't thinking this patient was well enough to go home. You wanted them to come to the emergency department, but for X, Y, or Z reason they didn't. That will help you later.
That's a great thing to document too. Like you told them that they should go to the ER because we couldn't necessarily fix or rule out the bad stuff in the urgent care. Okay, good. Yeah. Document that discussion.
That's because we made the ER such an attractive place to go. It's like, oh God, not the ER, not the ER, because you have to wait forever, and it's like a project, and we don't have a very good reputation.
I don't know. I feel like our ER are victims of our own success. Like people came in for the most benign stuff sometimes. Maybe not my ER right now that I'm currently working at. I'm just talking about in generalities. Let me rewind a little bit here, okay? But people just say, "Oh, you guys just get us in and out so fast for our small stuff. We're so happy to come here." It's like, yeah, we are good at that, aren't we? Okay, thanks for coming. All right, next question here. Dr. Bucata, what do you think about this? So you've got somebody who has, it's cold and flu season, and the chief complaint is chest pain, and you talk to them some more, and they go, yeah, I got what sounds like a cold, but they also say, I'm short of breath, and I have chest pain, maybe it's with a cough, maybe it's just constant here. At what point are we drawing troponins, or what point are we doing any sort of more invasive testing in, they specified, healthy, under 25-year-old patient? When are we drawing blood on these people who have what sounds like URI, maybe costic chondritis?
Well, I'd like to see what their chest EKG looks like because I have a low threshold for the concerns regarding myocarditis, and especially young people. If that EKG's got abnormalities across all the leads, then you can order the troponin. The troponin comes back elevated. You made the diagnosis of myocarditis. Whether you're going to be able to do much about it is another thing. But it can be a deadly disorder. As I mentioned, 20% of the sudden deaths in young people are thought to be due to, myocarditis. That it wasn't picked up by anybody. It was just a flu doc kind of thing, and really wasn't. So be aware of this disproportionate tachycardia and the potential for failure. Because remember, the heart does only two things: it pumps and beats. And if the beat is fast, resting tachycardia always gives me the heebie-jeebies, especially if there's no fever.
Yeah, that's such a good point. And remember that kids with myocarditis, they die from an arrhythmia usually. So, if you don't send that patient to the ED from the urgent care, admit that patient for cardiac monitoring, they can go home, have an arrhythmia, and they're going to die. They may die. So
one of my friends was a ER doc, and he died from arrhythmia while out jogging. He had a known history of myocarditis. He thought he was over with it, but I don't think you're ever kind of over with it in terms of your susceptibility to dropping dead. And he dropped dead while jogging because when you have this, you after a period of time, you kind of progressively kind of try to get back to your baseline level of activity. And he was a jock, and he did all of this stuff, and he was extraordinarily well known in the community, and like there were 1,000 people at his funeral, but he died. He was probably 50.
Yeah. You will get pushback from your staff when you tell them that you want to get an EKG on a good-looking 9-year-old. Okay? But if I have a 9-year-old telling me they have chest pain in the setting of a viral URI, yeah, I'm going to get an EKG, and I'm getting a chest x-ray too, by the way, and I want to see what that shows us, and then, yeah, maybe that kind of drives our what do we do next. Let's do those things first, potentially. In, again, otherwise healthy, under 25-year-old, start with EKG and chest x-ray, and let's see what happens after that, maybe, okay? And if it's, I like that too, extraordinary tachycardia relative to age, to fever, maybe you do jump on a troponin early in those patients. I don't know, person dependent.
I want to see an EKG first because, but yeah, and obviously there's going to get a chest X-ray thrown in there too because you're looking for maybe other kinds of things that may be causing this, but that's at the top of the list, even though it's an uncommon disorder. We're in the bad disease business, so we're the worst first kind of people. So which actually gets us in trouble because our colleagues in fact, tend to be critical of us for over-ordering, overdoing it. But I think that we see more subarachnoid hemorrhages than they do, and we see more MIs than they do, and we see more nasty stuff than they do. So it's kind of like our point of view is a little bit different than like primary care.
So two things that, yes, exactly.
Okay.
Well played.
So two things I'd say with this. A, paper is cheap. Like it really is one of those, I think we're all in agreement up here that EKG is just something that it's very easy to do. And yes, you might sometimes get some pushback from staff, but it's a quick, easy thing to explain. There are weird things that happen with kids and adults that are young, and we're just double checking that. It's a very easy, quick thing to do. The other thing that I'd say with it is the disproportionate tachycardia, as we've alluded to, like especially with kids, disproportionate tachycardia can be easy to overlook because the fact that, they have a fever or, they just don't look well. And that disproportionate tachycardia is really important because with kids, that's the way that they compensate when they're down. Like adults, we have more squeeze or we have faster beating, and that's what we can do. With kids, it's pretty much always going to be that relatively consistent, squeeze unless they've got other underlying issues going on. But that heart rate is going to be the big thing that changes, and that disproportionate heart rate can be something that, especially with once you're starting to get into prepubescent, like older kind of kids there, it's very easy to overlook because you're so used to looking at like little kids with tachycardia, or that the teenagers and young adults are going to have more obvious tachycardia that you can pick out.
Jesse, what is a way, is there a certain thing we can do to distinguish between posterior STEMI versus maybe an early end STEMI with ST depression, not fully getting into ST elevations in the anterior leads?
It's an interesting question. I think it's really semantics, because if I see ST depression in the anteroseptal distribution, then my mind immediately goes to posterior STEMI, and I think that's probably, a safe, maybe your mind should go there too, like if you're seeing ST depressions in those leads, you should be considering posterior STEMI first. Really what it comes down to, if you have ST depression there and you have a positive troponin, if you have, I'm calling that a posterior STEMI. I think that's a posterior STEMI. I don't know if you can say it's an anteroseptal end STEMI with ST depression, right? Because an end STEMI means you have a positive troponin.
You have chest pain and you have rising troponins.
Yeah.
That meets criteria for a MI.
That meets criteria for an MI, and then if you have ST depression in the anteroseptal leads, you have a posterior MI. So am I missing something? I think that's a posterior MI. I would call cardiology.
Something you can do that's kind of unconventional is you can apply posterior leads. So instead of the right-sided leads we think about when we're doing, you've got inferior looking MI, let me do right-sided leads. You can also do posterior leads to the back of the left scapula, to the back of the chest wall. And those ACC criteria on this new pathway that came out 2022, it takes very little elevation for them to meet criteria, okay? It's like less than or equal to 0.5 millimeters of elevation in your, they call it V7, 8, 9. So that little elevation, not even one small box, that is their confirmatory criteria for posterior STEMI.
You remember that the mortality rate for end STEMIs is higher than the mortality rate for STEMIs?
Just we don't catch them? Is that why, do you think? They're
No,
missed?
because there's this whole new idea about nomes and omes.
Oh, yeah. We talked about this
just talked
actually
about
earlier.
this,
Yeah.
Is that?
We talked about it earlier.
Occlusion.
And it's kind of like, with that idea, the threshold for saying somebody may have to come into the hospital and get a rapid angiography is, you're allowed a lot more leeway now because it's not just ST elevation anymore.
We talked about that. Remember, OMI is occlusion MI and NOMI is non-occlusion MI, as opposed to the STEMI and STEMI, which you kind of talked about.
All right, Jesse, you jogged your own memory here in terms of the other EKG finding. So that's in terms of, you mentioned, you put it on the Slido, you went the bifurcated block.
Yes.
So that was something you were trying to remember and you got it, that's
yes.
good. Okay. In terms of speaking on MI stuff, right, you kind of had this thing that at least previously, at least a few months ago, the AHA only recognized one of these STEMI equivalents as a true STEMI equivalent, and you made a joke as far as, well, who recognizes the other STEMI equivalents discussed on that slide? You mentioned it was who?
Yeah, so it's the ER profession, really.
Right.
Yeah, so I think, you correct me if I'm wrong, but it's my understanding that we're the ones who came up with the idea of STEMI equivalents.
Yeah, this some ER doctor is basically a troublemaker, and this is his concept, which is now being seeded up. But this is kind of like the bottom, coming from the bottom up. We're telling the cardiologist about something that we think we ought to get them quicker to doing angiogram rather than the normal like 8 or 10 day delay that these people have.
But that's a really important point, is that you can sometimes know more than the cardiologist that you're talking to on the other end of the phone about these EKG findings, like Wellens phenomenon. I've talked to cardiologists that had no idea what Wellens phenomenon is, or that, I have these hyperacute T waves, or other things that, again, traditional older cardiologists and even some of the newer ones are just not as familiar with this because that's not what they're dealing with day to day. And so it can be a great educational moment, and I've done this with a lot of the docs in our emergency department, as well as the other PAs and NPs that we have, is letting them know that these different types of OMI or NOMI type findings and what matters and how you look for that, like who needs PCI right now, who needs to be observed, and so on. Knowing those EKG findings are really a significant thing that, again, someone who you may be talking to may not be familiar with it, and there's plenty of times where I've pulled up just my personal preference here, because it's so easy to show examples with them, is Life in the Fast Lane. They have a great EKG library. And so I was like, well, maybe this, and then we take a look at it together. Next thing you know, they're like, well, I guess it matches that. And you can push hard enough to actually get people to recognize that this is something concerning, and this isn't someone who just gets to go home.
Yeah, and Wellens in particular, you don't even have to have active chest pain.
Yeah,
You might just have the EKG changes.
And don't rely on a troponin there either, because the troponin can be negative.
These are tricky things. Like you've heard us kind of mention over and over again some of these new AHA, ACC guidelines or pathways. And why do we bring this up? Because you might have to have this uncomfortable discussion with a cardiologist at the other end of the phone. Do you say, hey, this person's got Wellens syndrome here, and they got to go to the cath lab, and they go, Wellens what?
Say what?
Yeah, it's like, how do you spell that? Is that 2 L's? What is that, Wellens? So you might have to go and say, hey, look, this is what I'm looking at. These are the criteria, these are the guidelines, and this is why I want you to take them to the cath lab. And so it's easier now to maybe start building your pocket brain of, hey, when I see this funny thing, I already have something on my phone that I've bookmarked, so I can go to those criteria. I mean, there's time to do a lot of things. There's time to look up a lot of things here. But there are certain things that are very time sensitive, and I would say recognition of STEMI and semicolons, very time sensitive, and something you want to have at your beck and call very immediately.
It may be one of the reasons why you should be handed the EKG of normal people who have normal EKGs, because is the programming of that EKG machine current with the the 8 findings that have been associated with these OMIs, which are not ST elevation MIs, and so you can make a case for, you got to hand them to the clinician within the 10-minute AHA thing, everybody. Other people would say that that's really not a good idea, you'll be interrupting people, et cetera, et cetera. But with this new perception that a normal EKG, you don't know the troponin yet kind of thing, you just need to be more alert to these kinds of things.
Yeah, it's estimated that 40% of occlusion MIs, the OMIs, do not meet STEMI criteria.
There you go.
Yeah.
I like that.
Yeah, so that's a lot.
Well, it's gone almost like well, why wouldn't we do every person who has an elevated troponin, who has comes in with chest pain? Why would we try to fractionate these people out and say, well, you need an immediate one, but you can have a delayed one? It's kind of like, if a member of my family was in there with chest pain and elevated troponin, it was like, geez, why wouldn't we call them, Yeah. I just don't want to play the statistic and say, well, most of these people don't have anything wrong on their angiogram, They're leaking troponin in a situation where it's not myocarditis, it's not some other reason why they may have an elevated troponin. They're there for this funky chest pain. Why not? But I'm sure there's going to be a good argument why not. I think there probably is, but
Yeah.
It seems like from a empiric point of view.
It's like, no procedure is benign.
Right.
Right? So if
Well,
you take
that's
someone to
true.
the cath lab,
That's true.
well, hey, good news, they don't have a STEMI. Bad news, I tore a hole in the coronary artery, or now there's a
Their kidneys
aneurysm
are
or whatever
bugged.
else.
Yeah,
So,
there's
yeah.
contrast, and their kidneys, might suffer, and they've been exposed to the procedure, which isn't benign. Yeah, so there are definitely side
Well,
effects.
what about a CT coronary angiogram? We don't necessarily need to go to what is the value in those cases?
Yeah, so that's a new thing, and did we talk about that in any talk, the coronary CT angiogram? Have we talked about
I
that
just
anymore?
mentioned
Yeah.
that if you're we talked a little bit about low risk and
Yeah.
intermediate risk with the new 2021 JACC guidelines and updates, that if you're intermediate risk, they, imaging such as the CCTA or a stress test, they say either or, depending on your age, is something that you may benefit from. And yeah. No, go for it.
This is a relatively new imaging modality, and not everyone's shop may have this. But if you hear about, hey, we just got in this new coronary CT angiogram, that's what it's for. It's a medium risk chest pain. If they're negative on that and somebody reading it is competent, then that patient can go home without patient follow-up potentially.
Just note, last thing on that before we move on to a totally different subject, is that just keep in mind though, the evidence here is controversial. Like there's conflicting studies as far as is CCTA actually beneficial.
Something I'd like to ask about in terms of the cannabinoid hyperemesis, I'll kind of casually float it like, boy, I see you've been here a lot for this nausea and vomiting. Hey, you ever tried taking a hot shower, hot bath? How does that feel for you? Oh man, that's awesome. Oh, that helps a lot. So that's one more thing that, again, you can't totally hang your hat fully on that. It's one more history finding you can go, oh, this could be related to the cannabis here. Okay. The next one here, as far as nausea and vomiting, I hate and I love to keep on referencing Ken Milne's SGEM blog. He did an episode about inhalation of isopropyl alcohol. You pull any drawer in your ER back far enough, you'll find an alcohol pad in that drawer, okay? Pull it out, rip it open, and have the patient just take some big sniffs on it. And you'd be surprised, like, we talk about, like, what's the risk of, doing a cath on a patient's heart. I can't think of any risk just sniffing on an alcohol pad. That's a super low risk. Be surprised how good people have, cessation of their nausea, and while you wait for their medications to kick in. Okay. I had a patient who had a small bowel obstruction, and nothing I could do to get their vomiting and nausea to come down. I gave him an alcohol pad because what's the harm? And he's like, wow, what is this? This is amazing. I don't know.
They're going to say, where did you go to school? You're given, no, that's not proper. So you have to kind of dress it up a little bit.
Sell it.
You got to sell it a little bit,
yeah.
I'm not a wacko, this is.
So as a quick anecdote and slight overshare here, I had like horrible gastroenteritis. I'm like ending my shift and I'm thinking like, I just got to make it home before I throw up. And I grabbed a whole thing of alcohol wipes thinking there's no way this is going to work. And I made it a whole hour. I just kept sniffing alcohol pad after alcohol pad.
One in each nostril kind of thing?
I just had one hand. I just kept sniffing along. But it works and it's a great bridge. And I'll use it with patients. They start saying that they feel nauseated. I just rip it open and just say, hey, take a sniff of this. And then most of the time it works, and it at least buys you time to give them some kind of, actual antiemetic. But
what happened after that hour?
I vomited a liter.
It didn't work anymore.
No, it didn't work anymore. I got into the house and it just all went to hell. But I made it home.
That carpet was never the same after that, unfortunately. Okay. So imaging in terms of pancreatitis. So CT you're going to want to use for non-specific abdominal pain where you haven't quite ruled out other things beyond pancreatitis. And CT you're going to want to consider several days into the pancreatitis attack. But the things generally you find with uncomplicated acute pancreatitis that you find on CT are not there in hour 1 or hour 6 or hour 12. So I really suggest, I put that link to the JAMA review in my slide for a reason, because it's really brilliant. Like, they really do a good job, and one of the things they do is they have a nice little time course as far as when you do each test, when you should be getting this test or that test, when should you consider this here. That really honestly changed my practice. Now me think about, like, when do I have to get these scans? So that was very helpful to me.
Yeah, this is a case where you've already made the diagnosis because the lipase is sky high or something like that?
Yeah, exactly. When it's like, again, when you're clear that it is pancreatitis and nothing else, then those complications occur, a day or 2 or 3 into the course. If you're still not sure, then go ahead and do the CT because we're still in diagnostic mode. If you've already said this is for sure pancreatitis, we can wait on the CT scan. They can be admitted and hospitals can handle that.
Which can sometimes be an uphill fight. Like, be prepared for that because they'll want you to do the CT even though they're only a couple hours into their illness, and usually that's what I explain is like they have clearly an elevated cause, and we don't have biliary obstruction or something else going on with it. Like, this is something that's not going to be very diagnostic right now, and most of the time I can get away with that.
Have they had this before?
I think we're assuming in a patient who's probably had it before.
That you had it before, or it's just clear that it's pancreatitis. Jesse, I think you had the back pain lecture, right?
Yes.
So let's talk about some back pain stuff, some
Yeah.
gait issues? Are there special gait testing you might do and things like that?
Yeah, this is a good question. Basically, what do you do if the person has an abnormal walk just because of the pain? And that does happen. You know, when I'm standing the patient up, there's just so much to be gained from every aspect of literally getting them up and getting them standing and getting them to walk. I see, first of all, if they can stand and if they can even take steps. Because if they truly have like weakness, true weakness, then I'm going to be able to see that. You know, if they really can't walk, they can't sit up, they can't lift their legs, they can't walk because of weakness, then I'll notice that. And that is an objective finding, right? It's not just the person saying, I feel weak. I'm actually seeing that they truly are. I've examined their legs. I want to see if they're unsteady. Are they unsteady on their feet? And that may even point me in another direction. Maybe this is a neurologic, you know, maybe this is in the brain. If they're unsteady on their feet, maybe maybe it's not just back pain, maybe they've had a stroke. What else is going on if they're really unsteady? I have them take a few steps. I do, if they can handle it, I do like to see if they can heel and toe walk, right? Because then we're evaluating L5S1. Not everyone can do that, but I just think that it's nothing special. I have them take a few steps out, turn around, take a few steps back, assessing really their strength, whether or not they're steady on their feet. If I feel like they have good strength, but they're super unsteady, again, that person probably can't go home, right? Because they're not safe. So all of that gives me a lot of information. And I think you can usually kind of see like, oh, the person, oh, are you uncomfortable? You appear uncomfortable. Is that why you're sort of favoring one side? Is it because you have pain here? What about you guys?
What service admits back pain at your hospital?
Yeah, so it really depends. If there's a neurosurgical problem, just pain,
Yeah.
try really hard not to admit just plain back pain. But if I absolutely have to, it's medicine and they hate it and I hate it too. Yeah.
That's a great segue into the next question. I really want to go rapid fire here and just get a straight yes or no from each of the panelists here. Back pain patient, no red flags, no neuro changes. They're not weak, they just can't walk because of the pain. Is it safe to discharge home with analgesics? Let me get a yes or no.
No.
Sorry, Dr. Mikata.
No.
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 No. If you usually can walk and you can't walk, you know, unless your ankle's broken or your leg's broken, then you stay in the hospital till we can figure out why you can't walk.
Yeah, if you can't walk out under your own power, then you probably ought to stay. Now, with the exception of, sometimes we give a wheelchair to people for just to help them. They got an ankle or the back hurts, but they could walk out, but you're just kind of being nice, help them out kind of thing. But if they can't walk out on their own, they're not walking, they're not leaving. We'll find somebody to admit them.
Yeah, and like maybe they just need an extra day or whatever, okay, of pain medication.
Yeah. There are people who have just, really bad back pain.
Mm-hmm.
It's just like, and the idea of selling these to people, somebody upstairs needs to have really bad back pain one time, and they'll help. But
right. Maybe they need an MRI that we can't do in the ER. Maybe they need something we just can't do in the ER.
They're easy cases. I mean, once you've excluded kind of serious things with the CT, MRI, or whatever, it's like, it's analgesia. And some of the hospitals have doctors who do analgesia, like pain doctors and all these other people kind of thing, to help you out.
If you're really lucky, you can get a physical therapy consult while they're there. If you can like have an OBS unit with physical therapy, which is something we're just starting.
Yeah, the physical therapist would like to see these people as soon as possible.
The hard part is that we want to respect your time, and this is the last Q&A panel, unfortunately, for the boot camp. Tomorrow we're going to have some talks, then we can let you guys go after Martha wraps it up with some housekeeping stuff.
No, we could continue, and you're
going?
welcome to stay, and you're welcome to go.
Do we keep going?
I mean, you can go.
We keep going. Yes. We're going to keep going. Okay, here we go. All right, let's keep going. Let's get.
As I say, at least
we won't call you out
really
if you
important.
leave.
The next one, okay.
You over there? No, we won't do that. This time is.
If you gotta go, you gotta go. Okay.
We're on your own time.
Let's do 10 more minutes. Let's see where we get.
All right,
okay?
let's go.
All right, here we go. Oral steroids. Let's just take.
No.
Oh, which one?
Nitro and inferior
Oh, that is
because
the next one
that's
now.
nice and fun.
This
and
is a great one. Okay,
And
very
I
good.
did answer that on the chat.
Yeah, so
you
just in
answer
case people aren't looking at the chat,
Oh,
this is a
okay.
critical one here, okay?
Yeah.
So we were taught back in the day, right, like What is the phrase? Mona greets every MI patient at the door, meaning every person that has an MRI, you're giving them nitro, okay? I think there's big downsides to that. You want to talk about that a little bit, Jesse?
Oh yeah,
What was
definitely.
your slide?
The
It was your
big
deck,
thing,
right?
it was my talk.
Yeah.
But I want to hear your thoughts too. The big thing you worry about, like the classic teaching, right, is that an inferior MI, 2-3 AVF is usually the RCA. And so if you're involving the right side of the heart and you give someone nitroglycerin, you can decrease preload. If you have an MI that's now taking out the right side of the heart, remember that's going to be preload dependent. So if you're taking away preload in a preload dependent situation, then you can really end up with hypotension and a lot of badness. These patients, a lot of times they need fluids. So that is sort of the classic teaching and the concern with giving nitro to an inferior MI where the right side of the heart is thought to be involved. Now, that doesn't mean you can never give it. It just means you need to be aware of the complications that can occur. And you can get right-sided bleeds as well. But I'd love to hear your thoughts. Did you have something else? Oh, I'm sorry. I thought you were going to say something else about it. Maybe not.
So I think two thoughts.
Yeah.
One is that if you are good with ultrasound and you're good with echo, this is something that can really help you to figure out, is it really RCA, which you're looking at wall motion abnormality there. And that's an advanced skill, so that's not something that the average person working in the ED is going to know, but it's definitely a worthwhile skill to see, is there a wall motion abnormality that's consistent with that? Because if so, then yeah, I probably should avoid it more versus there's another wall motion abnormality that's more consistent with this, and then, hey, I've got a different cause. But this is a fun one because it's been more and more controversial with time about whether or not you need to do it. My other thought with this is, do you really need to give nitro, or could you give something else for, like, what's your goal with the nitro? Is it for pain control? Because if so, we've got other options here, not necessarily morphine. I think there's
Right, exactly.
Right.
That's
Going
where I
back
was
to
gonna go.
Mona, yeah,
Yes, exactly.
yeah. So
that is usually the problem because the patients I see with inferior MI, they're uncomfortable, they're high risk for coding, and having unstable arrhythmia, and you're trying to figure out what to do for them, and you don't want to give them morphine, and nitro, they could become hypotensive. It's tricky.
Can you mention why about morphine? Yeah. Sorry.
Oh yeah, so that was in my talk.
Oh, you did? I'm sorry.
Yeah, no, that's okay. No.
I'm going to express my ignorance. Why wouldn't you give them morphine?
So
because of hypotension?
Yes.
Well, and there's a lot of studies. So the long and the short of is that we probably shouldn't give it because there seems to be a problem with long-term outcomes, negative long-term outcomes, and it also decreases the antiplatelets. It decreases GI uptake of the antiplatelets, and so the antiplatelets are less effective.
That sounds a lot of theoretical thing. Now, if Ken Milne was here, he said he was going to say, "Show me the clinical
study.
outcomes."
What's the level of strength of evidence on that one?
Actually,
Hey, Ken.
guys, pull up my slide. Don't I have like four studies on
say, you
there?
probably have
I
multiple
quote
citations
4
on it.
studies on that slide.
Outcome.
But fentanyl
So,
is...
well, I'll say this, the research is very good for the antiplatelet, but the research is not as good for the mortality. And so that is weaker evidence. And so it's not a slam dunk. It's not this is terrible, you're definitely going to have bad outcomes from this, but it's like suggestive in a weaker study, but the antiplatelet is a higher quality of evidence. And overall, if you have to choose, it's better to avoid morphine if you can, but if you have to give it and the patient has refractory pain, you can give morphine or fentanyl. So how's that for like a really terrible answer?
That's a really good answer, I think.
Were you a radiologist at one time giving hedging answers?
I know. That's what it sounds like.
Okay.
The following question is kind of 2 questions here. So, PO steroids for asthma exacerbation for peds with viral URI or flu. Yeah, I think that's pretty straightforward. Yeah, if they have known asthma, you'd give them steroids, and maybe they wouldn't take them right away. You could also say like, hey, if you start getting some shortness of breath, wheezy, go and start the steroids then. But yeah, I think I don't know about standard of care as the right answer, but that's how you treat asthma exacerbations, is give oral steroids, I feel like.
Yeah, well, it's initiated by the parents at the first sign of a cold in kids who have routinely basically wheezed when they got a cold. And it probably would be viewed as a really pretty egregious sin in the past, but from a pragmatic point of view, 1 dose of steroids is not going to hurt anybody.
And
until
there's
they
some
get
suggestion
aseptic
that you
necrosis.
could give dexamethasone. Give dexamethasone and then wait 2 or 3 days, and the patient or the parent fills dexamethasone 2 or 3 days later and takes that instead of taking 5 days of prednisone.
Oh yeah, yeah.
Although there's good evidence for a lot of these for single-dose dexamethasone,
that-
probably
even
works
that-
just as
That's
well
right.
as the two.
Yeah, that's what we're talking, one dose.
So the other question in that question is PO steroids for acute allergic reaction, okay, significant urticaria, okay. I am really getting away from Benadryl, and I'm kind of getting away from PO steroids for my first-line treatment for garden variety urticaria, okay. I'm liking giving like double dose of non-sedating antihistamines, so like take Claritin morning and evening, and you can also take famotidine, so that's a H2RI, and you can do topical hydrocortisone, and you can also, Sarna is a menthol lotion you can buy. It's menthol, I think camphor, and you can apply that. That really helps for the itching and burning. And I say all that because it's what my dermatologist told me when I got an infection a few months ago, and I had vicious urticaria. Like, I had like Mickey Mouse hands. Like, I'm still wearing the rubber wedding ring because I couldn't wear my regular platinum wedding ring that I had, okay? And so I was miserable. I couldn't sleep because I was itching so badly. And so that was kind of the regimen I was put on here, is not necessarily hydroxyzine or Benadryl. No, they said take Claritin twice a day, take famotidine. They said take steroids if it's not working. But yeah, so there's ways to do urticaria without Benadryl and without steroids, at least the first set of treatments.
I think it's the American Academy of Dermatology or American College of Dermatology, something to that effect, that does specifically recommend using cetirizine as first line, and specifically mentions not using diphenhydramine, and that steroids are usually not needed for urticaria. Given one thing, if you are going to go down the pathway of do you do topical versus oral, a big part of that, is this like a truly localized where we can get away with that, or is it something that's more generalized, in which case if you're going to go steroid, it's probably going to be truly easier to do the oral steroid. But cetirizine is good, and then with adults you can do up to 20 milligrams twice daily, so 40 milligrams daily, and that's again in those same recommendations from dermatology.
Take a look at...
Although we're not supposed to use trade names here, but as far as I know, the only trade name for cetirizine, is Zyrtec.
Yep.
Yes.
Yeah.
So that would be what, Benadryl's over the counter and Zyrtec's over the counter as well. There's a big, I don't know if you've seen the ads for IV cetirizine in the setting of non-anaphylactic hives, just itching. And if you see anything like that, I would advise you not to do that, because oral cetirizine, maximum effect is within an hour. IV cetirizine, which is the only place it's going to be used is in the ER kind of thing, is $300, which is absolutely absurd. So stick with, you can transfer over from Benadryl. There's some reasons to use this other generation of antihistamines, but I see no indication for IV antihistamines.
And you can just tell the parents too, it's like, or the parents or the patients themselves, hey, you know how Benadryl diphenhydramine can make you feel either really sedated, or sometimes you get the opposite in a kid and you turn them to 11. And now they have that paradoxical reaction where they're running around and climbing the walls, okay? And parents don't want either one of those things, okay? So like, it's a relatively easy sell to say we have a safe and effective other way to do this other than diphenhydramine. Check the links there. We went deep dive on this in one of our 2-view episodes as far as, current urticaria suggestions from American, European guidelines, how safe it is to double and maybe even triple the non-sedating antihistamines. Good case studies out there about that. So consider it. How about, I want to skip the next one just because it depends, okay? It depends as far as the URI. Is it COVID? Is it flu? Is it rhinovirus? I think it's going to depend, and you guys can read more about that as far as guidelines there. How about a nebulizer? Some folks swear by the nebulizer versus just getting the meter dose inhaler. Are there any hard and fast rules for y'all to go with the nebulizer if someone doesn't have it already at home?
Nebulizer with a spacer.
What's that?
You're talking about a nebulizer with a spacer, yes.
Well, I'm talking about the whole machine. The machine with the nebulizer, mask, and whatever else.
MDI with a spacer.
MDI with spacer, right.
Misspoke.
So So I talked about this in the chat because I'm glad people asked about like the spacer and stuff like that, because I meant to include that, but I was trying to keep things moving here. So when I would normally prescribe a nebulizer versus trying to prescribe an inhaler with a spacer is if logistically they say there's no way I'm going to be able to afford an inhaler, and I can give them a nebulizer from the emergency department that I know that they can go home with, and the albuterol vials are super cheap, but an inhaler is not. And then the other thing is when feasibly, for whatever reason, they can't take they're not good at taking the inhaler, but they could do well with the nebulizer. And that's sometimes a personal preference thing, like Mike alluded to, as far as, someone says that's what works for me. Probably it goes back to they probably don't know how to use their inhaler correctly, or some physiologic reason why they can't do it. Maybe they can't take the appropriate breaths, but with the nebulizer, it kind of helps force things down a little bit. But those are the main times that I'm prescribing a nebulizer versus just going ahead with the inhaler. And then whenever I can, I'll actually prescribe both to have options, because there are some cool, they're not as good as like the home like box nebulizer machines, but they do make pocket nebulizers, which are really neat. And for people who really do have a hard time for whatever reason using an inhaler, those pocket nebulizers are really effective.
I think if you have an adult or even a child who is using an MDI without a spacer, you really ought to check their technique, because technique is everything. There's not a lot of drug going within each inhalation, so they need to use a nebulizer like they're smoking marijuana, basically, with the breath holding, so that it basically can disseminate. You try to do all of the things to make it as effective as possible, and poor technique is really very common in people who use MDIs.
In terms of chest x-ray, and I welcome corrections if I'm wrong here, I think there are certain patterns of chest x-ray that go along with viral and certain that go along with bacterial, that ultimately nothing is perfect here.
Yeah, I showed some viral and I showed some bacterial. If you have a lobar kind of thing and lobar, that's not likely going to be viral at all.
Right, that's probably a bacterial. Yeah, exactly. Yep, very good.
Ultrasound, see, I'm going to keep mentioning ultrasound here. There's some evidence that initially kind of showed as a little more convincing with the earlier studies, like many things where we study more and more over time, it's maybe a little less convincing, that we can use ultrasound to help differentiate viral versus bacterial as well. And there are some unique findings that we can look at there as far as that goes. But there, as far as like helping differentiate viral versus bacterial, most of that went back from H1N1, but there have been some follow-up studies that show maybe it's like the chest x-ray. It's not perfect, but it can sometimes help indicate that this seems to be more likely related to a viral pneumonia versus a bacterial pneumonia.
Well, I'd ask you, how many of you with any routineness order this test, that BioFire test? It looks at like 29 viral things, including flu. And there's a big push, I think, to use this kind of routinely and to differentiate what is causing this pulmonary infection. I think it costs $100, which is in ER probably not the end of the world. But anybody using that at all? Isn't that, what do you think? What do you think about? What's your experience with it?
You use it.
Carrie, so you use it?
Everybody's pointing to the next person down. Do you like it? You don't like it?
2,000?
Oh, you mean the hospital charges a lot for it?
So he's saying an outpatient ordering of this respiratory panel that susses out different viruses, $2,000 as an outpatient test.
Oh, that sounds pretty reasonable. All right, so forget that. You've been using it?
So people use it. Our cost is like $900
No.
That's a steal.
So it's like immunocompromised. We're trying to figure out like if it's bacterial, viral, something like that. That kind of helps.
Immunocompromised, it's only $900. You should send your patients over to her place and you'll save $1,000. there are a number of tests in the pipeline. Well, actually, there's two that are FDA already approved, but they've not really gotten any broad utilization, which are basically bacterial versus viral. And with the one of them, it looks like 25 or 29 messenger RNAs, uses artificial intelligence and basically tells you whether viral or bacterial, and what is your 30-day mortality as well.
Yikes.
I'm not sure that I want to know my 30-day mortality, but it's on a computer screen, and it is about, so the idea that we can do a test, because the response to a viral infection is different than the response to a bacterial infection on the mRNA level, and putting this all together. So there are things coming down the pipeline which have good sensitivity and specificity. The issue will be what they cost.
It's bad when you pull out the mortality estimate and it goes 5, 4, 3. No, I'm kidding. All right, for the benefit of posterity, the audience was saying that it costs a lot for this viral panel, from $1,000 to $2,000, and the hospitalist did not like it being ordered for that reason. But it was suggested to be ordered maybe in our immunocompromised, where you're really trying to figure out what exactly is going on here. Last question to Jesse. You had mentioned in your slides trigger point tenderness. Can you describe trigger points?
Thank you for asking that question. It is interesting. So a trigger point is different from a tender point. They are both muscle pain. And so the long story short is that it's not dangerous, and it's not something that's a red flag for back, something terrible going on in the back, but it is one reason that a person may present with back pain. And the way that a person, you may have heard of trigger point injections. That's something you can do to actually help with someone who has trigger point pain or muscle point pain. When you press on the muscle, the requirements to sort of be eligible for a trigger point injection is that you feel there should be a muscle twitch, and the pain needs to radiate. So it can't just be one area. If you're pressing on one area and they're like, yeah, that's where the pain is, that's a tender point. And that's where you can inject some like lidocaine or anesthetic. A trigger point, when you press and they have a muscle twitch and they have radiation of pain, what you actually do there are trigger point injections where it doesn't really matter. You're not using, it doesn't matter if you use lidocaine, it doesn't matter if you use saline, it's not what you're injecting, it's actually more that you're sort of a lot of people do a dry needling technique where you use truly a dry needle and you just kind of go in and out of the area and you're sort of breaking up the fibers, and that's thought to help decrease the inflammation. There's a lot of it's very complicated. It's very similar to acupuncture. It is, and it's something you can actually do in the ER or the urgent care. It's something that you can offer patients for pain control. Yeah, and Sean Nort talks a lot about it, actually, if you're familiar with him. And so thank you for asking that question.
I'll admit, I actually do use this sometimes, and very select patients like you're describing. Like it really does matter who you use it on. And obviously that they're not like with red flags or something else with it. But it's pretty effective when you're picking the right patients. And I personally never dry needle it. I do still use lidocaine. That's just more for pain relief there, because if I'm going to actually poke around there multiple times, it hurts a lot less.
Yeah, when you're going
numb it up a little bit first.
Fair,
so you're basically saying you could inject or needle both of these trigger points and
tender
points.
Yeah, you can. So part of the idea, again, to keep this very simple, is that you're intentionally irritating the muscle fiber there, so that way it will contract and then relax. I think is the easiest way to try and summarize what we're working on here. So you want to tick it off, you want it to get irritated, and then it's like a reset. It's supposed to let the muscle relax. And with patients where this works on, and again, it's all about kind of knowing the technique and having some good practice with it, it makes a world of difference. I've had lots of people walk out absolutely pain-free afterwards because of it. Yeah. But it is one of those things that I'm not doing it for everyone who comes in with back pain.
John Kennedy used to have a lot of back pain, and he used to get needled with frequency.
Oh.
It is the same concept, essentially, as acupuncture.
Acupuncture. Okay. Well, listen, I think we're done. I appreciate your staying. Is there any more left there? Did I miss one?
Keep on asking Slido questions, but understand there's no further Q&A, so we'll try to get to it on the Slido. Don't be afraid and come and talk to us as well. We're here for y'all. That's the only reason we're here in Las Vegas, for you guys. Okay, so come and chat with us.
I have answers to your questions, Eric. Okay.
Okay. All right. Thanks, everybody. Have a
Thanks.
good night.
Oh, you're too kind. You're too kind.